कुर्सी कहाँ गई यहाँ की? कोई नहीं, सुनो कोई बात।
Good morning to all of you. May I request everyone to be seated? बस यार हो गया, बहुत हो गया. Namaskar. Good morning to all of you. We'll start the proceedings of the academic day of foundation. I must say that we have been struggling with the attendance to listen to the people who can listen to outstanding work which has been conducted in the country. We received more than 200 applications, out of which 17 have been selected for awards and oration total combined. We have been struggling with it, honestly speaking. All the good work which has been done by our scientists should be disseminated to as many people as many possible. So what we have done is that we have tried to put on these proceedings on the YouTube. We have given link to all our 1,000 fellows, 3,000 members, 110 fellows, and about 8,000 MNA-MS members. And we expect them to join this particular event. Another issue which has been there is that all these awards and oration should be presented in the annual professional conference of their respective organizations. Like if there's an award in the field of pediatrics, you should go to Indian Academy of Pediatrics. And we can have a MOU, we can have what you call some mechanism. We may sponsor that session in Indian Academy of Pediatrics so that more and more people can be available to listen to the good work which has been done by the eminent scientists of the country. We have been struggling with this, to be very honest. Coming back to the today's function, what we have is we start from 10 to 1, we have the award session and oration session. We have the second part, we have award session. And we would like that all the speakers may kindly stick to the timings so that we have, what we have done is we have oration session, award session, and then we have, after 2, we have standing committee meetings of council, and 3 to 4:30 we have our council meeting, and 5 o'clock we would have our Foundation Day lecture, which would be delivered by Shri Rajnath Singh Ji. After 6 o'clock, we have eminent poet, Mr. Sharma, Mr. Surendra Sharma. He would be entertaining us with some nice poems, jokes about husband and wife relationship. So please do join us for the lunch, and please stay for the evening cultural program which we have thought would be some entertainment for all of you. And with these few words, we have, may I request Dr. Behra Saab to kindly come and inaugurate the session for the morning. And after that, we'll have Dr. Ashok Kumar Das, a very eminent endocrinologist, and Professor Piyush Gupta to chair the scientific sessions. Dr. Piyush Gupta and Dr. Das, please join us. Thank you very much.
A very good morning to all of you, and welcome to this 63rd Foundation Day function of NAMS. As Dr. Kapil has already told you, we have a very busy schedule ahead throughout the day and till late in the evening. I think the most important part for today's function is the orations and awards. And I congratulate all the orators and all the awardees on behalf of the NAMS. So, ladies and gentlemen, you have actually achieved and you are being selected through a very tough competition. We have a lot of, applications, a lot of other people who are there, they have competed, but you have come out. So, I congratulate you all. And without wasting much time, I think we'll have the main function in the evening. So now I request the chairperson to start the oration because the schedule is quite tight. So thank you again. I welcome you all again.
Thank you, sir. Thank you, Dr. Kapil, and welcome all on this very auspicious day. We have now before you the jewels of the NAMS presenting these orations, and we have 11 of them today. So I'll just request before starting, we'll not waste any time. We'll start just now, and just to please stick to the time, to all the orators. 20 minutes are allotted for each presentation, but that 20 minutes also include the introduction of the orator, the introduction of the award, and the summing up in 1 minute. So precisely, you will have around 17 to 18 minutes. We'll ring a bell approximately 3 to 4 minutes before you have to stop, and then there will be a bell finally when you have to wind up in next 15 to 30 seconds. So I'll request, please stick to the time, because we cannot go beyond this, because in this session it is jam-packed. We don't even have scope for lunch or even tea break. But for the chairpersons, but for the orators, definitely they can go out and have their, and the audience can have. So I'll request Professor Ashok Das to proceed with the first oration and invite the speaker.
Very good morning. Sincere regards, love and greetings. We'll start with Dr. R.V. Rajam academic oration. Dear friends, may I first invite the orator, Dr. Rajendra Prasad, to kindly come to the podium, please. Dr. R.V. Rajam oration was instituted in 1977 on the occasion of the 80th birth celebration of Dr. R.V. Rajam. The oration is awarded every year to an eminent medical or public health scientist to deliberate on his or her published research work on a subject which is related to the needs of the country, including, amongst others, related to community health, communicable disease, nephrology, and STD, sexually transmitted diseases, with special reference to their pathophysiology, clinical or laboratory diagnosis, medical and surgical management, and the prevention of such diseases. And this year, the award goes to Professor Dr. Rajendra Prasad. Dear friends, give a round of applause. Professor Rajendra Prasad doesn't need an introduction. He is the Emeritus Professor, National Academy of Medical Science. He is the Director of Medical Education and Professor of Pulmonary Medicine at the Eras Lucknow Medical College. He is former Director of the BP Chest Institute, Delhi, and former Head Department of Pulmonary Medicine at the King George Medical University, Lucknow. And he has been teaching, caring for the patients and doing research for over 45 years. He has worked on 30 research projects, supervised 165 MD dissertations, and published over 315 papers and authored 11 books, in 4 books on tuberculosis. He is a BC Roy National Awardee. Dear friends, the topic for his oration is a very important, very contemporary and challenging: management practices of tuberculosis in India. The current scenario. Over to Professor, and Sir, all is yours.
Thank you, Chairpersons. Thank you, National Academy of Medical Sciences, for bestowing on me this very prestigious oration. That is R.V. Rajam academic oration. What I'm going to do, what topic I decided, it was very difficult for me to what to speak, but then I decided, since whole of my life practically we spend on tuberculosis, although we have become now pulmonologists, but then I thought that what are the practices when about the tuberculosis in our country. And my agenda for next, I think 16-17 minutes, I hope, will be to review management practices of tuberculosis in private as well as in public sector in India. And then finally, last 2 minutes, I think, what is way forward to achieve NTB strategy goals based on these studies by 2025 in India. In the interest of time, I may be skipping some of the slides. You know, when I talk about tuberculosis, to me, in last roughly about 50 years, tuberculosis is a very curable disease. One of the case I focused in front of you has a cavity. He was treated well and got well, and he is still well, believe me. So it's a treatable and curable disease provided adequate treatment is prescribed and taken. But it is very unfortunate. Last year about 0.5 million people died with tuberculosis in our own country. When I say this, then question comes in my mind, why this is happening. To examine this, if anybody gets tuberculosis in this country, what he does, he first goes to the private sector, maybe 2, 3, 4 private practitioners, and then ultimately may land into the public sector. So half of people are going. So private sector is one of the very important sector where TB patient goes. Let me examine in next 2-3 minutes what is being done in the private sector, how TB is being tackled. I'll start this very first study. Mr. Upelkar, who is in WHO now, he did first study to know what is the treatment practices of private practitioner in city like Mumbai. Mumbai, I believe, is a very advanced city, very evidence-based practice. But you know what he said in his paper? I met him sometimes and I discussed with him that 100 doctors prescribed more than 80 regimen. That was city of Mumbai. I was very impressed with this study. So we conducted similar type of study while I was in KGMC, and we studied only 450 doctors' prescription habit. And what we could find that even prescription habits of private sector is not good. This was year 2002, and what is main issue was 75% of the doctors made one or another prescription error. Mr. Upelkar again after 10 years repeated the study to see that whether any change has occurred in city of Mumbai as far as TB. What he was trying to say that no change has occurred. I have a lot of discussion with him many times. And then one student who did study in Lucknow, what is how the people are knowing. But good point, this was 2010 again, about 2/3 of physicians correctly state. So things were changing, what I'm trying to say. And then in 16, somebody conducted a study in city of Chennai, and in city of Chennai, 160 prescribed 27. So instead of 100, in my study it was 33, now in Chennai studies 20, still lot of regimens are being prescribed which is unnecessary. And 78% prescribed regimen consistent with the Indian standard of TB care. That is a good point. So change is occurring, what I am saying. And one of this is what is happening in informal. Patients of tuberculosis go to the informal health system also, and they say that they usually use antibiotic for a prolonged time. They refer, but the referral is very delayed. So even informal sectors has also been. Somebody has done the systemic analysis of these all studies done, and he published. One point I can say that the suboptimal quality of TB care, that paper was published, and still some of the paper is saying, echoing the similar things. So how MDR TB, drug-resistant TB, is a common, but how it is practiced, not well known in the private sector I'm talking. We did one study when we find that a lot of second-line drugs are being misused or used, I must say. And the common drugs which are misused is fluoroquinolone, kanamycin, ethionamide. So you can see that the drug will be misused. Now you listen a lot about XDR TB, pre-XDR TB and MDR TB. These are the reasons why this has happened. And then private allopathic medic approach to management of multi-drug. So what I'm trying to say in all these studies, I can summarize in one say that management practices in a private sector is not very is far from satisfactory. Now, when patients go to the public sector, let me in next 4 or 5 minutes quickly review what has happened in public sector for last so many years. TB is the one which has changed changes in at least last 5-6 years. So what government did, national program of TB control was started way back in 1962 in India with very minimal drugs. And when this program ran for about 30 years, it was evaluated, and one line, if I say, it has not worked. It has not made any dent as far as tuberculosis control is concerned. So government was compelled to revise that national TB control program. Now revised at that time in 97-98, revised national TB control program where good diagnosis, effective treatment, and directly observed treatment and accountability, means record keeping. Those were the component, and with the aim that RNTCP should be able to reduce the prevalence and mortality by half in 2015. That was the aim when RNTCP was started. And then we have, you must have heard that we have in RNTCP 5 category of drug, 1, 2, 3, 4, 5. 4, 5 is for MDR and XDR, and 1, 2, 3 was for new cases and retreatment. That was the regimen in RNTCP. Even chemoprophylaxis was preventive treatment was in RNTCP, but it was only confined to children less than 5 years. RNTCP, from 97 till 2019, in these years, has done tremendous thing. As you see that 91 million presumptive TB patients were examined, 19 million TB patients have been treated, 3.5 million lives have been saved, and even more than 1 lakh at that time drug-resistant TB was treated. That was the RNTCP. But only problem RNTCP, not every patient is going to the government program. And what was the objective? Millennium Development Goal was to reduce it by 50%. I am happy to inform that that although the Millennium Development Goal was achieved in 2015. Then comes sustainable SDG came. And SDG came, we have now end TB targets. NTB, people say elimination. Elimination is practically very long, dream, but to go to the elimination, we have to first end TB. And what is the targets of NTB strategy? This is by, they say that from the level of 2015, there should be reduction of 80% in the incidence of the disease, tuberculosis, and there should be reduction of 90% in mortality of tuberculosis, and there should be no catastrophe should incur on the patient management. With this sustainable development goal, Delhi, this was the Delhi NTB summit, which was addressed by our beloved Prime Minister Modi ji, and what he declared in 2018 in that summit, that India will achieve NTB strategy 5 years earlier than the WHO Sustainable Development Goal. I think Dr. Bera and Dr. Arora is seen here. Probably we all attended that meeting where Prime Minister addressed. And so with that notion, the program name has been changed. Now we say as tuberculosis elimination. It is not revised national TB, now it has been changed to TB. And TB elimination program, we have made national strategic plan in which there are 4 components: detect, treat, prevent, and build. Unless these all 4 components are taken care of, it is very difficult to meet the NTB strategy. And in detect, large number of labs, large number of tests have been introduced in these 4, 5, 6 years. We have now microscopy lab tune of 23,000, rapid molecular tests to the tune of 5,000 throughout the country. Culture lab, we have around 100, mobile TB. So a lot of things with that notion had changed in this program. We have revised the diagnostic algorithm for drug-sensitive TB, and we have revised diagnostic algorithm for drug-resistant TB. I'll not go into details. And there are a lot of measures have been taken. Initially, we depended upon the passive case finding. Now the active case finding has been introduced, means you have to go into the community and find out what are the cases of TB, because without that, the NTB strategy targets were not possible. And we have now, if I say currently we have treatment for drugs, we have very simple treatment. One for drug-susceptible TB, and then one for INH-resistant TB, and then two for MDR TB, shorter and longer oral regimen, and even newer regimen, BPAL, which was introduced about 2 years back, has been introduced on a pilot run in India. So what I'm trying to say, whatever treatment is available throughout the world is available in this program free of cost. Last in 2020, because we know that COVID had made some dent, but last year more than 24 lakh people have been notified. That was about 87% of the existing load. So that was good news, that though there was a lot of setback with the COVID, but now we have equipped. Lot of MDR TB. I have heard last year report says that around 63,000 MDR TB were diagnosed. But it is very unfortunate, we have MDR TB load of about 119,000. So what I'm trying to say, now all the patients are going to the government, still some of the patients, and their outcome has been improved. For drug-sensitive TB, it has improved from 79% to 83%. And for MDR TB, with newer drugs like bedaquiline and delaminid, it was originally less than 50%. But now it has gone to the about 63-64%. And a lot of TB HIV comorbidities are taken care of, TB diabetes, because these are two very important risk factors. And we have Niksha Poshan Yojana. Time will not allow me to go into details. Another issue, you know that if you want to achieve the end TB strategy, when I was a student, I taught TB preventive therapy for many years, 40 years in KGMC, I must say. But now it has become very essential. So what government said, they have intensified the TB preventive treatment. And they have decided there are indications to call it. This is the first program where medical college task force was made. Dr. Behra is sitting here, and we have been all part of a national task force, and medical college is contributing to about 10 to 15% of TB management. You know, the government is very proactive. You see, Pradhan Mantri TB Mukt Bharat Abhiyan, they have started on 9 September 22. It was started by our by our President and Health Minister, and where more than 2.5 lakh people witnessed the live proceeding across the country. What I'm trying to say, in the government, a lot of changes has happened, a lot of improvement has happened, but only problem is not all the patients of tuberculosis. I wish if every patient goes to the government and get diagnosed and get treated, naturally it was very easy to end TB. So my last 2-3 minutes, what I think I have a time. So what is a way forward? Working in this field for last, I must say, about 50 years. What is way forward to achieve TB strategy? You know, this graph is very important. When we say that the current decline is around 2 to 3%. But if you want to achieve NTB strategy by 2024, we have to accelerate this decline, maybe to 10 to 15%. And to accelerate this, we have to introduce new drugs, which has been done. We have to introduce new vaccine. We have to introduce the preventive therapy. So all these will probably, which will be there, will lead meeting the NTB target. So my idea is accelerate the decline of incidence and mortality rate of tuberculosis, early diagnosis and effective treatment of all the cases of drug-sensitive and drug-resistant tuberculosis, strengthen diagnostic capability more, early introduction of newer shorter regimen. You know, TB treatment has changed this year, 2020. And now we have got a very shorter regimen. The country is planning to introduce those shorter regimens, say 6 months for MDB. strengthen education. Education is also, to my understanding, education in tuberculosis is very poor. That is why you see that there no, I believe no doctor wanted to write a wrong treatment. Why a doctor should write a wrong treatment? But because of the lack of education, this is happening. So I will request from this forum that probably NMC has to take action. We have to improve the education as far as the tuberculosis is concerned. Scale up and effective implementation of the preventive treatment, that is also very important issue. Then of course, research is another component, especially to go for quick BCG vaccination. We have, we have seen COVID within 1 or 1.5 years, we have developed vaccine, but we are struggling in tuberculosis to develop a new BCG vaccine. So that is the idea. Strengthen private sector. Private sector is one of the very important component. So although government has strengthened, but we need more. Improve linkages with general health system, reduce stigma, and a lot of stigma is still. I'm sorry to inform, yesterday I saw a patient of lung cancer. He was asking from me, sir, मुझे TB तो नहीं हो गई है. That was very unfortunate. हमने उससे कहा भाई TB हो जाती तो यार तू बिल्कुल 100% सही हो जाता. अब क्या बताएं तुम्हें, तो ऐसी डिजीज है जिसका कोई. So what I am saying is stigma, poor knowledge, poor education, those things has to be needed. In case community, without community involvement, nothing is going to happen. And then strengthen Jan Andolan for TB Mukt Bharat. I think with this some idea, I pay my tribute and my regards to my mentors, my PG students, from whom we have taught him and we have learned him from them, and my parents and family, and last not my patients, who has taught us like anything. With these few words, I would like to end my oration with this quotation. We are slowly becoming old, and especially the younger people sitting here will become old. So I'll talk with one quotation. Anyone who keeps learning stays young. So please keep learning. That is my request. With these few words, thank you very much. And once again, I am obliged to National Academy of Medical Sciences for awarding me this award.
Thank you, sir. Thank you very much for a very fabulous, very simple, lucid, and message for everybody in the audience. Sir, you started with the private sector's inadequacy, heterogeneity of the treatment, and unsatisfactory treatment, and took us to the entire government program of NTCP, RNTCP, and now NTP, National Tuberculosis Elimination Program, and pointed out every step what should be done. Be faulted. Thank you very much. Very fabulous, and a lot of information for your life work in about 20 minutes. Thank you, sir, very much. We keep our appreciation on record. Over to Professor Piyush Gupta. Piyush Gupta is the proverbial Dean and Principal of the UCMS, the eminent pediatrician. Over to Piyush.
Sir, request you to please come over, sir. Dr. Rajendra, sir.
Yes.
So we'll start with the second oration. This is Dr. Niranjan Khandelwal academic oration, which has been instituted in the year 2019 by Dr. Niranjan Khandelwal, professor and former Department of Radio Diagnosis, PGI MER, Chandigarh, and a fellow of the NAMS. The oration has to be delivered by an expert who has made outstanding and original published research work contribution in the field of interventional radiology. And we have none other than Dr. Amar Mukund. Welcome, Dr. Amar, and congratulations for bagging this very prestigious oration. Dr. Amar is a professor and head of the interventional radiology at ILBS, New Delhi. He is a course director of PDCC on interventional radiology, associate editor for IJRI and JCIR, have more than 100 publications in index journals, authored book on basics of interventional radiology. He has several chapters in various books, and there is a long list of awards which he has, so I'm not going to read them out. And recently he has been nominated for Sir J.C. Bose Oration 2024. So Dr. Amar, over to you. I'll just say the topic of his presentation today is the influence of shunt occlusion on liver volume and functions in hyperammonemic cirrhosis patients having large portosystemic shunts, a randomized control trial. Over to you. Your time starts now, Doctor.
Thank you, Chairperson, sir, and good morning, all. So, first of all, I would like to thank National Academy of Medical Sciences for bestowing this very prestigious award. And I was given allotted a time of 10 minutes through email, so probably my topic and presentation would be a bit smaller than 20 minutes. Anyway, so moving to the research. So this is a research which I'll be presenting because as when I went through the application, so it was this time there was a change in the application. You to present your research publication which has already been published for the oration. So anyway, moving to my particular topic, and this is shunt occlusion. So we are talking about cirrhosis, and in cirrhosis we know there are various portosystemic shunts, and we will be talking like what we do for the shunts, what happens due to shunts, and what exactly is shunt occlusion, how we do the shunt occlusion. So there are two procedures, namely BRTO and PARTO. So BRTO and PARTO are two procedures through which we inside a shunt and try to occlude it. And I'll try to briefly explain what the procedure looks like. So if this is the schematic diagram which I have made, and if you see this is, if you suppose this is IVC, this is the right renal vein, this is the left renal vein. And if you see in the light blue color, this is the portal vein supplying the liver. So ideally, blood from spleen, blood from superior mesenteric vein and short gastric vein, left gastric vein, everywhere, it should come in a direction towards the portal vein. So blood from the splenic vein, from the SMV, from the left gastric vein should go to the portal vein into the liver. So this is how the normal physiology is. But as we know, patient develops cirrhosis, there is intrahepatic portal resistance, and as the portal resistance increases due to any cause, it may be vascular, it may be parenchymal, or sometimes it may be extrahepatic portal venous obstruction, which may also lead to reversal of the flow. So as there is a reversal of the flow, because these are surrounded by major organ, like splenic vein is through a major organ, SMV is through intestine, small intestine and large intestine. So finally, these blood has to come in a direction towards the bottom vein. But this being one of the small veins, because the pressure is least in this, so the blood starts going towards the left gastric vein, or there are other small veins like short and posterior gastric vein. And where do they go? So once there is reversal of the flow, these varices form, these lead to formation of varices which may be esophageal, or if you see this pink color, this is the stomach which has been depicted over here. So there are large varices which form along the stomach. But why these varices form? Basically, this is a channel through which finally the blood comes to the systemic circulation. So the portal blood has to come to the systemic circulation. Normally, it comes after being filtered from the liver, but if there is portal hypertension, reversal of the flow, it will come through a small collateral pathway. And in between, there is a stomach, and finally, it reaches through the left renal veins. This is what happens. Now, I'm talking about BRTO and PARTO. So RTO is retrograde transvenous obliteration. What is retrograde transvenous obliteration? So we go into the IVC, we may come from jugular route, we may come from femoral route, we get into the renal vein, and then we cannulate the shunt. We reach over here, we inflate a balloon, or we place a plug, a vascular plug. It is just a plug like a plumber uses to occlude water outflow. So it is placed over here, and once the outflow has been occluded, then the blood over here is stagnated. And once a stagnant blood is formed, we start injecting sclerosing agent. So the sclerosing agent gradually builds up into the shunt and into the gastric varices, and that leads to thrombosis and obliteration of the gastric varices. So where do we do this procedure? It is mostly done for elimination or obturation of the gastric fundal varices, but it is also being performed for portal systemic encephalopathy, hepatic encephalopathy, and we reported it earlier in 2012 that occlusion of these shunts help in treatment of hepatic encephalopathy. So coming to my research, so this is the background for that research, that patients having cirrhosis and large spontaneous portosystemic shunts may present with recurrent hepatic encephalopathy or gastric variceal bleeding that we know through the anatomy which I illustrated. These shunts also deprive the liver of portal blood, rich in nutrients and regenerative factors. So if you go back, so normally all these blood coming from bowel, and nowadays there is a lot of research on a small bowel. We all know that a lot of regenerative potential and other important nutrients are formed in the small bowel, which has to go to the liver for, proper nutrition of the liver as well. So liver is deprived of this blood because it is being shunted out. Shunt occlusion using BRT or PARTO of these shunts redirects the portal blood towards the liver. Because we are obliterating these shunts, the blood has to go towards the liver. So the aim of this study was to evaluate the long-term of PARTO on change in liver volume and functional status of the liver. So this is what we did. And this is the methodology where we included 40 patients of cirrhosis having spontaneous portosystemic shunts, that is SPSS, with recurrent hepatic encephalopathy. They were randomized using block randomization to a group, that is the experimental group where patients underwent a shunt occlusion, and other group was a standard medical treatment, that is the control group, which is the standard of care as of now. Shunt occlusion is not as per the guidelines. Yes, majority of the places we are doing it. It is still in guideline for obliteration of gastric viruses, but for hepatic encephalopathy, still we need to do more work. And both this group were evaluated for any change in liver volume. So this was the primary outcome. We also assessed the patients for a clinical outcome, MELD sodium scores, plasma ammonia level, and T-score in DEXA for bone density of these patients. So this is the technique. I have already gone through the technique. I'll show what different we did. Initially, we were using balloon, but here we used a vascular plug, which made the procedure more robust, and there were less complications. So plug was placed, and above it sclerosing agent was placed, which used to obliterate these shunts. And some of the patients had paraumbilical vein, which was also one of the shunts. So in this, direct puncture of vein and thereafter placement of plug and sclerosant mixture was performed for patients having paraumbilical vein. And these are some of the examples. Images, if you see over here, this is the liver, this is the spleen, and if you see, this is the renal vein. And right from the stomach and spleen, this is a splenorenal shunt. You can see here is the stomach. From here and spleen, there is a intercommunicating channel coming up to the renal vein. And in this second image, if you see, this is a large device. If you see, this is a sheath through which we deliver this plug over here. And just above the plug, if you see this black area, so this is the sclerosing agent which is injected, and because there is stasis of the blood, this remains over here and causes thrombosis of the shunt. And if you see, this is the post-procedure CT scan which is done on the next day, took for how this actually there is a complete obliteration achieved or not achieved. So we see that a complete obliteration of the shunt has been achieved. Some of the examples, how gastric varices are. These are big gastric varices protruding into the lumen. This is liver, this is spleen, this is stomach, and all the varices. And if you see, this is the aorta, and this is the size of the varices, almost 3 times the size of the varices. And if it bleeds, how torrential it would be, it's very easy to imagine by looking at this image. And this is the coronal image. We can see renal vein, and this is how we go inside. This is how we do procedure. This is a sheath. We may come from jugular, and in another case I showed like we come from femoral root. This is after placing the balloon, we wait for 4 to 6 hours, and then we remove the balloon. Here there is no balloon, no sheath, and we see this cast is formed of thrombus. This is how it looks on the CT next day. And the next procedure, that is part O, where we changed balloon for plug. This is one of the examples for that. We can see these are the gastric varices. This is the shunt, the renal vein through the renal vein. And this is how we go inside. This is the IVC renal vein. We go inside and then we start injecting sclerosing agent. So this is the plug. If you see, this is the plug. Above it, it is being injected. This is the picture what we get later on. The whole of the shunt as well as the varices is obturated. It is totally gone. Here everything has been removed. This is the picture what we get on CT scan on the follow-up imaging. So moving to our study. So we assessed 51 patients for the eligibility. 11 were excluded and finally were randomized. 20 to the experimental group and 20 to the control group. 2 patients in the experimental group were lost to follow-up, whereas 4 in the standard medical care. And mostly it happens because most of these patients develop some of the other complications, and that is one of the reasons for dropout. So these are the results. Male is to female ratio was 4:1. And the most common etiology was NASH, you can see here, followed by alcohol. So in our population group, the hepatitis B and C was a smaller group as compared to alcohol and NASH. And if we talk about type of shunt, then splenorenal shunt was in majority of the patient, 15 of the patient, whereas only 8 patient had gastrorenal shunt and other shunts were in lesser number. Part O was technically successful in all patients, so the procedure can be performed easily. It is not a very difficult procedure. All patients showed resolution of symptoms and clinical improvement within 7 days. And post-Part O shunt closure, there was a significant increase in liver volume, which was seen in 18 of 20 patients, reduction in MELD sodium score, and reduction in plasma ammonia level. That was seen in 16 of 18 patients. And what was most interesting, there was 8.8% increase in mean total liver volume. So those patients who got shunt occlusion, there was 92 cc increase in liver volume. So pre-procedure liver volume was 140 cc, which increased to 1132 cc. So this is very important. But here I would also like to emphasize all cirrhotic patients with shunts are not actually candidates for shunt occlusion. Only patients with preserved liver function, that is child A and early child B, are the patients. Late child B and late child C may not actually give such kind of result. In fact, they may have a deleterious effect of shunt occlusion. And another interesting thing what we found was there was a significant decrease in liver volume in standard medical treatment group or the control group. So if shunt was persistent, there was a decrease in liver volume, and it was again in the tune of 8.6%, and it amounts to 84 cc. That is, if the volume was 988 cc, this is the mean volume, it came down to 904. So there was a significant reduction in the liver volume, those who were on standard medical care. Yes, there were some complications. What we saw, one patient developed ascites, but which was managed with diuretics and albumin. 4 patients were found to have esophageal varices at 3 to 6 months follow-up and required endoscopy and EVL. However, there were none had any episode of GI bleed or thrombosis. So there were varices, but no bleed. This is the bar diagram, which shows the results in a very lucid way. Liver volume, there was significant in shunt occlusion, whereas there was decrease in liver volume in the standard medical treatment group. Albumin, there was significant increase. Ammonia, there was a significant decrease. DEXA, we didn't find any significant improvement. MELD sodium, again, the liver function, synthetic function improved. The MELD sodium decreased, whereas in the standard medical treatment group, the MELD sodium increased. So we concluded that large spontaneous portosystemic shunt in cirrhotic patients diverts flow away from the liver and can lead to a progressive reduction in liver volume. Closure of such shunts by Part O, besides reducing the incidence of hepatic encephalopathy and plasma ammonia levels, achieves about 10% increase in hepatic volume and synthetic functions. And we were able to publish this paper in Hepatology International, which was published last year in 2022. And the conclusion of that paper, when we published, it was occlusion of large SPSS results in improving the volume and synthetic functions of the liver by restoring hepatopetal portal flow, besides reducing serum ammonia level and recurrent hepatic encephalopathy. Thank you so much for your patient hearing.
Thanks, Dr. Amar. Thanks for a wonderful insight by this randomized control trial into your intervention, mainly by the plug-assisted retrograde transvenous obliteration, that is part O. And you were very clearly, you have demonstrated the utility of the technique over the standard medical treatment. In fact, there was an increase in liver size by 8.8% in the intervention group, and there was a decrease in by 8.6% in the other group. So overall, there must have been a 15 to 20% difference at, isn't it?
Yes,
so
sir.
that is even more than that 8.8% that you had shown. So thank you very much. That was a real eye-opener for all of us, and with minimal complication, a very new technique being done in this part of the world. Thank you. Thank you so much. Please stay with us for your oration certificate. Sir, please.
Dear friends, will be changing gear and passing to another very important oration. May I request Dr. Govind to kindly come to the dais. Dear friends, this is about the late General Amir Chand oration, which was instituted by Trik Tirath Vidyabhati Chutani Charitable Trust, Chandigarh, to perpetuate the memory of late General Amir Chand. This oration is delivered by the awardee on the published work by him or her, especially related to non-communicable diseases and its etiology, pathogenesis, or the lab diagnosis, and the prevalence of such diseases. And dear friends, we present to you for this oration, Dr. Govind Makharia, who is well known to all of you. He is working on this problem for a very long time and had made seminal contribution. He is the professor of gastroenterology and human nutrition at the AIMS, New Delhi, and his work has been cited by 12,500 citations. He has about 321 publications and about 43 chapters in the books about which is also very important work, and the H index of his published work is about 55. Dear friends, he has worked incessantly in the field of celiac disease and given very important findings for our nation. Today he is going to speak to us on a very important aspect: celiac diseases in India, an emerging public health problem. Celiac disease in India, an emerging public health problem. Govind, all is yours.
Thank you so very much, and very good morning, everyone. Before we go to this oration, I'd like to bring certain points about Dr. General Amir Chand. He had been a physician, a teacher, a leader, a founder, and philanthropist. Pre-independence, he was the first physician to chair the Department of Medicine at King Edward Hospital, joined India-Pakistan in Lahore. Post-independence, he was one person who laid foundation of modern medicine in our country, which is still emerging at that point of time. And post-independence, he was the president of API and also of IAMA. He was one of the founders of our own society, that is the Indian Society of Gastroenterology. And once he retired finally, he donated all his savings to three great institutions in our country, that is ICMR, AIMS, and AFMC. So it's an honor to me to celebrate, or all of us to celebrate his life and his contribution to our country. And I'm proud that I have been bestowed to deliver this oration by the National Academy of Medical Sciences. My gratitude to Dr. Sareen, Dr. Kapil, the governing body of NAMS, and also selection committee of NAMS, to bestow this award or oration to me. I feel really proud. So coming to celiac disease, and why I chose this topic for this prestigious oration. Celiac disease is emerging in our country, not in our country, but globally, and every physician must know about celiac disease. And this is likely to be a model which will let us learn more about pathophysiology of many other autoimmune disorders. So coming to what is celiac disease? Celiac disease is a disease which occurs with two important factors. One is the genetic susceptibility, and second one is ingestion of gluten, which is a protein in wheat, what we eat every day. And humans cannot digest the gluten protein, therefore there are many peptides, and these peptides are presented to T cells, and they get activated, and leads to multiple activation of adaptive and innate immune response that leads to creation of gliadin-reactive T cells, which infiltrate different organs in our body and leads to multiple organ damage. It can affect almost every system of our body, although we believe that celiac affects only small intestine, but that's not true. It affects almost every system of our body. So this is the scheme of my oration, that one inspiring story, and we go along. First, that before we knew what is celiac disease, how to treat it. So in 30s and 40s, the treatment of such patient was to give them dietary therapy, like more fruits and vegetables, or oyster diet, or carbohydrate restriction, and banana diet. All these patients were given bananas in 30s and 40s. There comes a very smart individual, very committed, Dr. Willem Karel Dikke. He was a Dutch pediatrician, and one day in his outpatient, one of the patient's mother told him that my child is good if I don't give him bread. And from this narration, he experimented for the next 10 years in his hospital, just 5 children. He used to admit these patients, give them no wheat, look at their weight and diarrhea, give diet and look at the weight and diarrhea. And over 10 years, when just 5 patients, he convinced himself and others that indeed weight is the reason for celiac disease. And this is a story of an astute listener from a patient, and that led to a discovery of, I would say, is a great discovery of mankind. So in 50s and 90s, celiac disease was very uncommon world over because making diagnosis was very difficult. In 80s or 90s, a change occurred that we developed a technology which can diagnose celiac disease just by simple blood test. And that led to occurrence of modern epidemiology of celiac disease. Before, say, 90s, celiac was thought to be a disease of Western Europe, Italy, Finland, and Scandinavian countries, but now it's a global disease. And then we look, so how do we look at the epidemiology of celiac disease? I just want to take your attention to 2 important points. So once you suspect celiac disease or want to do a study in community, you do a blood test. It's called anti-TTG antibody. If blood test is positive, we call it seroprevalence. So in a community of 100 people, how many are seropositive? That's seroprevalence. And those patients who have antibody positive, you do the biopsy. And if the biopsy shows advanced enteropathy, then you call them celiac disease. Therefore, we look at epidemiology of celiac disease in 2 terms, seroprevalence and biopsy confirmed celiac disease. And I'll refer to these terms in my subsequent talk. Coming to modern epidemiology, I said before 70, no celiac disease, very few celiac disease, but this is a seminal paper done by one of our very dear friend, Carlo Cattassi in Italy. Look at 17,000 children and confirmed that 1 in 184 have celiac disease. From none to 1 in 184. Subsequently, in the United States, 1 in 133. Before that, celiac was not known in the United States. So therefore, we looked at the global prevalence of celiac disease, and for that, we did a systematic review of global population, and what we found that globally, 1.4% people are seropositive for celiac disease. It means 1 in 70 people are seropositive celiac disease. And if you look at the biopsy-confirmed celiac disease, is 0.7. 0.7% of global population have a biopsy-confirmed celiac disease. And if you convert this 0.7 into real numbers, we will find that in our world, there are about 40 to 60 million people have celiac disease. It occurs in every continent. And people believe that it's uncommon in Asia, but it's not true. Even in Asia, the seroprevalence is 1.8 and biopsy-confirmed celiac disease 0.6%. The prevalence is increasing over time. We showed in the systematic review that over 2 decades, so before 2000 and after 2000, there's an increase in prevalence from 0.6 to 0.8%. Further, not only the prevalence, but incidence also is rising. There are many countries where celiac disease is not known, their celiac become many operant. And its incidence is rising about 7.5% per year. So coming to our own country, it would be it is extremely uncommon in India. And if at all, it is seen only by pediatrician. And I was taught in my undergrad that celiac disease only children, and don't even think of celiac disease. But over time, things changed, and so the first question was, in our country, do we have celiac disease? And therefore, we looked at a population in northern part of India, that is in Haryana, and we looked at 10,000 individuals, and we showed that indeed 1% of North Indian have celiac disease. The two other studies, one from children from Ludhiana, Dr. Ajit Sood, who showed 1 in 300 children have celiac disease. Another study from PGI, Dr. Rakesh Kochar and his group, he showed in 1,600 blood samples from blood bank that 1 in 179 might have celiac disease. So all the studies are from North India, and people believe that this is a North Indian disease because they take a lot of wheat. It doesn't occur in southern part of India and northeastern part of India. So we had a doubt, is it really so, and why it is really so? Why my country, only one population will have celiac disease and other will not have celiac disease? And for that, ICMR considered a task force based on the data and looked at the pan-India prevalence of celiac disease in northern part, southern part, and northeastern part. And in that, we looked at about 2,300 subjects in population and confirmed that 0.67% of people have celiac disease. So coming to why, the question was, is there a difference in northern part of India, southern part of India, northeastern part of India? Indeed, there's a difference. Northern part of India is about 0.2%, as we saw in our previous study. In southern part of India is about 0.1%, much lower, much lower. And in northeastern part of India, 0.8, equal to northern part of India. But again, we don't see patients out there. So we looked at why so? Why there's a difference? We look at 2 factors which determine the occurrence of celiac disease. Number 1, the genetic susceptibility of a population, and especially HLA-DQ2 and DQ8 haplotype prevalence in population. And we found that all 3 populations have a similar HLA-DQ2, DQ in population. Means all 3 regions are susceptible to develop celiac disease. Then we looked at the other region, that amount of wheat intake, and we observed the amount of wheat intake in northern part of India is much higher compared to northeastern and southern part of India. Could that be a cause for change or difference in the prevalence of celiac disease in 3 population? And this was our finding. The question came, if so, then if southern Indians, South Indians, if they move to north part of India, many of them, they have moved from southern part to north part, reside in Delhi. So if you look at them, those South Indians who came to North India and develop a North Indian diet habit, certainly pizzas, burgers, parathas, and all those things, do they have more celiac disease? And now we're doing this study. Again, this is ICMR funded study. We're looking at this called migrant study. So those South Indians moved to North India, second generation, and those North Indians who moved to South India, second generation, we're looking at prevalence of celiac disease in them and risk factors in them. The study is still going, so we don't have data till now. Once we did the previous study, we also found one other paradox. Paradox was people believe that for celiac disease occurrence, you must have actually DQ2, DQ8 haplotype. Without that, you can't have celiac disease. Right? So what we have found that 30% of our patients who have celiac disease do not have actually DQ2, DQ8. And for that, we looked at, in our celiac population, about 400 celiac, 300 control, and genotyped his actually A1 and B1 gene, and we found that indeed 30% don't have DQ, DQ8, but they have other haplotypes. They have DQ4, DQ7, DQ8, and DQ9. The question is that why so? Why it is so? And if somebody has celiac disease, it means the antigen has been presented. How other haplotypes have presented this antigen? And to answer that, we are still planning this study by looking at a computer modeling of the structure of HLA and binding of peptides in this. Again, we don't have data on this, but this is a study still going on. And to strengthen the amount of work and coordination of celiac disease, we constituted a consortium which is funded by Department of Biotechnology, and also developed a biorepository of well phenotype patients with celiac disease, and we have almost now 600 celiac patients data, which from all over the country. Now coming to in Asia, people believe celiac disease in Asia, no. India is an exception, but it's not true. This is a systematic review we did, and we confirmed that almost about 1.2% of Asians have celiac disease. But again, the study only for a few population. And to further on, now we are doing a pan-Asia or multiple Asian country participation, looking at celiac disease prevalence in Asia. The study is still going on, but interestingly, we have found the first case of celiac disease in Indonesia and Thailand. And people believe celiac disease in those countries, no, doesn't happen at all. Once they screen the people, we found they have celiac disease too. So summarizing the celiac disease epidemiology or global burden, North India 1.4%, 1.04%, in overall 0.6%, more is northern part of India compared to, and globally about 0.67% have celiac disease. Overall, we have a 60 to 80 million patients with celiac disease globally, and in our own country, 6 to 8 million people, and most of them are still undiagnosed. 90% of them are still undiagnosed because awareness amongst us is very low. We still believe that we don't have celiac disease. So if there are so many people, where are they? Where are they? So that three things have happened over the last 30, 40 years, that people believe celiac disease not in adults. It's not true. Celiac disease occurs at every year of age, and we diagnose celiac disease at 70 years for the first time. People believe it affects only small intestine. It's not true. It can affect every organ of our body. People believe it has only sort of diarrhea. Think of celiac disease. No. People can have patients with infertility, liver disease, and many other manifestations can have celiac disease. So celiac manifestations are diverse and affects multiple organs, not only GI tract, but also anemia, short stature, type 1 diabetes, and many other manifestations. So if you look at, if you get a sense that in our country, 1 in 140, or globally 1 in 140 have celiac disease. Of 140 people in our society, 1 has celiac disease. If you look at those with chronic diarrhea, 1 in 10. Those with short stature, 1 in 10. Those with iron deficiency anemia, 1 in 31. Those with IBS, especially D variety, diarrhea variety, 1 in 33. Those with people with liver disease, Amar might be interested, that 1 in 4. And if you have type 1 diabetes, believe that 1 in 16 will have celiac disease. And if somebody has celiac disease, the chance of family members having celiac disease is much high. So who are the people to screen for celiac disease? Those who have malabsorption, chronic diarrhea, iron deficiency anemia, failure of rise, stunted growth, dermatitis herpetiformis, and many other conditions. So these patients should be screened for celiac disease. Now coming to other part that again is interesting, how to make a diagnosis. Before 90s, we didn't have blood test. And making diagnosis was extremely difficult, 3 biopsies. And people will not make this diagnosis, therefore very uncommon disease. The advent of a serological test, blood test, led to remarkable change in understanding and picking of patients with celiac disease. Now diagnosis is made by a positive serology, as simple as that. You suspect celiac disease, do a blood test, simple blood test, 1,000 rupees. And if positive, you do biopsy and confirm celiac disease. Now the data that even diagnosis can be made confidently if you don't need to do biopsy. If serology is very high, if the serology is very high titer, you can confirm this is celiac disease. And we also showed that if serology is tenfold higher, the chance of patient having enteropathy is almost 96% specific. Coming to last part of my talk is excitement in the treatment. And just give a glimpse, we all know that the treatment of celiac disease is lifelong gluten-free diet. And lifelong and complete means no wheat, no barley, no rye. And therefore, it's very difficult for patients to comply lifelong gluten-free diet because gluten is there everywhere in our society. And very difficult for these patients to stay away from gluten. Therefore, there's a need for development of alternative strategies. And with advancing science and understanding, new modalities are being explored. I'll just give you a glimpse of what's happening in the field of celiac disease. So we talk about wheat grains. As I said, that wheat grains, once we eat like a flour, the protein part of wheat, that's a gluten, is not digested by all of us. Because we don't have enzyme to digest every peptide of gluten. Therefore, they remain peptides in the intestine. These peptides pass through intestinal epithelial cells. Between 2 cells they pass. Once they pass between epithelial cells in the intestine, they get deamidated by an enzyme called transglutaminase, which is essential for every cell repair. Once this peptide is transdeamidated, it becomes a negative charge. So this is a foreign protein picked up by the internally presenting cells and which have a HLA haplotype. And this peptide binds with the HLA and that presents to T cells. The T cells get activated, which are gliding reactive T cells. That leads to reactivation of B cells, and subsequently these T cells infiltrate everywhere and damage tissue. And therefore, the disease occurs. So now, once we know this, the multiple targets which can be explored. Number one, the most important, that can we give an enzyme to these patients which can digest this gluten. So take a meal and take an enzyme, pop-up enzyme, and this can digest. And this is a drug called lactiglutinase is under trial. Want to inhibit the passage of this peptide through intercellular junctions. That's called the lanreotide, a new drug. This is you can inhibit TTG, which is a paper published in NAMS 2 years back, anti-TTG inhibitor. Then you can block HLAs, you can block cytokines and immune tolerance. So these are the strategies which are being explored. Many of these are in phase 3 clinical trial. And last part before, so we know that celiac disease is extremely common and unrecognized. Therefore, we need to put emphasis on medical education. People still teach. Our teachers still teach celiac disease doesn't occur in my country. Therefore, we need to put the courses in undergrad and postgraduate curriculum with the more CMEs, with a target to train every physician that celiac disease is one important disease you must look for. And also, we need to create infrastructure for celiac disease in our country. In summary, celiac disease is a global disease. In our own country, about 60 to 80 lakh people have celiac disease, and many of them are, or most of them are still not diagnosed. And we need to create infrastructure for care of these patients. And there's a huge opportunity for research and development in this area. With that, I'd like to thank all our collaborators, colleagues, friends, both national and internationals, my own department, my own family, and parents for making me able to do this work. Thank you for your attention. I'm sorry for delaying, taking some extra time for my talk. Thank you.
Thank you very much for describing your entire life work in 20 minutes. You know, the way you have dispelled the myth is great. You rightly said that it is a prototype of autoimmune disease. And in type 1 diabetes, we look upon celiac disease, as you said, 1 out of 16. I know it's a really prototype of the autoimmune disease. You also said that about the north-south divide, and also said that it is possible because of the diet. And you know, the way you developed the story is absolutely fabulous. About the discovery of the gluten by serendipity, to the finding the 3 diagnostic tests, and also proving to the world that celiac disease is not uncommon. 1.4 in North India and 0.7 in the South India, 0.6 or little less South India. Still the number is very great, and you know, it needs very simple effort to give a total life, a gluten-free diet and freedom from celiac disease. Govind, I wish you all the best, and it's our great pleasure and honor to present the certification. I have a message for the youngsters here. You know, as a physician or a surgeon or our specialty, we have always enamored by multiple things, but the victory belongs to him who organizes his research interest absolutely focused. This year Nobel Prize in Medicine went to someone who did an entire life work on the anthropological genetic research, and he got Nobel Prize this year. Govind, I wish you all the best.
Thank you so much. Thank you so much.
Great.
Thank you, sir.
I'm so proud of you. Thank you. Congratulations.
We now go on to the Dr. V.R. Khanolkar Academic Oration, which was instituted in 1987 to commemorate the memory of late Dr. V.R. Khanolkar, who was the first president of the Academy. The oration is to be delivered by an eminent biomedical scientist of published research work in translational research that includes gene therapy, biological therapies, genomics-driven cancer therapies, and regenerative medicine. And we have none other than Dr. K. Somasundaram, sir. Welcome, sir, and congratulations. He is a professor and chair of the Department of Microbiology, Cell Biology, Indian Institute of Science, Bangalore, and he has obtained his veterinary medicine degree from Madras Veterinary College, and then biotechnology, PhD in bacterial genetics from Madurai Kamaraj University, and subsequently postdoctoral training abroad in Northwestern University and University of Pennsylvania in cancer genetics, before moving finally to Indian Institute of Science. The primary focus of his lab is the genetics of glioma, the most common primary adult cancer. So welcome Dr. K. And he'll be speaking today and delivering this oration on genomics-driven cancer therapies. Over to you, sir.
Thank you, Chair, for the nice introduction. Friends, I am very happy to be here on this 63rd NAMS Foundation Day celebrations. And I also thank the jury, the committee, which identified me to give this Dr. V.R. Khanolkar Academic Oration Award. It's an honor for me to stand here to give a talk in his name. And I also pay my respects to the founder president, Dr. R.V. Khanolkar. Let me start my talk. So I'm going to talk to you about cancer stem cells. Okay. There has been considerable importance in the people who are working in cancer, trying to look at cancer stem cells. What are they? How do they look like? For 2 reasons why. We know now cancer stem cells, which occupy a small proportion in the entire tumor, very tiny proportion in terms of number of cells, and they are the only one which can initiate a tumor in an animal model, number 1. Number 2, they actually they are actually resistant to traditional therapy. These 2 reasons people are trying to purify, trying to study how they are different from the other bulk cells so that one can develop therapy which can specifically target cancer stem cells. Okay. My question is that enough? Will we be able to develop a therapy, a new method of treatment which can completely stop the cancer? That is a question we asked. We asked this question not because we want to be different. Okay, we want to look at everything possible. Okay, so now if you look at this slide, this is a section of a mouse brain carrying a artificially induced by injecting human glioma cells into the brain by stereotactic injection, and you can see nicely the tumor is growing. Okay, if you look at through the microscope, I have shown here a schematic of this tumor, what kind of cells are there. There is a core tumor in the middle, and the tumor cells are also infiltrated with various stromal cells, which you all know. There are many types of cells, immune cells, macrophages, blood vessels consisting of endothelial cells, pericytes, and also the normal cells of the parenchyma. In this case, if it's a glioma, astrocytes. Okay, but if you look at little more closely into the tumor core, one can see actually there are two types of cells in the tumor core. There are cancer stem cells, the red color cells, which are in minute proportion, and the remaining bulk of the cell, bulk of the tumor is called differentiated bulk cells. Okay, why do I call it a differentiated bulk cell? They come from the cancer stem cells. Cancer stem cells, in addition to their ability to initiate tumor, they also differentiate in large number to form so-called bulk cells, so that the entire mass of the tumor is formed. Okay, we asked a question, if cancer stem cells are so important for the tumor and they need to be targeted, what happens to the bulk cells? They are the one which forms the bulk of the tumor. Do we just simply ignore them? So we have data to show you the molecules which are secreted by bulk cells, the tumor bulk is also equally important if you want to really control the tumor. That's what I'm going to show you today. Okay, so now if you consider this is a mass of a tumor. Okay, this is a tumor mass, and you have these red color cells, which are very, very small proportion. They are the cancer stem cells. The green cells, which occupy the whole of the bulk of the tumor, are the differentiated bulk cells. That is otherwise called non-cancer stem cells. Now possible, there are techniques available based on the surface markers. If you have freshly resected tumor sample, you can make single cell suspension and sort them out. Stem cells and non-stem cells can be separated out, and they can be studied in terms of biology, how they are different, what kind of genes are expressed, how they are different from each other. All those things are possible. People are studying in variety of cancers, including glioma. Okay, so how is it possible? How is it possible if the cancer stem cells, which are in small proportion, is able to initiate tumor at the end? Most of the tumor is populated by the differentiated cell. How is it possible? How does it actually happen? It starts with the cancer stem cell, let's say single cell. In this case, what you see on the left top is probably the normal stem cell of the particular tissue. Let's say in this case, neuronal stem cell, which has a capacity to differentiate to form glial cells or neural cells. When these cells are exposed to carcinogen, there is mutations in the genome that results in the formation of so-called cancer stem cell. So this is a cancer stem cell of glioma. And then that divides into two becomes 4. As the division occurs through the self-renewal process, it also differentiates in large number to also form the bulk cells. This is how the tumor is formed. Okay. Now, what we do in the lab is we get freshly resected glioma tissues, particularly the grade 4 GBM samples, and make single cell suspension, and we grow them as a neurospheres, what you see on the left side. These neurospheres are enriched with the glial stem cells, glioma stem cells. And we can also put them into adherent plate on the right side, where the medium is combined with the fetal cough serum. They form a monolayer, and they are called differentiated glioma cells. Essentially, one can call cells in the neurosphere are the cancer stem cells. On the right side, which grow as a monolayer, one can consider as a differentiated bulk cell. Now we have a system, matched stem cells, and the differentiated cells derived from the stem cells, so one can compare on how they are different. What are the molecules which are expressed differentially, and can we study the impact of those markers which are molecules which are differentially expressed in stem cells versus non-cancer stem cells, and then in an animal model. Thereby one can actually find functions for stem cells as well as non-cancer stem cells. We use this term GSC, glioma stem like cells, that refers to the cancer stem cell. That is the cancer stem cell of glioma. And differentiated glioma cells are the bulk cells of glioma. GSC versus DGC, these are the two terms I will continuously use for you to make it clear. Please remember this word, GSC versus DGC. So what we did is, we took at the second we took the secretome of GSEs and DGCs, a bunch of them, matched ones, and subjected to mass spectrometry. We identified several proteins which are highly abundant in the secretome of GSE, the red color spots on the right side, green color spots which are actually highly abundant in the DGC secretome. So we got interested, even though we are looking at many of the red dots, why are they being expressed at high levels by GSE? We got interested on one green color dot. The protein is highly abundant in the secretome of DGC. Why we got interested in this particular protein? It's called fibromyalin. Earlier, a few years ago, we published a paper in the journal Oncogene. We showed this RNA for this gene is highly expressed in glioblastoma. It promotes the migration. It doesn't affect the proliferation. It only promotes the migration. Okay, so because of that, we got start interested looking at this protein. Here is a protein which promotes the migration of the glial cells, expressed very highly in glioblastoma. And why is it secreted by DGCs? These are non-cancer stem cells, which are, after all, not so important, right? Because the cancer stem cells alone can initiate a tumor. So we asked a question. We used a traditional approach where we established glioma cell lines. We took where this protein is expressed in very high amounts. We used RNA interference-based silencing and then asked a question, if the cell line is made silenced for fibromyalin, does it affect the tumor growth in an intracranial mouse model system? You can see on the right side, when the FMOD is silenced, the tumor growth is reduced dramatically. Okay, so that was surprising. That was surprising for us because what we know about FMOD is it promotes only glioma cell migration. It does not affect the proliferation of cells, number one. Number two, it is secreted by DGCs, that is non-cancer stem cells, which are not so important, right? So why if you silence the FMOD, it inhibits the growth of the tumor? So what we did was we cut in the literature, there has been a paper published a few years ago where they showed there is a cooperation between stem cells and non-cancer stem cells. Non-cancer stem cells also secrete certain factors which can work on the stem cells to work even better, to make the stem cells to make a bigger tumor. So we use this approach. The experiment, what they've done is, if you see on the left side, they're injecting a certain number of stem cells and you see a very small tumor here. But if the same number of stem cells were co-injected with the non-cancer stem cells together, now the same stem cells make much bigger tumor, right? You can see the same number of stem cells make a bigger tumor when they are co-injected with a certain number of non-cancer stem cells. Of course, non-cancer stem cells by themselves do not make a tumor, which is very known. We use this approach to exactly same experiment we repeated, wherein the non-cancer stem cell DGCs were taken, which are devoid of fibromyalin, and asked the question that DGCs which do not express fibromyalin, will they be able to cooperate with GSEs to make a bigger tumor? That's the question we asked. This is a way we have done the experiment. I will not go into details. Basically, one can see the FMOD silence condition where doxycycline is injected to induce silencing of FMOD. You can see the tumor growth comes down drastically as the time goes. And you can see here two parallel lines, the orange and the red color lines. Orange one where FMOD is not silenced, red is the one where FMOD is silenced. You can see the tumor, the DGCs are not able to cooperate with GSEs to make a bigger tumor, which means FMOD silenced DGCs, FMOD silenced non-CSEs are not able to support the growth of the tumor originally initiated by GSEs. What it means, the FMOD should have some unknown functions, because the only known function is to induce migration. It does not affect the proliferation. Just inducing function cannot be, it cannot justify the complete absence of the cooperation rendered by the DGCs to GSE initiated tumor. So we went on to do additional experiments to prove that fibromyalin secreted by the DGCs can actually induce angiogenesis and increase the blood flow to the tumor. Thereby, it appears it will increase the tumor growth, which is initiated originally by GSEs. In order to find the mechanism by which it acts on the endothelial cells, we carried out a proteomic technique wherein one can find out the different kinds of proteins which are regulated in the endothelial cells by fibromyalin. We went on to show basically there are two pathways which are activated: integrin dependent notch signaling pathway, which is responsible for inducing endothelial cells to make more blood vessels. Thereby, blood will be supplied in large quantities to the tumor, so the tumor grows bigger. I will skip this slide more. And the last experiment, That way the experiment was carried out, the co-implantation experiment, to show the importance of DGC, is not the real good model, because DGCs and GSCs are not added together from outside in reality when the tumor is formed. The reality, stem cells are made first, they divide, and then subsequently they differentiate to form the big tumor. Okay, so in order to answer the same way, in order to show the importance of fibromyalgia, the tumor is formed. What we did was, as the tumor is being made, the differentiated cells are being made. Can we just stop the fibromyalin secretion, fibromyalin synthesis in the DGCs, and then see whether it will affect the tumor growth, instead of combining and injecting the two type of cells into the animal model? So what we did is, we used the same approach where doxycycline inducible silencing FMOD, but then this construct was introduced into the GSC cells. GSC cells are the cancer stem cells. They don't secrete fibromyalin to begin with. So inject the cells, GSC cells, stem cells carrying doxycycline inducible FMOD construct is introduced into the mouse intracranially into the brain, and GSCs are allowed to form tumor. Remember, GSCs are actually introduced here, and they have inducible SH-FMOD construct. FMOD is not expressed in the GSCs, it is expressed only in DGCs. To begin with, the GSCs will start making tumor. As the tumor is being made, very small size, differentiation occurs, DGCs are being formed de novo inside the brain. Now you inject doxycycline to induce silencing of FMOD and ask a question, does it affect the tumor growth? You can see the result here. On the left side is a non-targeting shRNA, right side is the FMOD targeting shRNA. At the beginning of this, up to 21 days, doxycycline is not given. You can see the tumor size is similar in both cases, whereas as the days go, doxycycline is injected. Left side, no silencing FMOD, tumor continues to grow. On the right side, FMOD is silenced. DGCs which are formed de novo, they don't make any more FMOD, they don't help the tumor to grow any further. And the quantitation is shown on the right side. Survival also is shown on the right side. When FMOD is silenced, tumor is not formed, mice survives longer. Okay. So now, finally, of course, in the tumor, we also check by making sections. The angiogenesis is very much compromised. The vessel size and various markers which are related to the endothelial cells are actually measured by immunofluorescence. We show that angiogenesis is compromised in fibromyalin silenced tumor. That's why the tumor size is small. And one last evidence to show that this is indeed occurring, a clinical relevance. If you look at this model, the whole model, there are 3 RNAs which are very highly expressed. FMOD RNA is very highly expressed in the DGCs, which forms the bulk of the tumor. The FMOD protein acts on the endothelial cell, activates so-called JAG1 at the level of RNA. It is a ligand for Notch receptor, and then Notch finally activates a protein called HES1, again at the level of RNA. So FMOD RNA, JAG1 RNA, HES1 RNA, all are upregulated, okay, starting from fibromyalin. If that is really true, in the context of the whole tumor, that's what we actually look at with respect to patients. There should be a positive correlation, and the level of this RNA should be highly upregulated in samples compared to the normal tissue. Can we see that? You can see here in 5 different GBM data sets, FMOD, JAG1, HES1, transcripts are highly upregulated in glioblastoma samples compared to the control brain samples, number 1. Number 2, there is a significant high R value positive correlation between FMOD RNA and JAG1 RNA, FMOD RNA and HES1 RNA. Again, confirming indeed our findings are actually working in the context of tumor samples. And finally, you also look at in the context of tumor, the FMOD transcript level predicts poor prognosis. Higher the FMOD, prognosis is poor. On the other hand, FMOD promoter methylation, which would actually inhibit the expression of the FMOD gene, predicts the good prognosis. All these things provide clinically relevant findings which support our whatever the conclusions we made from the animal model experiments. I'll stop here. This is a model. Basically, you have in the tumor on the left side, bottom, the tumor consists of GSC and DGC, cancer stem cells and non-cancer stem cells. GSCs are very, very small, minute fraction. They are no doubt are the most important cells in the tumor, and because they alone can initiate a tumor, and they also post resistant to the traditional therapy. We need to study them. We are actually studying. There are many red dots, which are proteins highly abundant in the GSC secretome. We have taken many such spots. We are trying to understand what is the role in context of GSC initiated tumor. On the other hand, we also found in this study the DGCs, that is non-cancer stem cell, which occupy the bulk of the tumor, they also secrete certain factors or express certain factors, and through which they can actually help the tumor to grow much bigger than what can be done only by GSCs. Okay, and the take-home message is, it's very important that yes, we need to study about GSCs, that is cancer stem cells, and develop cancer stem cell targeting therapy. At the same time, we should not forget DGCs, that is the non-cancer stem cells, and try to understand their biology as well, and try to combine both cancer stem cell and non-cancer stem cell directed therapies together to achieve the best possible treatment. And finally, acknowledgements to my graduate Gupta, who did most of the work, and other people who helped in this work are Arani, Prasasvi, and Mainak Mandal. Thank you all. On the right side are my collaborators.
Thank you, Professor Somasundaram. This was a fascinating journey into the world of glioma, and you very well showed that targeting cancer stem cells is probably not enough. We need to target both the cancer stem cell as well as the non-cancer stem cell. So that was a fascinating introduction to the glioma stem cell, GSC, and the differentiated stem cell. Thank you very much for this very informative and very new insights into the therapy of, and it has immense clinical research implications, as we can see from the research that you are carrying out at the Indian Institute of Science. Thank you very much, sir, for your very illuminating lecture. On behalf of NAMS, we are proudly presenting Well, we go on to the next oration, and the next oration is Dr. K.L. Wig academic oration. It is also close to my heart because I have been a recipient of this oration, so I can very well relate with the medical education. Thank you very much. The oration was instituted in 1993 to perpetuate the memory of late Professor K.L. Wig, one of the founder fellows of the Academy. The orator must be a fellow of the Academy and is an outstanding teacher in any of the clinical subjects, with a long association with medical education and a demonstrable and proven track record of published work in the field of medical education. And today we have none other than Professor Tejinder Singh. I welcome you, sir. Please come on the dais to deliver this oration. We all know Dr. Tejinder Singh as the father of modern medical education, and he has been instrumental. I remember the days when we used to go together for a perpetuating or for workshops on medical education. There used to be no takers, and we have come a long way. With his insights, we have been able to implement the competency-based medical education curriculum, both at the undergraduate and postgraduate level, create a network of fellows on medical education across India, and connecting them to the fellows abroad through the Famer Institute, which was the first to be instituted at CMC, with the, and now subsequently many others came up. He is also awardee of Dr. B.C. Roy National Award, National Board of Examination for Excellence in Medical Education, and in the extensive training in the field of medical education, student assessment. He has more than 300 publications and author and editor of 4 books. He is presently Emeritus Professor of Pediatrics, NAMS, and Chair, Center for Health Profession Education at Adesh University, Bathinda. So over to you, Professor Tejinder. Just a word about the topic that he will be discussing today is assessing the Indian medical graduate. We all know that the competency-based medical education has now come up. So it is a big challenge to implement that. That has been implemented, but even bigger challenge is to devise the assessment for competency-based medical education. So we request today Dr. Tejinder has chosen a very important topic, that what do we understand from clinical competence and how do we implement that or utilize that for assessment of the Indian medical graduate. Professor Tejinder Singh, over to you.
Thank you, Dr. Piyush, and I thank the NAMS for bestowing this honor on me. I very vividly remember the year 2016 when Dr. S.K. Sareen, as chairman of the Board of Governors of Medical Council of India, had actually announced the competency-based curriculum with the intention of producing an Indian medical graduate. And an Indian medical graduate conceptualized to be a person who would be fulfilling the 5 roles, that is, clinician, leader, communicator, lifelong learner, and professional. Few months down the line, we were asked to write a support module for assessment in competency-based medical education. And in fact, what attracted my attention was a statement made in 1976 that the effort in competency-based education lie in the design of instructional material, but in the design of appropriate assessments. Now, I think that is what makes competency-based education a success or a failure. We have not forgotten the educational impact of deciding the career of the students on single entrance examinations. Most of them don't study medicine from their books. They study from MCQ books. And to avoid a rehab of same thing happening, we looked at the evaluation of assessment over the years beginning from almost 1900. In fact, if we look at how evaluation has evolved, it's possible to clearly make out 3 distinct phases. And these phases were actually based on our evolving understanding of clinical competence. One of the major issues which has actually cropped up, and which most people agree, that the assumptions behind large-scale examinations and classroom assessments are very different. What we ask and assess in a NEET examination, for example, is not applicable to what we ask and assess in our university or classroom examinations. The first phase can actually be called the measurement phase. And what happened in measurement phase was the belief, and that came from 1918, that anything that exists at all exists in some quantity, and anything that exists in some quantity is capable of being measured. To this extent, it was probably all right. But somehow it went on to say that if something cannot be measured, then either it is not important or it does not exist. Now, that was the unfortunate part of the whole process. We have been almost 3/4 of a century in medical education after independence, but even today, no medical school in India actually assesses professionalism. No medical school actually assesses communication, leadership, lifelong learning, because they cannot be precisely measured. And our paper on competency-based medical education and McNamara fallacy, in fact, raised many of such important issues. The predominant belief during that time was that competence is a trait, it is generic, it is transferable from one job to another, and is stable over time. So there used to be concept of a G factor, a general factor. So if you have that general intelligence, you can do anything. And what we believed is that content, context, and situation play no role in competence. The purpose of assessment is only to quantify learning and indirectly to separate competent from incompetent. It's not surprising because most of these assessments were actually based on psychological testing, where the purpose of testing is to separate normal people from people with psychological problems. And even today, if you look at some of the terminologies in education, like we still talk of discrimination index as a measure to discriminate between good students and not so good students. Reliability was seen as reproducibility. But what is very interesting is that we were only looking at reproducibility of the marks. We were not looking at reproducibility of the performance. So what we were interested is that if another examiner is there or if the student is examined again, would he get the same marks? We never bothered whether this student, when he goes out of the medical college, would he be able to repeat his good performance? And that is something which was badly lacked. And then there were manipulation of numbers and limited sample of task because many of the things required for a good doctor could not be objectively assessed. And what could not be objectively assessed was left out. We saw during that era the advent of multiple choice questions, OSCEs, oscillars, special management problems, and so on. The second phase, which actually evolved because of the dissatisfaction that we had with the previous phase of assessment, and that was the decision-making phase. This decision-making phase actually perpetuated by the evolving definition of clinical competence. If you read the most respected and most widely used definition of clinical competence, then certain things actually stand out. The most important is that it is habitual. So it is not just one-time assessment. The student has to repeatedly demonstrate. And what he has to demonstrate? Knowledge, technical skills, attitudes, communication, clinical reasoning, emotions, and so on. So not only it was not supposed to be one-time process, but at the same time, it also told us that assessment of competence is not stacking of the individual components. So you have isolated assessment of knowledge, isolated assessment of skills, that will not add up to competence. In fact, if that was there was no need for a competency-based education. Everything was going on fine. Yet another thing which we learned the hard way, I should say, I'm showing you two models of professionalism and model of clinical competence, which was given by MCI. Both the models are very well accepted. This, even if you don't take MCI model, you take ACGME model or any international model, most of them will have these common elements, maybe by a different name, but professionalism, lifelong learner, clinician, communicator, they'll always be there. Now, I hope you have noticed that to be a professional, you need to be clinically competent. And to be clinically competent, you need to be professional. You can also notice a whole lot of linkages between the various aspects of professionalism and various aspects of clinical competence. So that means that from independent generic traits, we actually moved on to a combination of competencies and competency domains. From our earlier conceptualization of one best tool for everything. We had one best tool for knowledge, one best tool for skills, one best tool for communication. We have actually moved on to what is called a assessment toolbox. In fact, assessment toolbox is a combination of tools which is designed to provide the teachers an ability to assess the various aspects of competency based on the content, the context, and the situation. In this era, we saw the advent of many newer assessment methods. So many clinical evaluation exercise, direct observation of procedural skills, professionalism, mini evaluation, multi-source feedback, mini peer assessment. So these were the things which evolved during the second or the measurement phase. And if you look at the list, you would find that compared to the traditional MCQs or OSCEs,
these assessments are mostly subjective. And when I say subjective, I don't mean bias. What I say, expert subjective. And the push that subjectivity got during this phase was actually enormous. In fact, if you look at the current assessment literature, it tells you that subjectivity is not only to be expected, it is to be welcome. We'll discuss a bit more about it. Another important concept which came during this time was the concept of utility of assessment. Now, what happens is that we have various attributes of assessment in the form of validity, reliability, feasibility, acceptability, and most importantly, educational impact. Now, depending on the situation, you may have to decide which is the most important attribute for that particular assessment. And the utility of assessment is actually expressed as a notional product of multiplication of these 5 components. Not that you have to multiply anything by anything, but this is just an example to illustrate that different assessments with different attributes can be equally useful. So for example, if you look at the first example, the educational impact is low. For the second, the educational impact is relatively higher, but still both are equally useful because the second one is more in terms of validity. It also tells you that if any of the attributes is 0, then the entire utility of assessment can become 0 for that particular. Now, what we know based on all the research that has gone on in competence and assessment is that competency does not reside in individual. Rather, it resides in the way an individual interacts with the context. So that means competency is not an innate or inborn trait. Competency is acquired and and competency can only be inferred from performance. You can't look at a person and say, oh, so competent. You have the performance. Excuse me. No, I have, thank you. But against knowing about competency, what actually we think is that we can break down the medical roles into different elements of knowledge, skills, attitudes, and we can rejoin them to create a competency. So it's like you can, break down a cycle into smaller components, reassemble and again get a cycle. But suppose you were doing the same thing with a frog. Would you be able to reassemble a frog into a live one? No. So some things are like a cycle and some things are like a frog. We also have a problem that performance can be tested only like a race. So watch and to the precise 0.00 something seconds. But after all, gymnastics is also assessed internationally in the Olympics. We all heard this statement that assessment drives learning. We have also heard that assessment is the tail which drives the curriculum dog. But it's generally not that simple and straightforward. Summative assessment is a poor feedback carrier. Summative means the university exam or the final exam. Because the purpose there is to say pass or fail. You're not taking a tutorial for the student. For the formative assessment, when you do it in the classroom, there are takers. Students will say, nothing is going to happen, why should I go there? Teachers will also say, nothing is happening, why should we waste time on that? So what actually you need is to have a strategic use of assessments, which means in training assessment, internal assessment, and combining the summative and formative functions of assessment. Now, when we talk of the validity of assessments, what actually is true is that the things which are most important in working of a doctor are the most difficult to measure. Patients do not go to the doctor after seeing their degree or new gold medals or anything else. They go to the doctor by the word of mouth, by the communication skills, by the way he deals, by the way he talks, and so on. So the success and failure in practice is not decided by the knowledge and skills. You look at any of the consumer protection cases, most of them are not related to the knowledge and skills. Most of them are related to bataya nahi, theek se samjhaya nahi, paise zyada lag gaye, and so on. So those kind of issues will always be there. And we have to decide what you want, whether you want highly structured assessment or you want a authentic measure of doctor, what the doctor actually does. That is what you should be assessing. Here's another example. Look at the reliability values. In fact, if you look at the reliability of the common assessment methods, the only thing which I would like to draw your attention to is OSCE, which is highly objective, highly structured, has a lower reliability as compared to a long case, which is highly subjective. But when I say subjective, I don't mean biased. It's expert subjective judgment. But what else comes up is that as you keep on increasing the testing time, the reliability of all the assessment keeps on increasing. So it is not objectivity which helps you. It is the broader sample of the tasks. We have also developed workplace-based assessment. You don't prefer to assess the students in the laboratory or in the classrooms. Take them to the place where action is actually happening and then assess them there to find out what they are doing. Yet another important point which I would like to mention is meaningful aggregation. See, as a doctor, no one of us will tell our patients that unfortunately your blood sugar is very high, but fortunately your serum sodium is very low, so on an average you are okay. No one does that. But when it comes to assessment, we do that. Okay, you couldn't revive the patient, okay, but you certified the death very nicely, so you should pass. And that is what happens, that OSCEs, all long case we club together because they are all practical examples. All MCQs we club together because they are all theory assessment. So we go horizontally. Actually, we should be going vertically. So for each system, the knowledge, the skills, the communication, and other things, because that will give us a better and more meaningful indication of combining various things together. Now, often a question is raised, can we have human-less assessments? I'll just take one example of MCQ because they are the epitome of objectivity. Even for MCQs, there are a whole lot of procedures like blueprinting, question framing, distractors, standard setting, which require a lot of complex human intervention. And if that can happen with MCQ, with performance assessment, you will never be able to have a human-less assessment. So what is more important is to create assessment literacy, because that will help people to accept the newer assessment methods, to increase the expertise of assessors. In fact, the international CBME collaborators are on record having said that the primary instrument in competency-based assessment is the assessor and not the tool or the test that he or she uses. So the culture shift in assessment that we have seen is from easily measured to hard to measure qualities, from simply giving grades to attaining standards, from identifying failing students to helping all students, and from standardized methods to authentic measures. I'll remind the learned audience that we do not award a degree with an asterisk and fine print saying terms and conditions apply. We do not say that this student was certified fit in a examination. We don't know what he can do outside. No, you are certifying him for fit to practice medicine and surgery. And do we need to learn something from our past? Yes, we can. So an assessment which is on low stakes, based on expert subjective judgment, uses a lot of mentoring, multiple context, and quality assured is what will produce a competent student. Thank you very much.
Sir, thank you very much for touching on a topic which is of vital importance and very rarely discussed. I mean, you developed the story from the time when Professor Sharin took over as the president of MCI and started to introduce competency-based curriculum, and you took off in the three directions. And we like profusely what you said, that what we cannot measure in the quality cycle, we cannot improve it. Therefore, it either doesn't exist or if it is not important. That is great message you gave. Therefore, the assessment is of paramount importance. And you've given us a great landscape, a panoramic view of the entire assessment system. I hope this will be followed. I'm sure the NEP centers, as you rightly said, sir, two things: competence-based learning and clinical skill learning. And many other things also you pointed out. And assessing those is of paramount importance. Your talk has been invaluable, and I'm sure that many of us who are teachers, even doctor is basically a teacher, a scientist basically a teacher, will do a lot of good to our country. Please continue your good effort in making these things known to the people and be carried, being implemented, which will change the destiny of the medical education in the country. Thank you very much, sir. Please accept our... Dear friends, the type of presentations and the skill and the way it is presented is something great. And yeah, so I will request Piyush to kindly call the next orator. Over to Piyush.
The next is Dr. Pranna Chutani Academic Oration. Dr. Chutani Oration was instituted in 1999 on the subject of tropical medicine and communicable diseases, who was a past president of the Academy and one of the distinguished fellows. The orator has to have original contribution in related to the subject of tropical medicine and communicable diseases, including basic research towards diseases and such diseases, laboratory diagnosis, medical or surgical management. So now today we have Dr. Jai Bhagwan Sharma, who is working as a professor in obstetrics and gynecology at the All India Institute of Medical Sciences. He has worked as a professor in NAMS. He also worked at the St. Bartholomew's Hospital, Homerton Hospital and Whipps Cross Hospital, London, UK for 4 years. Dr. Sharma has 400 publications in indexed and non-indexed journals, including 150 in peer-reviewed indexed international and national journals. He has been awarded in 2005 the Fellowship of National Academy of Medical Sciences for his contribution to the specialty. Welcome today, Dr. Sharma, and today sir will be speaking on current diagnosis and treatment of female genital tuberculosis. Over to you, sir.
Thank you, respected chairperson. At the outset, I thank Professor Sreen, Dr. Kapil, Dr. Behera, and Dr. Loy, and all others, and for granting me this opportunity. And my, all predecessors from me, they have done a wonderful job. All the orations have been of extreme high quality. I congratulate NMS for that. So, so already we have told about Dr. P.N. Chutani, who was director of PGI and done a lot of work for that. So I'm really basically overwhelmed by receiving this oration. And as sir said, my topic is current diagnosis and management of female genital tuberculosis. So I'll try to make it more clinical as possible. So we all know, I mean, so Dr. Rajendra Prasad has made my work easier by on talking about tuberculosis as a opening bats person in the morning. So we know that nearly 10.6 million people have TB every year and 1.6 million globally, and in India, sir already highlighted the topic. Okay. So as far as genital tuberculosis is concerned, I will restrict myself to that, though mortality and all are much less in genital tuberculosis, but it causes a lot of morbidity. First case was detected as early as 1744 by Morgagni, and it was like, we all know about Robert Koch and you know about the course and of the disease. So exact incidence of FGTB is not accurately known. I mean, unlike pulmonary TB, which Dr. Rajendra Prasad highlighted, we have a lot of asymptomatic cases in genital TB, and there is lack of reliable confirmatory diagnosis. And but we really so, and we know that genital tuberculosis is seen in almost 30% of sputum positive pulmonary TB cases. If you do, Dr. Tripathi et al. From Odisha did this study, and 10% of extrapulmonary TB. So typically young women, 80 to 90% are 20 to 40-year-old in India and Asia, though in developed countries the mean age slightly later, 40 years or so. At AIMS we did studies and we found the FGTB prevalence with infertility almost 16%. Traditionally 10% of all infertility patients have TB, sir, but in AIMS we found it higher because we got the referral from like Odisha and Bihar, etc. And incidence of fertility in FGTB is very high, 42%, and 8% AUV patient can also have due to FGTB. As far as infertility clinic, I already mentioned that in USA, only 1% patients of infertility have TB, same with Scandinavian countries, South Africa 4 to 8%, and India 1 to 19%, and higher incidence in like centers like AIMS where we get referral patients. And we know, this August gathering all know that tuberculosis is the commonest, but we can have M. bovis also sometimes because of unpasteurized milk that can also cause tuberculosis. And in genital tuberculosis, sir, it's mostly primary, mostly secondary genital tuberculosis is usually secondary 98 to 99%, but 1 to 2% rarely cervical vulval vaginal tuberculosis can also be from the infected semen of a male partner. But essentially, we deal with the genital tuberculosis, and secondary genital TB almost 98 to 99%. So unless proven otherwise, we label it secondary TB. And pulmonary TB, the commonest from which it goes through usually hematogenous route, but they can be from GI tract, kidneys, etc. also. And hematogenous spread, we all know, is the commonest from lungs, and fallopian tubes are the most common site involved, almost 90% cases, and then usually bilateral involvement. So that is unfortunate because then the lady tends to be infertile. Lymphatic spread can also occur, and direct spread from the neighboring viscous, like from the intestines and all, which are very close to genital organs, so we can also have from there. And the sites involved are commonest fallopian tube almost in all patients, 95 to 100%, endometrium in about 70 to 80%, ovaries 20 to 30, cervix 5 to 15%, myometrium about 2 to 5%, and vagina and vulva rare 1 to 2%. And sometimes they can be there in primary tuberculosis also. So what are the symptoms in genital tuberculosis? Unlike pulmonary TB, where mostly it is symptomatic, it can be about 10 to 12% patients can be asymptomatic, but some patients may have fever with night sweats, loss of appetite, weight loss, typical poor malaise, general condition, etc., just like in all other TB. But many patients actually may be asymptomatic, or the symptoms are not that severe, sir, as in other TBs like abdominal TB or pulmonary TB. But we have seen that many patients have menstrual dysfunction, especially oligomenorrhea, etc. Initially, when the initial stage, when there are ulcerative lesion, patient will have menorrhagia, postmenopausal bleeding, but later on TB will eat away the endometrium, so patient will have oligomenorrhea, hypomenorrhea, and sometimes even amenorrhea, primary and secondary amenorrhea. And amenorrhea can also be due to basically antigonadotrophic effect of Mycobacterium tuberculosis. And infertility is the commonest presentation. It can be primary, secondary. There can be mass in the abdomen, abdominal pain, chronic pelvic pain, acute abdomen, and abnormal vaginal discharge also we found in our studies. Similarly, the patient may have no physical sign. So this is very important, that a patient of genital TB may be normal looking, she has no symptom, no sign. But then there can be fever which is not very high grade. So often can be missed unless you take it every day. Lymphadenopathy in cervical lymphadenopathy, and crepitation on chest examination. Then on abdominal examination, there can be mass abdomen, vague or definite ascites, doughy feel. It can be there. Dr. Govind Mukharia is there. We did studies together in abdominal TB and genital TB. So this doing field is very particular about it. Then on vaginal examinations, we can have uterine enlargement, pyometra, adnexal masses, induration, tubo-ovarian masses, fullness and tenderness in pouch of Douglas, which can sometimes be not only because of tuberculosis, but because of the superadded other pyogenic infections, sir. And rare signs we have observed are hypertrophic or ulcerative lesion in the cervix, vagina, vulva, and on labial mass, Bartholin swelling, vesicovaginal fistula, ectovaginal fistula. In fact, we have reported 8 to 10 cases of cervical, they mimic cervical carcinoma. And when we took biopsy, it turned out to be tuberculosis. And similarly, I had patient, unmarried girls, non-sexually active, having rectovaginal fistula or vesicovaginal fistula because of TB. And we didn't operate upon them with them ATT, and the fistula healed themselves. So don't try to operate upon these patients, give them ATT, and then only you can do some surgery. Now, how to diagnose? Diagnosis of pulmonary TB is very, specific and straightforward, as Dr. Rajendra Prasad said in his presentation. But in case of gynae and same way in abdominal TB, Dr. Govind will agree with me. We have difficulty in diagnosing, sir, because many of them are asymptomatic or symptom, signs may not manifest like in pulmonary TB. So family history of TB or history of anti-tuberculosis therapy in a close family member or a past history of TB or ATT is very, very crucial. So we have to take a detailed history. So that history taking is very crucial for this patient. The general physical examination for any lymphadenopathy, any evidence at any other site, like bone, joint, skin, chest examination, abdominal TB, examination of external genitalia, specular examination, bimanual examination for endometrial fallopian tube is very crucial. I had 2 girls, they are unmarried, having tubo-ovarian mass and non-sexually active. So I was suspecting TB, but I didn't know what to do, unmarried girl. So I admitted the patient thinking I'll take FNAC for them. But then on the next day on ward round, I saw one had discharging sinus from the knee. And when we examined it, ultimately it grew AFB. Another patient found to have cervical lymph node. So we took FNAC from there, which is easy to do. We have to do a close examination of these patients to find out the TB at any other side. And the test will depend upon the site of TB and its clinical presentation. I was part of this index TB guideline with Dr. S.K. Sharma, ICMR, AIMS, and Ministry of Health. So in which we index TB guidelines were developed for all extrapulmonary TB, including genital TB. And for that, we combined basically history taking, examination, and judicial investigations. So how to investigate for this, I'll come to that later also. So any premenopausal woman presenting with infertility, menstrual problems, unexplained abdominal pain or pelvic mass, rarely patients having systemic symptoms of fever, weight loss, and night sweats, and then ectopic pregnancy, cervical vulval lesions are rare presenting features. And a postmenopausal woman presenting with vaginal bleeding. So we should suspect these patients, not that they will always have TB, but we should investigate these patients. So single most important investigation in all sexually active will be endometrial aspirator biopsy. Menstrual blood alone has a very poor sensitivity. So it is performed on luteal day 21 to 24, and we take the biopsy, we put it in saline sample, and we send the sample for AFB microscopy on ZN stain, which is rapid and cost effective. We do AFB culture also, and Dr. Urusi Singh cooperates with us in that. Then we do gene expert for these patients. PCR is done, but we don't rely only on PCR. We are doing LEMP, LPA, formalin, and then we take a formalin sample which we send for histopathological examination for third granuloma. So this is the protocol which we follow at AIMS. What is the role of radiology for these patients? I mean, this is controversial, but yes, like Dr. Rajendra Prasad showed a role of X-ray at all. So we do have role of ultrasound, CT scan, MRI, PET CT for and HSG for these patients. But usually the role of these radiological measures is mainly for tubo-ovarian masses, sir. But HSG usually we avoid doing because HSG can sometimes flare up the infection. But many times because these patients are asymptomatic, so we do HSG as a part of infertility protocol for which these patients present, and then we have the finding of that. So otherwise, in an active patient of TB, don't do HSG for avoiding flare up of the infection. We published this paper, Gene Expert, as compared to conventional method in diagnosis of genital tuberculosis, and I thank Central TB Division, Ministry of Health for funding this study. And we found that almost 30%, sir, sensitivity was at 30%, but specificity was almost 100%. So that is important. So then what is the role of transabdominal transvaginal? Can we publish this study? So we found that it has got more role in case of tubo-ovarian masses. But without that also, like if like person, Dr. Smriti Hiri, Dr. Ashok Khurana, they who are special, like, you know, special predilection for detecting these patients, so they can pick up the disease in early stage. Like subtle signs of TB can also be picked on these patients. And then what is the role of CECT? CECT, again, I told you CECT and MR, they have main role for tuberous masses. So that can differentiate between carcinoma ovary and tuberculosis, and there can be like mesenteric lymphadenopathy in these patients. And usually same way MRI. MRI has even better resolution. So we can say there will be cystic lesions with internal debris, bilateral adnexal tuberous masses, and it can differentiate in TB and ovarian malignancy. In ovarian malignancy, in TB, usually the lymph node will have been centrally necrotic, and there are other subtle signs which is beyond the scope of this, but like, you know, that is important for this patient. But again, I mean, you know, sometimes even these tests may go wrong. So if it's better to open the patient, because we may miss you know, ovarian cancer. We have seen patients of ovarian cancer being treated with anti-tuberculous therapy, which is very greater seen. But on the other hand, we did study in which AIMS, MEMC, Lady Harding, GTB, 22 patients are where we opened the abdomen for CA ovary, they turned out to be tuberculosis. So that also mistake is possible. But if in doubt, it's better to like do laparoscopy or do laparotomy, but not to miss a case of ovarian cancer. The role of PET-CT, again, Dr. Rakesh Kumar collaborate with us in that case. So I found that, you know, though MRI can also pick up the TB ovarian masses, but the PET-CT will show us the TB activity by glucose uptake. And Dr. Rakesh Kumar can differentiate between TB activity of a ovarian cancer from TB lesion. And another important role I found, it's like we gave the patient over 174 patients. So out of that, after treating the patient with 6 months of ATT, 8 patients were still having mass. And then we didn't know whether it is a just persistent like a lymph node, which is or it is a persistent disease, because it's very difficult to go to FNS, to do FNS in these ovarian masses. So we did PET-CT on these patients, and out of 8 patients, 4 had no activity. So we didn't treat them further, but 4 had activity, then we for them. So PET-CT can actually help in end stage of the disease. It can tell us the end point of the disease. And I was like, we had a study done from Dr. Ravi Mittal from orthopedics. So he did study 6 months, 9 months, 12 months like that. And he observed that in skeletal TB, almost the disease may persist up to 15 months or so. Same in CNS TB. So PET-CT can have a role in basically predicting the end stage of the disease, like when to stop ATT. So I think we need to do study, and that is what we also observed in our study. And the HSG findings, basically, as I told you, we normally avoid doing HSG in active patient because it can flare up the disease. But we can have like various HSG finding in advanced cases, like there can be, you can say bleeding of the tube, blocked tubes can be there, and sometimes this is a case with whole uterine cavity just shrunken, and both tubes are bilkul like a dry tree branch basically. And again, this you can see the dye, both tubes were blocked, so the dye was going into the lymphatics or the blood vessels. And now laparoscopy has a great role. We had a lot of studies on laparoscopy. It's a most reliable tool to diagnose FGTB, especially for tubal ovarian peritoneal disease. Luckily, our patients are infertility, so we do laparoscopy dye test as a part of protocol for them. And then we found that we can have tubercle zone, peritoneum, ovary, cages, nodule, tube ovarian mass, hydrosalpinx, pyosalpinx, tubal blockage, adhesions, encysted ascites. I'll be showing the pictures. And this study I already quoted that abdominoperine TB can masquerade like ovarian cancer for these patients. And these are the another study we published, and these are the, I want to show some share some findings. So you can see the hydrosalpinx in a patient. Now this hydrosalpinx alone does not suspect that it is a case of definite TB, but this patient was infertility. She had oligomenorrhea, she had positive PCR, and then hydrosalpinx. So then so we took it as a TB, probable TB. Same way, this patient was clear-cut hydrosalpinx, cages nodule. So cages nodules are very specific for tuberculosis, saggy areas and obliterated pouch of Douglas. But this like cages nodules are very specific of tuberculosis. Then various types of adhesions are very common, sir. Like, though I want to see that when we put a laparoscope in, we should look all around 360 degree. We can find the subtle signs. Like this patient has perihepatic adhesion, Fijakatis, very common. Normally, traditionally we label gonorrhea and chlamydia for it, but in TB also we found it high. This thing. Then these are the have a look all around. In peritoneum, we found the cages nodules. Again, cages nodule in pouch of Douglas. Then this is the patient. Normally, endometriosis, once we say we rule out TB and vice versa, but it had both. So in India, both these are so common, so they can have combination of both these. Now this is a like beaded appearance in a proven case of genital cox with hyperemic tubes, hyperemic uterus. Again, this case you can say convoluted tubules. This is the, you can say the hanging gallbladder sign. I have marked it. So you can say that there is a casus nodule there, and leaves becomes hanging because of the perihepatic adhesion. So it's very commonly seen in tuberculosis. Then this is the sign I discovered. In this case, when we put the dye, so normally in a normal patient, dye just flows. But in case of TB, it trickles slowly. So the tube becomes distended like a blue python. Later on, it may come out also, but delayed spill. And then this is the patient. In this case, the kissing material came out, both tubes got fused to each other. So there is a kissing ovarian sign in case of endometriosis, but this is the kissing fallopian tube sign in tuberculosis. And you can see the cages nodules. So it's a very definite case of tuberculosis. And then again, perihepatic adhesion, ascending colonic adhesion, lower 2/3, upper 1/3 junction. We found it in about 40% cases. This is the dry tree branch sign. You can see that the tubes become just dried, just like a dried tree because of calcified tubes. Unfortunately, poor prognosis for fertility. And then we found the parachute sign. In this case, the ascending colon becomes adherent to anti-abdominal wall, and on higher magnification, you can see the cages nodule there. This has a remedy because if you put a laparoscope, a second port, we can go through the ascending colon, we can injure it. So never put a second port on the right side. Under vision, we put it on the left side. And then we found the sigmoid colonic adhesive band in these patients, like this, and other adhesions, of course. And then the compartmentalized sign, like this becomes like just like any other infection. TB also gets to be compartmentalized by the this thing. And then recently we have published this, you can say white cotton ball sign. If you see almost 5 centimeter big white cotton ball or a snowball, you say, we found it, and we have just published this study. So this also is in very advanced case of tuberculosis. And then TB algorithm we have found. So we then on histoscopy we can have, sir, like small uterus deposits, saggy areas, and pale cavity. And this is grade 3 adhesion in case of on histoscopy, grade 4 adhesions, and this thing, yeah. So, but there are increased complications of laparoscopy, laparotomy, and other surgery in TB patients. So, the surgery for TB patients should be done by consultant or a senior agent under supervision, because the complication rate is higher as compared to non-TB patients. The treatment is, like, I won't go into detail. 6 months course of ATT is given to all these patients, and that's under National Tuberculosis Elimination Program. So, I encourage that all patients should be referred to the government setup, as Dr. Anindra Kumar said, where they will be given free treatment, and this, we are following this regime. I won't go into detail of that, but grossly 2 months of RHID daily, then 4 months of RHE daily. And in case of FG, this can be drug-resistant TB also. We have reported our first study in European Journal. So in that case, the treatment tends to be 14 to 16 months. I won't go into detail of that. And but these patients are tolerate these drugs very properly, but there can be chances of liver toxicity and all. So we need to follow them up, do LFT and all. And then the surgical treatment usually we don't shouldn't be done because causes more complication, and still we have to give AT to the patient. So even if I have opened the abdomen for like suspected malignancy, turns out to be TB, just take a biopsy, as we did in this case. There was cages material, so I just came out, took biopsy, came out. Never try to do surgery because there are chances of bowel injury and all, and still we have to give AT. Usually they to that, but assisted reproduction has a role in these patients. Almost 30% success rate of IVF in these patients, and this is my last slide basically. So whenever you get a suspected case of FGTB, you do we do composite reference standard for these patients: endometrial history taking, examination, endometrial sampling for smear, culture, gene expert, PCR. If anything like smear positive, culture positive, gene expert positive, they are definite TB, but if or histopath positive. But if they are only PCR positive, others are negative, or we are clinically suspecting, so then we do ultrasound CT for tibio ovarian masses, otherwise do laparoscopy for them. And on laparoscopy, we can have definite findings, we can have probable finding or possible finding. And if there are no findings, then we label it as negative. So just only on the basis of PCR we don't start the treatment. And that is the composite reference standard we have developed. So, and then the patient is treated 6 months course of ATT under National Tuberculosis Elimination Program. So this, thank you very much. This is my last slide. So it's an important cause of infertility in developing countries. Clinical examination, history taking, endometrial sample, laparoscopy, hysteroscopy is very useful. Treatment under NTPE dot strategy. I encourage all my colleagues to refer patient to government setup, to get them treated in government setup. IVF has a role, and stem cell therapy may have a role in regeneration in future. Early studies are being done. Thank you very much, sir.
Thank you, Professor Sharma. I think that was a wonderful, exhaustive review of the female genital tuberculosis that you gave. And with the insight, with so many papers of yours, you have done extensive work starting from the magnitude, epidemiology, clinical features. And I was amazed to see the number of signs that you have given. I was noting down, I noted down the python sign, kissing sign, and then I lost track. because there were so many of them, I couldn't even remember them. So thank you, sir. You have done an extensive work, and I think this will be one of the unique work that you are doing in this particular field. Thank you so much for enlightening us with this very important topic.
Thank you, sir. I think, sir, why all the science would be Murphy sign after British or American wide? Why they shouldn't be after Indian scientists? No. And like TBJ, an area where we can work a lot. So thank you, sir. Thank you.
Yeah. Dear friends, we pass on to a very important oration once again. This is named after Dr. B.K. Anand. B.K. Anand was a very famous and eminent neurophysiologist and also past president of the NAMS. And this oration was instituted in the year 2004 in his name. And you know, it was a donation from the Dr. B.K. Anand Benevolent Trust which made this oration possible. Dear friends, this oration is awarded alternate year. 1 year to a basic medical scientist and the other year to a physician or healthcare professional who has contributed maximum to medical education or to the patient care. Now this year's oration is being awarded to a very eminent basic medical scientist with special contribution in the field of neurosciences. Please put your hands together to welcome Dr. Madan Mohan Gadbole, who is the orator for this year. Dear friends, Dr. Gadbole served as a professor of endocrinology at the Department of Endocrinology at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. He obtained his PhD from the AIMS, and you know, he has contributed immensely in the field, in two areas, in the field work and the bench work on the many aspects of iodine deficiency in our country. And his research includes brain development, breast cancer, stroke, relation to iodide and thyroid hormone, and has 80 quality publications in this field. He is a fellow of the National Academy of Medical Sciences, and also he has been seeing his contribution. The Government of India has also awarded him with Padam Shri for his immense contribution. Over to Professor Gadbole, and the topic is going to speak to us. The name is very big, but it's very, very essential. It's going to speak to us regarding the temporal effects of iodide / thyroid hormone deficiency on the neurodevelopment. Not only that, he's also going to describe to us what are the plausible areas, plausible approaches to ameliorate this effect of iodine deficiency, thyroid deficiency in human being. Over to Professor Gadbole.
Professor Das, thank you very much for very kind words. At the outset, I wish to express my thanks to the National Academy of Medical Sciences for selecting me for this year's B.K. Anand's oration. I am going to speak to you on spatiotemporal effects of iodine and thyroid hormone deficiency on neurodevelopment and plausible amelioration approaches that go beyond the critical window. Normally, it is customary to thank your teachers at the end of the teachers and colleagues at the end of the lecture, but I prefer to do otherwise. As I was influenced by a few great people like Professor Amlingaswamy, who was the forefather of iodine deficiency in India, Professor Ahuja, who insisted that I should also do some bedside research, and my revered teachers, Professor Narayan Kochupille and Professor M.G. Karnakar, who taught me the science and art of investigation. So with this acknowledgement to my teachers, now I come to the thyroid hormone, which are critical regulators for mammalian brain development. They regulate the cellular and molecular aspect of several dynamic neurodevelopmental processes, including neurogenesis, neuronal osteoglycogenesis, synaptogenesis, neuronal apoptosis, and myelination in a very precise spatiotemporal fashion. Therefore,
thyroid hormone deficiency during early brain development that leads to severe and often irreversible mental disabilities in the humans. Additionally, requirement of thyroid hormone and timing of development of different brain areas is also unique. For today's purpose, I have decided to divide my talks in 4 parts. How do the thyroid hormone is maintained and how the thyroid hormone act, and concept of neurogenesis and concept of neuronal migration. I thought it is important to give this brief introduction before I come to the research that we conducted. As all of you know that iodine is a part of the 7th group of the periodic table. It is a halogen. It is indeed needed for the synthesis of thyroxine and T3. Iodine deficiency is still a major problem despite the universal salt iodization program. And from public health point of view, fetuses, neonates and infants are most vulnerable groups of the iodine deficiency disorders. Iodine gets attached to a hydroxyl amino acid known as the tyrosine and then forms thyroid hormone by coupling and addition of these hormones. And once how do the thyroid hormones cross the placenta and cross the blood-brain barrier? It is the thyroxine which gets transported through a receptor to a transporter called MCT8 in the humans or OAPC1 in the rodents. Once that enters the brain, different cells of the brain, these different cells of the brains like astrocytes and tenocytes and neurons, what they do is they convert this T4 to the T3. So T3, as far as the brain is concerned, is a locally produced one and not come from the circulation. And how does body avoids the accumulation of large amount of T3 because it can be harmful also. So nature has provided another deiodinase that is called DiO3 and which removes an iodine molecule from another position and making it a hormone T3, which is a totally inactive. That is the way nature controls the thyroid hormone homeostasis. And once this thyroid hormone enters, they get attached to a receptor called thyroid hormone receptor, and they make a dimer, TR-TR dimer or RXR-TR dimer, and T3 gets attached. Once T3 gets attached to this receptor dimer, it sits on a cognate DNA sequences. That is called the thyroid hormone response element of the target genes. And once it sits there, then it recruits coactivator, which has a histone acetylase activity. It means it will open up the nucleosome and RNA polymerase II will act and the target gene transcription will take. And majority of these target genes like BDNF2, PCP2 and myelin basic proteins are needed for dendritic arborization and neuronal myelination. And what happens in the hypothyroid condition? This TR-TR dimer which sits on the TRE, instead, because there is no T3 attached to it, instead of coactivator, it recruits a co-receptor. And when that co-receptor is, it has a histone deacetylase activity and it will therefore repress the transcription of the genes which are its target. So that is how the dendritic arborization suffers and neuronal myelination also suffers under the condition of hypothyroidism. The concept of neocortical neurogenesis and neuronal migration. The neocortical histogenic sequence is initiated with the generation of neurons in the pseudostratified ventricular epithelium at the margins of the ventricular cavity. Cortex, the earliest formed post-mitotic neurons migrate to the deepest cortical layer and progressively later arising neurons migrate past them to the progressively more superficial layers. Once neurons take up their final position, their number is reduced by apoptotic cell death because all the neurons are not able to make the synaptic connections and those neurons which are not able to make the synaptic connections are removed by apoptotic cell death. So these are the two kinds of the cell, symmetric division and asymmetric division take place when within the cell cycle that one neuron gives rise to the two daughter neurons. And in asymmetric, one neuron gives one neuron and another is a radial and not the dot. So that is called the asymmetric division. The symmetric division is very important for the brain to have its normal function like seeing, hearing, feeling the heat, all those basic bodily functions that you are alive, they are done by the symmetric neurons. So this is the way one can depict the symmetric. It is broken from the middle, and other one take the different components of the DNA in the both the daughter cells. And this is how when the neurons are formed, neuronal stem cells or outer radial glia or basal progenitors are formed, then they move upward. And they move upward and settle in the cortical plate or the marginal zone. That is where the renin is situated. Renin is a molecule which is produced from the Cajal-Ribes cells. And what renin does it gets attached to the receptor, which is an ApoER2 and VLDLR. You can imagine a situation, renin is like a mother sitting on the top and neuron is like climbing a child. So it has to recognize first the first ladder to climb. Then it has to have orientation towards the top. He has to see the mother, really. And that is how, then it has to get cues. Okay, hold the hand, hold the first ladder. So those attachment cues are provided by alpha beta integrins. And then it has to know once it climbs a particular layer, then it has to know now I have to get detached. I have to get disembarked from this. So there is a detachment cues which are provided by DAB1 dephosphorylation. So this is how the migration of the neurons take place. So two important things I told you, neurogenesis. One is the symmetric division and asymmetric division, and second is the neuronal migration. Then I will give you the experimental design because we studied these two phenomena of the neurogenesis as well as neuronal migration, whether the thyroid hormone deficiency exists. So we had the Sprague-Dawley rat model. The day of visualization of spermatozoa in vaginal smear was designated as embryonic day 0. The pregnant rats were divided into 3 groups, namely euthyroid controls, hypothyroid, and hypothyroid dams that were treated with the thyroxine. To induce the hypothyroidism, we use the methimazole in 0.025% in drinking water from embryonic day 6 onward, and T4 replacement dose we used was 1.5 microgram per 100 gram of body. And we collected the fetal cortices, which were collected at embryonic day 14, embryonic day 16, 18, and embryonic day 20. You have to remember here that embryonic day 14, the fetus is totally dependent on the maternal supply. The fetal thyroid start functioning only at the embryonic day 18 or onward. So till all this time, the fetus is totally dependent upon the mother's supply of thyroxine. By 1994-95, it became clear to us that the receptor-mediated effect of non-target genes like PCP2, neurogramine, failed to conclusively decipher the irreversible brain damage, a hallmark of the neurological cretinism, and we realized the need to look into the new paradigms. In a series of publications, we not only showed that the maternal neonatal hypothyroidism enhanced apoptosis during the rat cerebellar development, but also provided evidence for the possible contribution of both the mitochondria and extrinsic signaling. We focused our attention on the effect of the maternal thyroid hormone deficiency on neuronal progenitor fate, the neuronal differentiation and neocortical thickness. The rate of neuronal progenitor proliferation, that is the generation of Ki67 cells. What happens is these are the two commonly used markers. Ki67 is only absent in the G0 phase. It is otherwise present from G1S, G2 and M phases. While the BRDU is a thymidine analog because when it is a part of the DNA. So this is used when the cells are acquiring nucleic acid compound. So these two are the commonly used, and Ki67 negative means cells are in G0 phase, they have crossed the mitotic and they are now ready to get out of the cell cycle. That's why these two are the very important markers we use. And what Vishwamohan was able to show that under hypothyroid condition, there is a thinning of the cortical plate and marginal zone. You can see at the central panel at both embryonic day 16 and 20, and when you give thyroxine, the effect is reversible. You can see in the middle of this thing, the thinning is there and the thinning has gone out on the giving the thyroxine. And same thing you can see for the DCH, DCX and NUN, which goes down on the upper panel of the western blot. They go down and they get reversed by giving the thyroxine. And what this figure shows is a flow cytometry data that upper left-hand corner and right-hand corner you can see the cells which are proliferating, which means they are still within the cell cycle. And Ki67 negative cells means those who are leaving and are ready to migrate. So both these units go down under the hypothyroid condition. So to a large extent, they both go down, and when you give the thyroxine, they again reverse back. And what the student did remarkable was he used the Takahashi mathematical model, in which you can calculate the cell cycle. Between embryonic day 11 and embryonic day 18, body does have 11 cell cycles. And cell cycle length is an important component, and he has used the mathematical equation. What you can see here, that embryonic day 14, both euthyroid and thiamazole treated rats have the same length of the cell cycle. And what he was able to show, that on embryonic day 17.5, there is a difference in the cell length. Cell cycle shrinks in the hypothyroid condition. So this was a remarkable finding which came from our group. And you can see that the proliferation or the symmetric division is very important. That is complete by the embryonic day 14. And that goes down till the embryonic day. So major body needs or brain needs is synthesized in the very early part of the neurogenesis. And in case of hypothyroidism also, this symmetrical component is basically low, but it keeps on increasing toward the end of the E18. But now look, contrary to that on the lower panel show asymmetric division. Asymmetric division increases from embryonic day 14 till embryonic day 18, but in case of hypothyroidism, it also tries to increase, but it is never able to make up. So it is the asymmetric division that suffers and not the symmetric division. And this asymmetric division is very important for learning, memory, and so many of the mental tasks and motor coordination. So it is the asymmetric division that we are able to show. That experiment showed that proliferating, and then there was a question whether these cells have the transporter or not. They are the brain cells, they are growing. If they don't have the MCT transporter or receptor, they won't function. So what Vishwa Mohan did was he measured TR alpha, MCT8 and type 2 diabetes. Found those to be intact. Means they are not the culprit. So it is only the thyroid hormone deficiency that was hampering the asymmetric division. Then next question we ask whether the fetal thyroid function can have adverse consequences for progeny's neurodevelopment. We studied the effect on the cerebral cortex neuronal migration, because once the neurons get out, they have to migrate. We studied the effect on the polarity of the migrating neurons. We addressed the question the maternal thyroid hormone deficiency action involved the renin down regulation, and if so, involvement of the Carl-Wright cells. Is the renin gene regulated by thyroid hormone? So to answer all these questions, the first slide shows you that the radial glia in the central, if you see the hypothyroidism, the density of the radial glia is much less. Compared to euthyroid animals and hypothyroid treated with the T4. Again, the second panel shows that the layer is thinning out, and in case of T4 treated, layer is brought back. But the most important finding is in the last panel. You can see the neurons are able to maintain a polarity for migration. And there's a loss of this polarity. If you go in the middle panel, last slide, the polarity is lost. And this polarity gets restored by giving the thyroxine. So this was another remarkable finding which came from our group, that it is not only the migration suffers because of the newborn neurons lose their clarity, they lose the focus. Then we also measured the Cajal-Wright cells. We thought that probably Cajal-Wright cells are dying because of apoptosis, but that was not the case. So we said that if it is not the case, then is the renin molecule directly controlled by the thyroid hormone? And we found a TRE for the renin, and we reported that TRE, this renin molecule is directly controlled, transcription of renin molecule is directly controlled by the thyroid hormones. So we were able to show, I'm not able to mention each and every site, that we were able to show that the aberrant migration of neuron is a result of the loss of bipolarity of the migrating neuron. This is correctable by the early treatment with thyroxine. Renin gene harbors a negative TRE in the intron 1 by cheap assay. The lipoprotein receptor alpha ER2 and VLDR and renin are reduced under the maternal thyroid hormone condition. Now we will come to the last part, what is the amelioration. As I showed you in the first slide, what happens under the hypothyroid conditions is this TR-TR dimer co-recruits a co-receptor. And then in turn it has the histone deacetylase activity. And that's why the transcription of the target genes is not able to possible. Then we hypothesize, is it possible to de-repress this repression? Can we find a molecule to remove this repression, which is caused by the absence of the thyroid hormone? Then to our, we found that valproic acid, which is used normally for epileptic patients, is a very good inhibitor of the histone deacetylase activity. So we decided to use histone valproic acid in the hypothyroidism. And the results, you will find that both histone acetylase activity is restored back. You can find MBP, that is myelin basic protein, and BDNF, both are restored back in the group, which hypothyroid group, given valproic acid. Cerebellar development that is late in the life. And see the dendritic arborization, which has gone down under the hypothyroid condition, is restored back by giving these animals valproic acid. And not only that, they were able to get their neurobehavioral functions like by-Mace test, grip strength, as well as stay on the rotor rod. So using valpate and HDAC inhibitor, we show that the HDAC inhibition significantly blocks the deleterious effect of hypothyroidism on rat cerebellum, which is evident by the recovery of TH target genes as well as improved dendritic structure of the cerebellar Purkinje cells. Together with this, HDAC inhibition also rescues the hypothyroidism-induced motor and cognitive defects. This study therefore provides an insight into the role of HDACs in the thyroid hormone insufficiency during neurodevelopment and their inhibition as a possible therapeutic modality. I'm just saying possible, and this is what happens. This is graphically shown. In the last panel, you can see if VPS sits on the HDAC, and the repression goes off, and the transcription of the target gene gets restored. Thank you very much for your very kind attention.
Thank you, Dr. Godbole, and I think you have shown a great deal of work and a lot of experimental model where you have really shown that thyroid hormone is responsible for the neurogenesis and also neuronal migration. And iodine deficiency producing both defects in the neurogenesis, neuronal length, and also in the migration. And you have also showed how thyroid hormone receptor responsiveness is responsible for ameliorating those effects. And you have given us the clue that but you said the very beautiful word, early replacement. The early replacement of thyroid hormone can definitely take care of that and reverse it, and also give insight to a new drug we use it every day for the epilepsy, but the valproate use as an ameliorating agent is something very new and to be taken further forward. Thank you very much for a very learning and great lecture. Thank you, Dr. Godbole.
Now we now move on to Dr. Baldev Singh academic oration, which was instituted to commemorate the outstanding contributions of Dr. Baldev Singh to clinical neurosciences, who was a founder fellow of the Academy and professor of neurology at AIMS, New Delhi. The orator must have made the original published research work contribution to the practice of neurology or any of its branches, must be a recognized leader in the practice of any branch of neurology, and shall have achieved professional excellence through the clinical research and demonstrable impact on the health outcomes. And we have none other than Professor Dr. K.K. Deepak. Welcome, sir, to for the oration. You all know Professor K.K. Deepak. He is currently a visiting professor at CBME IIT Delhi, and earlier he has headed the Department of Physiology and was a Dean of Exams at All India Institute of Medical Sciences. And he set up the first autonomic function test lab in India and vascular function lab, and he has initiated clinical physiology in the country and set up several autonomic function test labs in the country. And he has more than 200 peer-reviewed research papers, 4,000 citation, H-index of 34, and he is inventor of the gravitational loading body gear and co-inventor for another 6 patents. Thank you, Dr. K.K. Deepak. Over to you for your oration on establishing autonomic function testing in India. I think a lifetime work, difficult to concise in 20 minutes, but I am sure you'll do, as you already, you are accomplished speaker. Thank you.
Thank you, Dr. Piyush, and thank you, Dr. Ashok. I'm very happy to be here. Thank you, NAMS, for giving me this Ocean Award. So I'm going to talk about in next 20 minutes about what we have done in the field of autonomic function testing in the country. So, so my gratitude to grandfather Neuron, and who joined Department of Physiology AIMS after the retirement, 65 to 67, and what you see Neurosciences Center is a result of his efforts. And then later he joined Department of Physiology till he was there. So during 1982 to 92, I happened to interact with Dr. Baldev Singh and have very great memories of Dr. Baldev Singh. In the evening, Dr. Baldev Singh and Dr. G.S. Jinnah and Dr. Bajaj would normally meet 6 to 8 in the evening in the Department of Physiology. And that was a great occasion when these great stalwarts would talk. So occasionally Dr. Buchanan would come. So that was the Department of Physiology, and we had a lot of, I still hold several personal letters written to me by Dr. Baldev Singh. So some other point of time I can share those. So what we did, I got inspired by the then Dr. M.C. Maheshwari and Dr. Baldev Singh, both neurologists, who were walking to physiology department and were talking about, once listening to Dr. Manchanda's, Dr. Maheshwari's talk, that we have nothing to do to test autonomic function, and that the sentence clicked me, and then quickly I went to Dr. Baldev Singh that we want to do that, and then I thought, so that is the time we started. We started in 1989. We started clinical testing, research, capacity building, technology development, and database development. We have accomplished all, and next week I'm going to AIMS Devgarh to set up another autonomic function lab right over here, so that we keep on doing so, and we have gone. So in 20 minutes or less than that, I'm going to talk about the need, the technology, the clinical evidence of autonomic function testing, and new applications in clinical scenario. As you know, autonomic function symptoms are very, very important and very intriguing, very difficult, starting from psychiatry to dermatology, to gynae to cardiology, anywhere you go, symptoms. The knowledge of organ function can explain the symptoms, unknown symptoms sometimes, and that's what happens across the departments. So it's very useful, there's no doubt. And what is AFT adds to the routine investigation? It establishes the diagnosis, the loss of ANS. It excludes CNS etiology when results are deranged, and it predicts. It predicts the sudden cardiac death, whether because of epilepsy, SUDEP, or infant SIDS, or even an MI. So this is how, and several things is what it's known that it should be monitored, and this has already been published at several places. And AFT can provide answers to the following question: where is the lesion located in neuraxis? Which particular branch is affected? Sympathetic, parasympathetic, peripheral nervous system, central nervous system. Make a differential diagnosis, starting from beriberi leading to peripheral neuropathy to the central multisystem atrophy, or the further workup is required to differentiate multisystem atrophy from Parkinsonism and non-Parkinson MSA type. You can do that, and that we have published work on that, and in management HR. So it's a promising, cost-effective, reliable tool. And then if you go to the literature, you'll find enormous indications which actually try to define how you can do a differential diagnosis. I give you some example of POTS, like paroxysmal orthostatic tachycardia syndrome, which we studied and then reported. And there are several other examples which can be done. Now, how to quantify? Simple method, direct. You measure direct catecholamines, or based on a microneurography, you put 20 micron tungsten electrode on sympathetic C fibers, and you would know sympathetic output. This is a direct method. Indirectly, you give a task and try to find out how autonomic system is responding. It could be a short task you can give, muscle exercise, head up tilt, or some other, it can be done, or even at rest baseline recording of HRV, heart rate variability, gives you a window to sympathetic and parasympathetic control into the myocardium or the vasculature, depending. And so all these can be used to modulate ANS. That's a new thing, that if you know how to record autonomic nervous system, the same system can be used to modulate it. For example, isometric exercise. By this you can change autonomic response, but if you perform autonomic, by this you can raise your blood pressure, and that's what we have shown, that they can also be used as a biofeedback, as a modulator of auto. So this is a new thing which we have been bringing to ANS studies. The technology, we have gone through all technology and then collected this or created one. And so sympathetic, we have several tests like partial challenge test, cold pressure, hand grip, sweat response. Parasympathetic partial challenge test by recording heart rate, deep breathing, recording heart rate, and Valsalva maneuver. And there are several more. So we have gone through this full battery. The first time, when we started 89, nothing existed. We went to the literature and standards, make all standard our own. Then we developed our own HRV software and hardware in the country, right over here next across the building. And then we did blood flow measurement because we knew end organ dysfunction could be there. Vessels is one of the effector organ. Heart is one. Sweat is, so unless you measure the end organ dysfunction, it becomes very important. So that we did by this, and then quantify bioflex sensitivity. Difficult task, like how do I know what is my carotid response sensitive, and that we quantified by using both heart rate responses and vascular responses. Then we developed electrogastrography and gave idea to the industry, and our industry is making the one. Brain blood flow, impedance cardiography, cardiac output, developed and our own devices, and they are available. And now look at here, when we started 89, no people were talking about, although it was very important. Harrison only in 19th edition now talks about the indications of these tests which I have enumerated. And now it is a full-blown chapter on autonomic testing and autonomic disorders. So this is what is. Now, if you do technology assessment, how difficult or how easy it is, considering the country is a vast country having 650 medical colleges, do they afford? So we always say, yes, if you have a desire, you can afford it. So here are the list of testicles with the difficulty level, 1 minimum and 5 upper limit. And so there are some tests like MSNA, difficult to perform until you have a very high level of recording. Otherwise, most of the tests are doable if you have a ECG machine and if you have a continuous BP monitor or even a simple blood pressure monitor, you can do that. So therefore, this is what is doable. There are several other tests like pseudomotor function test, so like CN Center, we have a machine, we of QSART, we use it. SSR can be easily performed, anybody who's having EMG machine. So only a knowledge is required. So sympathetic skin response can be obtained by giving a stimulus and then you record it. Pupil function, we did several studies with RP Center with ophthalmological sciences, and then we documented the autonomic involvement of eye in several cases, including diabetic or central serous retinopathy. Our work on CSR, central serous retinopathy, is very well cited, conducted with Dr. Agarwal and others. And then GI, gastrointestinal GI physiology. We knew when GI is many controlled by irritable bowel syndrome, and Dr. Makharia is sitting here. We did a lot of work with Dr. Govind Makharia, Dr. MP Sharma, and ulcerative colitis, and then documented various. We also went to the intervention also, anal incontinence biofeedback with GI surgery. So this is have been our story. So once you know what to do, how to do, and do, you can generate a new test. No, it's not difficult. Interpretation, as an expert, you should be able to do that. And that's what we did. So our story lies, 87 we just thought, we just joined as a faculty member. In 89 we set up first lab. Now by 94 it was full-blown routine clinical lab. Patients were referred from neuro, endo, GI, and then routine referral, currently it's going on. And then we have multiplied this to several places in the country. And so our major contribution, we provided clinicians a definitive value of autonomic value, loss. Second, we provided consultation, whether it's a private ward patient or an OT or anywhere, whenever there was a loss, unexplained partial hypotension or something in anesthesia, we were there. Insight into the intervention and management, and that's what. So this is the pre-COVID picture. I think we have large data in our labs. A pre-COVID picture, something 1136, and this is a patient done in a year. Imagine we have 800, we have 20 working days. So every day we are doing, by the time I'm here, two or three patients have already been tested in the lab. And this is 22 for two slump, we come back, so 990 patient in a year. And this is again, now we have a huge database, 21,937 data. It's more than that, available across the world. And this is the world's largest database available, well structured. A lot of it is digitized. It all and it's large number of classification is available. So this is what is a gain that we have done that, and we have achieved it. Now, what we have done? We have done 4 levels of research. Level 1, developing test. Level 2, physiological responses. Level 3, physiological insult like bleeding or and then several diseases. This is the list of diseases which we have reported, published literature on this. It's a large number of diseases which you will find all literature published, and there are various departments like disease and the publication wise. So large disease, 36 is only a listing for last 4-5 years before, but then it's all has been published. Several departments we have collaborated, not only medical sciences department, but also we've gone to engineering side because we wanted to develop our own devices to do this kind of a testing. So it's a large collaboration which we have done across the board wherever is autonomic nervous system is involved. And now we also shown when we started the day one, the question, so what if there's a loss? What will you do? We said, no, let's look for. So reversibility of autonomic loss, we reported right over here. It's not that threatening that you got a loss. The body has a mechanism, and the important case we reported, lead poisoning. The case was referred from the GI with an unexplained huge loss. The patient, young patient, was not able to stand. Huge fall in blood pressure. And so that we reported is 25 years old. Imagine person is not able to do it. It was a lead poisoning for some known reason. This patient, this has been reported, and we reported that within 6 weeks, if you do chelation lead, it becomes normal. And look at these pictures. Day one, huge loss of autonomic control, sympathetic, parasympathetic, there's a poverty. And then within 6 weeks, and then we followed it up, and normal it becomes. Similar case was reported, arsenic poison, referred to us from medicine department. And so this is what normal pictures comes up. So can you modify it? Reversibility by chelation, natural. So we also proven that the recent case report which we have published, very unique, and an autonomic dysfunction in post-operative primitive neuroectodermal tumor of heart. The lady having 20 times fall in a day, 10 fall. And patient was said, what to do with this? So what we gave, we showed her that, look at, this is your fall. Can you do something? And we showed if she contracts some muscle like this, she can raise by 20. And that was enough to prevent fall. And that's a simple learning, physical maneuvering, modifiability, that you can change your heart rate and blood pressure to upside the moment you have to do it. And that's what clearly shown in this graph. So it serves as a visual pressure biofeedback and doable. Anybody can do it. You change, you use a heart rate or autonomic or HRV, and this is what other biofeedback we published, like EMG biofeedback for hand dystonia, EG biofeedback for irritable bowel syndrome, sensimotor rhythm biofeedback, anal pressure biofeedback. So this is what, so what culminated, so that 30 years work. Last in month of January, we were able to inaugurate biofeedback clinic. It will go into the physiology department, look into anything, the biological signal which can be shown will be able to help patient. And you can use n number of anal incontinence or vaginal incontinence or cardiovascular disorders, or I wish I gave you several examples from neurology department. And autonomic dominant cerebral ataxia, we started long back on a day one, and we still continue working and publishing in this field. A large number of publication has been done in cerebral ataxia, and I'm not going to details. We showed the lateral inclination or hemisphericity by using the model of cerebral ataxia. It's going to affect left and right, and how do we know? And so there is a laterality in autonomous nervous system. This is the concept we said. It's not only we have a right and left, but even autonomic nervous system has a laterality, and there are several evidences which we put forward from right, left nostril breathing or spinocerebral ataxia or some other kind of. And this, we used AI kind of a structure, not exactly AI, but machine learning tools to classify cerebral ataxia. And we were successful classifying 80 to 70% by using different type of support vector machine or discriminant analysis. We also published our own norms and method of scoring, because we found the Western scoring was inclined towards totality, but we divided it into this pattern and prevalence has been published. So we have our own scale to classify. Now that resulted into capacity building and technology development. So what evidence we have? So we used our IIT help and then develop our own software for HRV called HRV Soft and blood pressure soft, BPV Soft. And we gave it to 6 or 7 places in the country, north and south. We got external validation, and then we developed CHRV. So anybody can type this, https secured chrv.dic.gov.in, Government of India, digitally. So this is the software available. If you have ECG file, ECG data in any form, upload it, you'll get HRV result, and you can know autonomic tone. So this is our own software. We developed several hardwares supporting autonomic, our own blood pressure device with IIT Delhi, and several impedance plethysmography, and they're all to modify it. Our own blood pressure device with the help of IIT, the part of theoretical part is published, tonometry based device. So this is the manpower development, more than 100 theses, 120 or so, and nearly 200 publication in the field. They're all available. You can visit kkdeepak.com. So I have kept those old publications over there. Now, what is the agenda for future? There should be an agenda, and we have an agenda. So this is what we met last January. and NAMS invited me because of my superannuation, but I give you the task. Why don't you make a consortium, make autonomic network, which can provide you consultation. Many patients, they go to the Google and type it, I have autonomic loss, what should I do? They land up in New York website because there's a dysautonomia international. They give me a call, why don't you go to Dr. Deepa or AFT lab? But since the information is not available, so that's what we're going to do. We also met last fortnight. I told one of the young guys, there was 10 of them, they are listed here, different aims and other places. Why don't you create Indian normative data, a prospective? We have a huge data, 21,000. You take this a historical database, but let's create our own for the wide country. And so we are doing it. So this is the agenda. And also take the CHRV forward. It's a free software available, far better than any software I can claim because it's all international standard we looked into, and one can do it and can use it. So it's a joint work of Physiology Department and DIC, which is the government of India. So this can be taken. So now I'm trying to create sustainability. We have done it, but somebody should take it for decades together. And so we have gone to the vascular, yoga and space physiology, and we have set up all these labs. All labs are available in the Physiology Department as of now. AFT, vascular, GI, space physiology, and biofeedback clinic. But what next? Still have 1 minute, I can talk about lower body negative pressure, lower body positive pressure are powerful manipulator of your central blood volume. And by this simple device, which is used by athletes, cricketers, can also be used in physiology to modify. Also a centrifuge, short arm centrifuge by which you rotate a person, you can change blood flow to periphery. And wonderful result has been shown not by us but others. We need to do that if you have a PVD and if you do a slow rotation in a rotatory device, you can change the blood flow. And that will, like slow rotatory device, you put a person. Also like peripheral vascular disease by a gravitational. So it's a gravitational therapy which can be brought very easy. Let's make one. It's not difficult. We know this thing can be easily done. Or low body positive pressure. The suit I'm wearing, we have shown that by if I wear a suit, I change to a suit, I can see my performance. So I'm sitting on a chair, I've gone down now, I can do it. Or a policeman can use and avoid peripheral vascular diseases. This is the paper published yesterday. We're proud of this paper. Look at the title. Vasoconstriction during non-hypotensive hypovolemia is not associated with the activation of baroflex, a causality-based approach. By using an engineering analysis approach, we are showing how low volume changes, which happen every day, now happening, sitting for a long time, or when you're giving a blood donation, or you're changing, but your attention or something is, what is the mechanism? The low volume receptors in the lung. So, and this is the mechanism. This paper came yesterday only. So this has been a team since 1990 onward, and a huge manpower which has been generated across the country. Most of them, some of them are faculty member across aims, different aims. So I'm very thankful for this, and the large number of collaborators. This is the list of non-aims collaborator, not from aims, but from other departments also, which includes large number of people, not from physiology department, sorry to say. This list is not from physiology department, which is my parent department, but across the AIMS department and IITs. So with that, I come to end. Thank you so much.
Professor Deepak, thank you very, very much. You know, it's a revealing study. You know, being in India, where we talk about mind-body medicine, where we talk about the finer aspects of health, spirituality, and automatism. This is a very important branch of medicine. And we are very happy that you have taken to newer heights. I remember, Deepak, when you came to Chipmunk, and the visiting professor. And I know it was great. Thank you very much. Yes, ready? Yes, sir, coming. Yes. Dear friends, we'll move on to the next lecture, which is named after Ashanta Lakshmipati Academic Oration. This was established in 1973 and is given for a subject published on a published research work which has relevance to maternal and child health and women's health and community medicine. And this year recipient, please put your hands together to welcome Dr. Shilpa Sharma, who is going to talk to us on a very important topic. And Madam is also present here. Shilpa Sharma is MCH and PhD stem cells therapy, ISTP in UK, the specialist therapy, Professor of Pediatric Surgery at the AIMS New Delhi, and but ardent academician for last 26 years, 2 books, 120 publications, and you know the list is endless. But I must tell you that she has been keeping the flag high in the pediatric surgery and contributed immensely on the patient care and research in this particular field. Today, is to speak to us on a very important topic: the gender assignment and the hormonal treatment for the disorders of sexual differentiation. Very specialized topic. Over to Dr. Shilpa.
Thank you very much, sir, for your kind words. Respected chairmen, senior and colleagues here. I'll be talking to you about gender assignment and hormonal treatment. At the outset, I'm really grateful to National Academy of Medical Sciences for this opportunity and honor. DSD, the terminology which you may have heard is intersex or ambiguous genitalia, but there was a stigma associated with this terminology, and of late the terminology is now DSD, that is disorders of sexual differentiation. Now why call it a disorder? So the latest is differences in sexual development. Think of a child from his point of view if he has this condition. From the second that I was born, there were many doctors who were deciding which out of the two genders would I fit in. And all this was done without my consent. So this gives an insight into what the child with this condition can go through. Sexual identity is very important and an issue of mental health. Various groups have got together to show their identity. Of these, for us, DSD or intersex is important because it's congenital in origin. We have to help the child to develop an identity and make him fit into either of the two genders, which is very possible with appropriate treatment. The objectives of my talk would be to take you through the introduction, classification, clinical features, gender assignment, and hormonal treatment of this condition. As we all know, we all have a unipotential gonad that can go into a binary pathway of differentiation. All this is based on the SRY gene, which is present on the Y chromosome that leads to the male sex development. Now, what is DSD? DSD is just a congenital anomaly associated with atypical development of the internal and the external genitalia. It may be due to chromosomal, gonadal, and anatomical abnormalities. The most common cause are enzymatic deficiencies and mutations. Various tools have now come up, like the NGS, next generation sequencing, where we can identify the genetic variants. But does it matter to the patient? No. He's just concerned about his identity and how he's going to live in this society. So the nomenclature has now tried to avoid the word hermaphrodite. We now call them as per 46XX DSD, 46XY DSD, ovotesticular DSD, and sex chromosome DSD. These four are the most common types that we encounter. There's a huge list of classification with the various subtypes. The most important ones are 46XX DSD and 46XY DSD. Out of the 46XX DSD, the most common is the congenital adrenal hyperplasia, in which there is a girl child which may look like a boy at birth, but with appropriate hormonal supplementation, that girl can be raised adequately to her original identity. So when a child is born, the first question that we all ask, is it a boy or a girl? And this may be ambiguous in certain conditions like undescended testes, proximal hypospadias, or there may be some edema which may be there due to the breech presentation. It may be apparent that we cannot make out that it's a girl or a boy. In that case, we should just leave it for adequate assignment, and the parents can just say child and not refer to that as a girl or a boy. So this picture shows you the clinical presentation. As you can see, it's a spectrum. So even if we have our chromosomes like a girl, 46XX, at the extreme right, you can see that the genitalia is like a boy. Now this may be assigned a gender of a boy if they present late, because the mental makeup has already become like that. On the other hand, even if a child has a 46XY DSD, the extreme left variant, which you can see looks just like a girl, and that boy may be assigned a girl child. And there's nothing wrong in that. We just have to carry on with whatever is assigned and how the child is behaving to that. There are other conditions where either a boy or a male gender may be assigned. Now, who does this gender assignment? It is done at various levels. Whoever meets the child first, the nurse, the gynecologist, the neonatologist, these are there in the labor room. And then the parents. You may have home deliveries where the parents have to decide and tell their society whether they've given birth to a boy or a girl. And finally, they may be wise enough to reach a pediatric surgeon and try and find out an everyday diagnosis. We are happy that now people are more aware and reaching us sooner. Earlier, there was this Hijra community, which you all must have known, being in India, who take away such a child and do not ever let them get labeled as either a boy or a girl. So multidisciplinary team is involved in the diagnosis and management of these patients. The most important thing for gender assignment is that the patients and the parents, mainly the parents, should accept the child. We have had a child who had an abnormality and the parents had tried to leave the child in the hospital and run away. They were trying to abandon the child. And later on, we had to force them, call the police and tell them, this is your child, you have to take care. They handed over the child to the Hijra community. The Hijra community gave it to the NGO, and the NGO brought the child back to us for treatment. So India is changing, and we should all encourage such things, but we cannot help such parents who have lack of knowledge. So the diagnosis is based on clinical examination, chromosome analysis. Radiology helps us to a great deal with ultrasound and imaging, hormonal evaluation, and now we have laparoscopy where we can just put in an instrument in the abdomen and see how the gonads look like if need be. All this assignment should be done before the child goes to school. Why? Because the child has to wear a uniform, a boy or a girl. Imagine a boy who cannot stand to pass urine and he's given a boy's uniform. He has to sit and void his urine. He will not go to the toilet because there is a urinal there in the boys' toilet. So children go through this trauma and we have to help them come out of it well in time. We had one child with complete androgen insensitivity syndrome that is the extreme left of the XY spectrum, who was raised as a girl, but the mental makeup was of a boy. His gonads were not removed in time. And so he was just like a boy. He did not accept it. He used to feel shy wearing a skirt and going to school. Ultimately, the child committed suicide. And that's a take-home message that these children need to be identified. If there's any gender dysphoria, the parents should not hide these problems. Now, how to assign the gender? We look at the sex of rearing, the size of the phallus, the internal gonads. These are the most important thing is the mental makeup of the child and the parents, what they think about it. Chromosomes do not matter. So here you can see this, whether it's a 46XX, XY, or DSD, or ovotesticular, we can make them a boy or a girl, depending on the various other factors which come into play. Though, most of the time in 46XX, as we know, it's a female with congenital adrenal hyperplasia. If they are diagnosed well in time, a female gender is worldwide acceptable. These girls can grow up, lead a normal life, be fertile, and we've also had 9 patients who have given birth to kids, and they're living happily in their married life. On the other spectrum, we have 46XY, who should be reared as a boy. And in India, as you know, it's easier for parents to accept an infertile boy who will be bringing them food to eat, rather than accept a girl who has infertility. But times are changing. There are conditions where parents now accept it. Yes, she will not have kids because IVF is there and adoption there to a large extent. So gender inclination surgery has to be done after the gender assignment, and we do genitoplasty for these. For 46XY DSD, we do a male genitoplasty. For congenital adrenal hyperplasia, we do a female genitoplasty. And for true hermaphrodites or ovotesticular DSD, we may assign them to either side. Most of them, however, are kept as boys in our setup. In 2014, the Indian Supreme Court did adapt the Hijra transgender as a third identity, but it does not help us in our situations because we need to put them either ways because these are congenital anomalies for us. So over the last 20 years, we have seen around 554 patients. Most of these have been a male gender, 333 of them, and 191 were a female gender. This is the clinical spectrum that we have come across. So now my next half of the presentation will be just pictorial depiction because whatever you can see, only that you can believe. So if there's a good phallus, a male genitoplasty is very much feasible, which may be done in stages. If the growth is not adequate, we may give local testosterone application to these children so that the phallic size can increase in length and girth, and we can offer a good urethroplasty. This child is actually a XY, both the gonads are there. But you can see the phallic growth is very small. He will never be able to fulfill potency if ever he gets married. So they are better carried off as girls. and they become very beautiful girls. We have many such patients in our follow-up. This is the child that I was telling you about who came to us late and with a gender orientation of a boy. In partial androgen insensitivity syndrome, depending on the phallic growth, we can assign either a male or a female gender, but it has to be done well in time. If the gonads remain there for a longer time and they have some testicular tissue which is secreting testosterone, the male imprinting becomes stronger. So this child can easily be made a female because the vagina is already there and they can have a normal married life, though they will never be fertile, which the parents have to be told well in advance that this will be there, but they all accept this now. For making a vagina, we use a Barrow's flap. Rarely do we need to do a vaginoplasty with bowel. So here you can see the main step is to reduce the size of the clitoris because that is the main thing which is visible to the parents and the society, especially in Indian children who live in villages. And the second step is then to create a vagina, which we will need at the time of having menstruation or for married life. So this can be done in one stage if the child has a very shallow vagina which can be brought out to the surface, or it may be done later on in life at puberty. So these are some pictures. Here you can see an ovotesticular DSD. The phallic growth is good. Here we identify clinically with the triangular phallus. The gonad may be palpable for having both the ovarian and the testicular component. The internal ambiguity is there and these ovotestids should be removed. We can keep them maximum till puberty if some hormonal supplementation is needed for bone growth. Otherwise they should be removed. Otherwise they undergo malignancy. The hormonal replacement starts as soon as the child is born in congenital adrenal hyperplasia. For others, it may wait. For male 46XY, we may apply local testosterone, but when they cross puberty line and they have adequate height, we give them supplementation with injection testosterone 50 mg or 100 mg per month, once per month. For female sexual characters, the androgen insensitivity syndrome do not need much supplements. They do very well because they do not have the testosterone in their body and they develop very good sexual characters, but we can give them supplementary estrogen for growth if needed. Those who have a uterus can be given estrogen and progesterone, and they also have anovulatory cycles. For male genitoplasty, if they do not have the gonad, we give testicular prosthesis which can be placed in the labial folds well in time. Biopsy should also be done if the gonad is to be left there outside because it has a malignant potential even if left outside. So the child should be told that you have to watch. It's better to remove it and put a prosthesis if there is any doubt. Now these children is not just a one-time surgery. They need lifelong emotional and psychosocial support because you are like a caregiver to them, a second parent to them. They may tell you things which they do not tell their parents, which they discover themselves at puberty. So a good rapport is very important in these patients, especially to identify the dysphoria. So this child was reared as a female, but he had a very strong male gender orientation. So these children may need to be called again and again, give them 1 hour separately away from the parents to know what they're going, and then give them the appropriate gender that they orient with. Long urethroplasties are done for these patients. Prostheses which we make in the workshop at AIMS, these are engineered by Professor Gupta, and these are very low cost compared to the prostheses available in the market. Now, some patients in India come late. So you may have actually a 46XX CAH coming late, reared as boy, already reached age 15, 16, and going up with the family. They do have a short stature, but they identify as males and we have to help them that way. In girls, you may have menstrual issues because they're on long-term steroids. They may develop PCOD, hypothyroidism, diabetes, and they may also have some masculine voice which may need training for them to speak with. We had gender dysphoria in 2 such girls. We evaluated our cases in 2006 and we had good outcome. We evaluated the clitoroplasty results with only 3 of them needing a redo, 1 for an enlarged clitoris. And we also assessed the vaginoplasty results for children, 15 children who had crossed the puberty line. Long-term results were quite good. In boys, they have problem with the facial hair growth, especially when the partial androgen insensitivity syndrome. We are recently trying minoxidil for them, though no one has agreed to do a hair transplant for them, but someday we may find an answer to that as well. With the long urethroplasty, we may have problems with beaded urethra pouches, which may need follow-up surgeries to be done so that they can have no problem. This was the tumor that I was telling you about. We had 2 such patients who came late with undescended gonad and a tumor inside. Gender assignment in CAH. So as you can see, it's a spectrum. For 9 of these, we assigned a male gender. So this child, you can even have a complete male urethra, the urethra reaching the tip of the glans. You will never even guess that this can be a girl. Only on doing the 17-alpha-hydroxyprogesterone, you will realize that it is actually a female child. So this boy is leading a life very well, though he has a short stature. We did body correction for them and we removed the uterus and the ovaries from them. So these two children I would like to talk about, because as we see these patients continuously, and as I told you, you have to maintain a rapport with them. We had two such children who at adulthood realized that no, they are actually girls. So they had a gender disparity. And to such an extent that if we said, no, now you have settled in your life, carry on, they were even saying we will go and do suicide. So for 2 years counseling with psychiatrists, both of them left their houses just because they want to be what they are. Even one of them lied that his father has died and said, just do whatever you can for me. But later on, we had to find out that his father is still alive, take their video consent, because such things are not easy to do. So imagine this boy born as a boy, brought up in the family with pagdi mundan, carrying on the shop of his father, the bread earner of the family. And then he had this disparity. We had done complete male urethroplasty for him. Nobody can say that he has a 46XX. All his gonads were removed, uterus was removed, and then he had this gender dysphoria. We had to go by him, and we did gender reversal surgery for him at the age of 32. He was accepted in the family. We found a match also for him with another intersex patient from Calcutta, from another colleague. A very gratifying outcome. She became really beautiful. We also gave her implants, stylistic implants, Dr. Anurag Srivastav had put up for her, and she was leading a very nice life till last year when she had COVID and she had liver failure because of the hormones, which we lost her. Another such child, as you can see, the boy is there sitting with the mother with the mustache and beard, but internally he is a female, and we have to take out the beautiful girl out of her by giving adequate treatment. So for her also we have done a gender reversal. Still not put the stylistic implants, and she's after us to do that, but we want her to adjust well in society, carry on with life with long hair, because their voice is masculine, so they have to learn how to adjust that voice. And these patients are poor, they have no money, so sometimes she doesn't have money to buy medicines which we have to provide her. So she stops taking her Premarin, and that's a problem. To summarize, patient management in DSD is individualized, especially for decisions related to gender assignment, surgical interventions, and hormonal therapy. Thank you all for patient listening. I'm really grateful to my mentors, Professor Gupta, Professor M. Badki, who was a teacher of Professor Gupta, who started this intersex clinic in NAMS in 1980, and we are all learning because of that. Late Professor A.C. Amini, who was an endocrinologist. I really miss her because I used to talk to her just on the phone for any patients, and all my patients with their lifelong trust. Thank you so much. Thank you, ma'am, Professor Churamani. Thank you, ma'am.
Thank you, Dr. Silpa, for a very, I should put it as one of the most interesting and scholarly, unusual talk. And you have so much wealth of information to give. It's difficult to summarize, but I must tell you the amount of effort and the physico-psychosocial adjustment you have tried to do for these patients is great. Thank you very much. You should continue good work, and it's our great honor and pleasure to listen to you. And great, it was a great.
I just
talk.
like that sentence, and that sexuality is primarily in the mind,
Yes,
not
sir.
in the X or Y.
Yes, sir.
Thank you. Thank you so
Thank you.
much.
I think these orations have been masterly and scholarly and absolutely great. Dear friends, please bear with us for the next two lectures. And the one now we are going to call now is named after Dr. J.S. Bajaj. Dr. Bajaj's oration was instituted in 2015 to commemorate the exemplary published research work by Professor Jasbir Singh Bajaj in the area of diabetes mellitus. It is given to one who has done outstanding published research work in this specialty related to type 2 diabetes mellitus or its vascular complications, etiology, pathogenesis. And dear friends, the orator for this year is no other than Dr. Giriraj Chandak. We are friends, I've been following him. I must tell you that his contribution has been great in the field of genomics of type 2 diabetes, fibrocalculous pancreatic diabetes, new genes he has found out, and he has also found the relationship between the gene and the nutrition. So much so that he has put many things which have revolutionized the field of the genes, nutrition, or say environment, and the developmental origin of the metabolic diseases. So that's why he has called this lecture triumvirate: genetics, environment, and the developmental origin, the Barker hypothesis. I have no time, but Giri, over to you for your scholarly oration. Thank you. Little louder will be better.
Oh, okay, sorry. So thanks, Chairs, for nice introduction, and I hope I can do justice to whatever they have said till now. So friends, the title of my talk is Triumvirate of Non-Communicable Diseases, much better explained by the chair than probably by me. And I really feel privileged to receive this award and presenting in this auditorium, which actually has Professor J.S. Bajaj's name as well. So I want you all to relax because since morning we have been listening to diverse topics. So as it goes for any award lecture, I would say that don't look at anything in a physics lab. That's the rule. Don't taste anything in a chemistry lab. Don't smell anything in a biology lab, and don't touch anything in a medical lab. So friends, my disclaimer is that please don't try to in an oration lecture. What I'm going to do is to describe my 2 or 2.5 decades journey. It's not easy for a medical professional, at least at that time when I was moving from one area to another, but I'm really thankful to my mentors, my collaborators, which fortunately I have had large number. So it was about 4 decades back that I graduated as an MBBS guy from, RGKar Medical College. And then at that point of time, I was running from bed to bed, and then I decided to move around from bed to bench and then try to see ultimately that whether the work that we do during this time, can it be brought back to the bed. I paid a very big price for that because I ended up as a clinician who has forgotten the basics. I became a confused geneticist because you know that genetics is not everything as we realize now, and I will try to convince you about that. I became half-cooked epidemiologist because you realize that in order to make anything beneficial for the society, need to have a knowledge of epidemiology. Probably I'm an epigeneticist in making, still understanding that. And last but not the least, a public health expert. So I start with the knowledge that we had as MBBS student. I'm sure everybody was taught this. All diseases are genetic, and it was a simple cartoon that explains that if you have a gene, you have a mutation, you have a change, you have a specific inheritance pattern, and the disease is straightforward. You have the mutation, you have the disease. You don't have mutation, you are normal. This was a pretty simple thing, which indicated that if you are born with a particular phenotype or a clinical problem, that is because of your gene. So the genotype determines the phenotype. And this was something which I started working on sickle cell anemia. I'm sure the audience is wise enough to remember this, that this is the first global monogenic disorder, which is because of one single mutation all across the world. And that's when we had participated in a CSR sickle cell anemia mission, which continues. What it told me that despite there being a single mutation and going by the hypothesis of genotype determining the phenotype, there were still differences in sickle cell anemia. Large number of differences, I don't want to go into that, but suffice it to say that the patients with the same mutation can present early, can have very severe course, or can have early death as well. Similarly, the only drug, hydroxyurea, even the patients can have different response to hydroxyurea therapy. And this actually challenged the thought that if the genotype decides what the phenotype should be, clearly these were not the right kind of examples. And at that time, I actually fell ill, not because of this cross thought, but I just felt ecstatic that I went to a clinic for getting my peptic ulcer problem diagnosed. And this is a report which made me ecstatic. Can anyone feel ecstatic about it? No. But then I was ecstatic because I came in touch with two crazy clinicians, Dr. Nageshwar Reddy and Dr. G.V. Rao. Both of them were running like, I can't tell you, their clinics would run from 6 o'clock in the morning till night, 12 o'clock. I came in touch with them, and here I was a crazy pseudo clinician, mostly trying to spend time by various entertainments. But then we came together and we looked at a disease which was tropical calcific pancreatitis. Govind is here, I can't speak much in front of him. Suffice it to say that this disease had a very different phenotype, and with this specific hypothesis, we started looking at if there is a different clinical phenotype, is there a different genotype as well? And to cut a long story short, we identified two novel genes, we found out various different mechanisms, we found mutational heterogeneity, and we proposed that genetic basis of pancreatitis is different in Indians. And that was only one gene we identified at that point of time. But then over a period of last 2 decades with close to 20 odd publications, now we know that tropical calcific pancreatitis is a genetic disease. It's not a nutritional problem, and it needs an interaction between genetics and nutrition for the disease to happen. And hence, this now entered into the online Mendelian inheritance in man, which means that tropical calcific pancreatitis was considered as a genetic disease. We have found many mutations and others, but now this test, which is a SPINK1 genetic test, is exclusively performed for tropical calcific pancreatitis, not for any other type. So the point I'm trying to make is that although it is clear that the type determines the phenotype, yet there are many other factors. There can be gene-gene interaction as shown in the top panel, and because of this interaction, the inheritance pattern is likely to be different, and then there is a big interaction with environment which influences the final phenotype of every individual. So I and you, despite having the same genetic constitution, may not develop the disease. And that's why the simple principle of monogenic disorder, that genotype driving the phenotype, doesn't hold. We switched gears, and during the work with tropical calcific pancreatitis, I came across another entity, which is fibrocalculous pancreatic diabetes, and it was really not very sure that what type of diabetes is that. And that actually led me to the understanding of type 2 diabetes. And what we realized that the type 2 diabetes phenotype is very different in Indians. Again, without going into much details, we developed the disease at least a decade earlier. We developed the disease at a lower amount of obesity, and we all are at least 20 to 30% more insulin resistant than the Europeans' counterpart. Now as I said, that the proof of the pudding is in eating. So genetics was the boon at that time, and hence we investigated on a well-developed cohort. And what we found that there were 8 genetic variants at that time which were identified in Europeans. When we did the study on one of the largest cohort at that time, close to 5,600 individuals, we found that the effect size of these 8 genes was very different. And secondly, the most important one was the FTO gene, which was identified as a major predictor of type 2 diabetes. Through its risk for obesity, we found that actually that is a type 2 diabetes as well as an obesity gene for us, whereas in the Europeans it was only the obesity gene, and that's how it was predicting risk of diabetes. This brought me in touch with another clinician, which I'll tell you in a little bit of time. But then by extending our work and collaborating with a large number of clinicians across the country, what we found that people who have higher number of genetic risk variants, they are at a higher risk of developing diabetes. As you would notice on the right hand side, that those who have more genetic factors, they are more at risk of developing diabetes. And further, we found that most of the intermediate traits that are predictive of type 2 diabetes, they actually overlap, as you would see in the right side upper plan. What we further found, we inculcated the genetic risk score from these 33 genetic variants at that time. We found that the area under the curve taking only genetic risk score was only 0.63, whereas by using the conventional risk factors, it was coming to close to 0.94. And when we combine the two, only 2% was added by the genetic risk score, suggesting that these genetics is also working through the various conventional risk factors like obesity or any other aspect. Today, the situation is that there are close to 400 genetic variants which are known to predict risk for diabetes, but overall, this only predicts 24% of heritability, which means that if I am carrying all the 400 risk variant and you are carrying only a couple of them or maybe zero, in that case, I'm only 24% higher in developing the risk of diabetes. So the question was that, can these genetic variants associate with complex diseases be used for predictive medicine? Because the genetic risk is fixed at birth, there are multiple genes, there are small effect sizes, there is genetic heterogeneity, there is an evidence of gene environment effect. Switch gears. Switch gears. This hypothesis, developmental origins of health and disease, which indicates that it's the maternal nutrition which predicts the fetal nutrition and growth, the birth size and future development. And it's well established that the birth size as a surrogate of fetal development is associated with future risk of cardiometabolic problems. This was proposed by David Barker, and I'm thankful to my collaborators in various cohort. One of them, Dr. Harshi Sachdev, has just walked in. We worked on many of these cohorts, and I met another crazy clinician, Dr. Yagnik, and I must say that it has been a wonderful scope working together with him. What his work had already shown that Indians are thin but fat in comparison to the Europeans, and further, the maternal vitamin B12 and folate, which are the predictors of homocysteine levels, had an influence on the future development of cardiometabolic problems, specifically at six years of age. These individuals who were born with low birth weight, born to mothers with high homocysteine, had an influence on insulin resistance and body fat. And last but not the least, that the thin fat phenotype persists even in the adulthood. And this was also established that these factors are important in future risk of developing cardiometabolic disorders. When we looked at the pathway of homocysteine metabolism or one carbon metabolism, this has got two parts, the folate and the methionine cycle. You would notice that B12 sits at the median place where the folate from diet enters into the cycle of regulatory pathways, which is synthesis of methionine. And you all might be aware that SAM is the universal methyl group for all kind of regulatory reactions. What it led us to something as a very serendipitous observation. Since we found that there are close to 40 to 60% people in India who are B12 deficient, but only 4 to 5% who are folate deficient, we looked at a disease which is so strongly associated with high homocysteine and folate levels. What we did in one of the largest study in India of about 350 women with neural tube defect children and 700 without, we found that in contrast to the Europeans, where the low maternal folate and the risk genotype at MTHFR predicts the risk for neural tube defect in the mothers, in India, it was all occurring despite normal folate status, and more interestingly, it was more associated with low vitamin B12 level, which were further substantiated by the association of risk genotype at TCN2 gene, which actually is the indicator of intra-tissue B12 level. So we questioned that what's the role of folate supplementation in preventing NTDs in India when most of the Indians are folate deficient, folate sufficient, but they are B12 deficient. And secondly, starting anything post-fertilization doesn't really serve the purpose. The other facts about vitamin B12 is, this is a study which Dr. Yagnik had done, that the Indians have lower B12 levels at every age in both the genders. And further, rather than folate supplementation, it's the B12 supplementation which reduces the homocysteine level. So to put this all part till now, what I've spoken to, that Indian women, this is a typical Indian woman, folate sufficient, B12 deficient, gets pregnant, and then gets a folate supplementation in B12 deficient background, which, as I told you, that this really aggravates the folate B12 imbalance, and the kids are born obese and insulin resistance, and that's probably a future risk of cardiometabolic problem. They think that an imbalance in B12 folate status in the mother initiates adiposity and insulin resistance in the offspring. Further, an intervention study done by Dr. Caroline Fall and Dr. Yagnik was also instrumental in demonstrating that a pre and periconceptional B12 supplementation does influence the birth weight, and this was also specifically interacting with maternal BMI. What we found that the mothers in the higher BMI state had kids who were born with this intervention had at least 133 grams higher body weight. So coming back to this particular cycle, as I said that methionine is the methylation regulator, and epigenetics, one of the mechanism of epigenetics is DNA methylation. Hence we tried to investigate what are the epigenetic regulation that influence because of this maternal nutritional imbalance. And that was a simple question to ask, that how to understand the effect of genes and environment on an individual. And from my medical knowledge, it's a straightforward that by looking at your father. And what does that mean? Well, on a lighter vein, that if your son resembles your father, if your son resembles you, it's genetics. If the son resembles your neighbor, it's environment. Very lightly put, but we took this very seriously, and we took two particular pathways. We compared the DNA methylation signatures in the offspring who were born to mothers with high and low B12, and we thought that because the outcome is insulin resistance, the kids, if you find any differentially methylated region, that will be associated with insulin resistance. Then we had an intervention cohort who had differentially methylated region. We tried to identify with folate and B12 intervention, and an overlap of this will provide us epigenetic modifications, which will be offspring's body composition influenced by B12. To cut a long story short, what we found that this methylation at several CPGs in PPR delta gene, which is associated with carbohydrate, fat, and other metabolism, was altered, and that's what was associated with insulin resistance. In the other one, where we found that folate and B12 intervention was done, we specifically found in the group which had the B12 intervention, they had the most number of methylation changes. And interestingly, the differentially methylated CPGs were enriched in the type 2 diabetes genes, particularly FTO and TCF7L2, which are known to be the strongest predictor of these phenotypes. So overall, to just put the whole thing in perspective, that this is the link between 1-carbon metabolism and type 2 diabetes. If 1-carbon metabolism is disturbed because of the B12 and folate imbalance, it is likely that the regulatory machinery in terms of DNA methylation, this gets dysregulated, leading to differential regulation of genes like FTO, TCF7L2, and have a tissue-specific phenotype. This is what was published a couple of years back. So friends, I have tried to convey to you that the dogma that is well established is that there is a genetic susceptibility and there are precipitating factors like obesity, diet, etc., which are the risk factors for type 2 diabetes. But then we propose another element, which is developmental origin of health and disease, and this is related to early life exposure. Well, friends, this is a little provocative slide which suggests that, well, if this is a Chinese dictum that if you want to prevent the disease, then you have to do it at a primordial stage, if I remember the terminology correct. And probably if we have an understanding of the factors which right at the intrauterine stage or early life can influence a future outcome, that probably can be one of the ways to move forward. So in summary, for non-communicable diseases, we need to look at genetic factors, we do need to understand the environment, and then the epigenetic factors. And this is what is the crux of fetal developmental programming. So the take-home message, as I understand, is that genetics is not the boon or the bane for risk of complex non-communicable diseases. Environment, oblique nutrition plays a major role in phenotype presentation, including regulating the genetic susceptibility. Early development is a critical window where future risk of complex disease like cardiometabolic or cognitive disorder is established, and this window provides an opportunity for targeted intervention which may be helpful in reducing the NCD burden and has public health value. Thanks to my collaborators, they are spread all across the country, and I'm also privileged to have collaboration with abroad, University of Southampton, University of Exeter. They have been extremely helpful. And finally, I dedicate this award to Dr. Lalji Singh, who was my mentor, friend, and guide, who had the faith in a medical doctor, and I'm really grateful to him. Unfortunately, we lost him a couple of years back at a reasonably young age, but his words still inspire me. Thank you very much for your patient hearing, and I thank my colleagues over last
Thank you
years.
for a very, very illustrative and a great lecture, Professor Giriraj Chandak. Thank you very, very much. Please accept our token of appreciation on behalf of the National Academy.
Good afternoon to all. We'll break for the lunch, and after the lunch, remaining orations and award session would be held. My most sincere apologies for overshooting the time, but oration is something in our lifetime work, so we have to give respect and our regards to the speakers. So there was an issue. Thank you very much. Please join for the lunch in the next building.
After lunch.
Good afternoon. We continue with the morning session. The one speaker, orator left, and she is Dr. Indra Sharma. She is going to speak on marriage and rehabilitation of persons with severe mental illness, and she'll be delivering Sridhar Sharma academic oration. So I invite Dr. Indra Sharma, please.
Namaskar. Mr. Chairman, sir, and Mr. Co-Chairman, I am extremely honored today to be given the privilege to present Dr. Sridhar Sharma oration. Dr. Sridhar Sharma, how would it go? Dr. Sridhar Sharma, I have always looked upon him as my teacher, my mentor, who has always guided me during these years of my psychiatry in this country. Professor Sridhar Sharma has worked in the institutions of this country, and he has done phenomenal work in the area of rehabilitation of persons, particularly those with long mental illness. Everyone will remember his contribution at IBHAS when he was a director, and more than 3/4 of the patients were discharged from the hospital and were united with their families and rehabilitated in a big way. I will be failing of my duty if I don't express my respects for the blessings that have been showered on me by my revered teachers, Professors B.B. Sethi, A.K. Agarwal, Dr. N. Lal, Dr. S.C. Gupta, Dr. Mata Prasad, Dr. Rastogi, Dr. A.K. Tandon, Dr. Prabhat Sitole, and Ashok Trivedi. My father, I don't have his photo, my father, Pandit Harish Chand Sharma, practicing law of the Allahabad High Court, I can never remember for the good values that he instilled in me, and I am today what I am is because of him. And then my husband, the great man who is behind all my success. Today, friends, I will be speaking on a very important topic, and that is marriage and rehabilitation of severe mental illness. A sizable proportion of persons with severe mental illness have disability. Disability associated with mental illness is a major contributor to global burden of disease. And psychosocial rehabilitation of persons with severe mental illness is needed to improve their functioning, integrate them into the society, and improve their quality of life. Current rehabilitation programs of persons with severe mental illness have their limitations. The author, that is myself, has almost 5 decades of clinical experience in psychiatry, of working in the general hospital setting, and also some experience in private sectors. All these years, no patients were ever referred to rehabilitation centers. Even then, most patients had been married, integrated well into the society, and are having a fairly good quality of life. So this paper will discuss rehabilitation of severe mental illness via the institution of marriage. The discussion will be focused on the situation in India. Now, what is severe mental illness? It is a mental, behavioral, or emotional disorder resulting in serious functional impairment which substantially interferes with or limits one or more major activities. The most common disorders are major depression, schizophrenia, bipolar disorder, obsessive compulsive disorder, and there are others also. You may note that 1 in 7 Indians is affected by mental disorder. Then, mental disorders are among the leading causes of non-fatal disease burden in the country. And severe mental illnesses with disability have the maximum contribution. Looking at the disability adjusted life years, it is most disturbing to note that the dialysis has doubled since 1990. And amongst them, you find that depressive disorders have contributed the maximum. Schizophrenia only 9.8% and bipolar 6.9%. Now, looking at this scenario, most people think that mental illness is a bad prognosis. But let me tell you, the ICMR 5-year follow-up study involving 3 centers on factors associated with the course and outcome of schizophrenia very clearly demonstrated that at 2 years, most active symptoms subsided, and at 5 years, almost 67% had good outcome. Then there are 2 major international studies conducted by the World Health Organization, the International Pilot Study of Schizophrenia, and the determinants of outcome of severe mental disorders. What has been most heartening to note that outcome of schizophrenia is better in Indian centers, and at 1 year all remitted, half with residual symptoms and half without residual symptoms. Now, talking about disability in persons with mental illness, the International Classification of Impairment, Disability and Handicap has defined disability as any restriction or lack of ability to perform an activity in the manner or within the range considered normal for a human being. And it has enlisted 9 categories ranging from behavior, communication, person care, and other disabilities. Then how do you assess disability? It can be assessed by the ICD-IDH schedule. It can also be assessed by IDEAS. This is the instrument which is most appropriate for the Indian setting, and it has been developed by the Indian Psychiatric Society, the Indian Disability Evaluation and Assessment Scale, and it classifies disability into 4 major domains: self-care, interpersonal activities, communication, understanding, and work. And to get the benefits of disability, one must have a disability more than 40%. Now, in order to assess disability, there have been a number of instruments. I will not go into the detail. They are for specific populations, both the outpatients and also the long-term residential settings. The whole list is there. You can go through it. There are also instruments to assess specific domains. For example, you have the schizophrenia cognitive rating scale, then you have the micro-module learning test, and then the responsiveness to training, modeling, and role play, which is used for imparting social skills training. So, having said this, I would just like to call your attention to the state of rehabilitation in India. Rehabilitation in India is primarily, is being carried out in the hospitals. It was carried out the NGOs, and then there are community-based rehabilitation programs. One which is being carried by NAMS with the help of ASHAs, and then there's the Richmond Fellowship, which has day centers, halfway homes, residential facilities. And then the Schizophrenia Research Foundation is doing seminal work in the area of rehabilitation of patients. And the Medico-Pastoral Association, this is also NGO which is doing excellent work, and it has provision for house parents, and this is very good to my mind. And then the most recent now in Kerala, what we see is the services focusing on the homeless, wandering, mentally ill. These persons who are just homeless, wandering, they are taken, they are given all sorts of care, and then they are treated, and then they are reunited with their families. And then the line, we also have a number of programs for rehabilitation of patients by consumers themselves who have been afflicted with mental illness, the Asha Deep in Assam and Asha in Tamil Nadu. Now, what I wish to draw your attention is that the author who has written down these different rehabilitation services in the country, it has expressed major concern. What does it say? It says, a vast majority of patients in India still do not have access to any form of psychosocial interventions, let alone a well-integrated psychiatric rehabilitation service. Goes further to say, organized, structured programs with adequate human resources and budgeting are scarce both in the government psychiatric hospitals and NGO sectors. It also says that whereas rehabilitation activities have been strengthened at some centers, but sadly, they have declined in a few centers. For example, CIP Ranchi, which was once considered to be the mecca of psychosocial rehabilitation, we find that the activities there are to a very minimal level. However, I wish to mention here that the authors have not appreciated certain basic facts. Number one, the role of marriage and family in health, which includes mental health care of persons with mental illness. Two, formal rehabilitation centers in CIP declined and have been replaced by better care at homes by the families. And three, many problems such as of food, clothing, housing, education, employment, etc., are not psychiatric problems per se. Rather, they are social problems that are faced by the vast majority of persons without mental illness. Fourth, it is the responsibility of the family and the state to ensure that no citizen be deprived of these basic amenities. And last, every citizen of this country has a right to work and have a living wage as per Article 43 Constitution of India. Now, having said this, I would like to highlight the limitations of the current rehabilitation in India. Number one, in many of these centers, we find the focus on occupational therapy is relating to the hospital and center's needs with no income generation. And where income generation is there, the payments that are given are very low. Number two, most of the rehabilitation centers are very expensive. For example, a 3 to 4 month program at a city-based rehab center could cost anywhere between 60,000 to 3 lakh rupees. And then you see the long stay centers which are coming on, such as the Kadabams in Bangalore, who take only a one-time payment, but are in great demand. This is very sad, and they are now they are the new mental asylums. The last limitation is that by being attached to these rehab centers, the stigma is maintained, and this seriously compromises the dignity of the person with mental illness in the real world. Fourth, none of these rehab centers provide for the sexual needs of patients because marriage is not in the agenda. And you will agree with me that an unmarried status is a taboo in our society. And women have more problems when they are unmarried, and because they are at great risk for sexual harassment by people, both in the rehab centers and outside when they go out. Then if they don't get married, then these persons with mental illness, if they go into live-in relationships, again it's a taboo. I wish to mention here that sex is a basic human need of a person. It is the first tier, in the first tier of physiological needs, of hierarchy of needs, the sexual need has been mentioned by Maslow. Now, marriage, mental illness and rehabilitation. I wish to make a point here that marriage is a socially supported union between individuals. It has been described as a stable, enduring relationship, the basis for the family and institution. It has 6 social functions, including regulation of social behavior, reproduction, nurturing, protection of children, socialization, production, consumption, passing of ascribed statuses such as race. According to the Hindus and Christians, it is sacro stand and indissoluble permanent union. In the Shastric Hindu law, marriage has been regarded as one of the essential sanskars. It is said every Hindu must marry. To be mothers were women created and to be fathers men. The Veda ordains that must be practiced by man together with his wife and offspring. He is only perfect who consists of wife and offspring. Now, having said this, people would wonder how marriage and mental illness would go together. Of course, the relationship between them is complex. If the marriage is stressful, it can precipitate or exacerbate mental illness in a vulnerable person. On the other hand, a stable marriage provides for all the needs of a person with mental illness, including sexual needs. It provides emotional and support, a dignified life with children and family. It also provides for adoption, and it rehabilitates the person in a natural setting with minimum costs and least stigma. Now, let us look at some of the work that has been published. It is, you will be happy to note that married patients are at less risk for suicide. Then there is a 10-year follow-up study which shows the varietal rate in persons with mental illness was 70%, and they had a good outcome, and there were no gender differences. Then in studies from Chennai Institute of Mental Health have mentioned that only 10% with a major mental disorder were divorced or separated and widowed. And of course, the divorce rate was more with schizophrenia compared to bipolar, 13:1, which means that mental illness really is not always the cause of divorce or separation. Then again, in a family court of Chennai, during a period of 1 year, only 45 out of 5,000 cases were filed for dissolution or nullity on the ground of mental illness. Now, has published very interesting data on 783 patients on divorce in persons with mental illness. What is most alarming is that the more women with mental illness got married, more women were deserted and abandoned, separated and divorced by their spouses, and more of them, those who were abandoned, did not receive any financial support, mental support from their spouse, parents, and the parents had to bear the responsibility of looking after them. And most women complained of treatment by in-laws. And on the other side, we find that more men continue to be married with their spouses taking on the wage earning role.
Madam,
so this study clearly exemplifies the role of ugly face of patriarchy. Why women should be divorced more and not men. Now, a question often is raised, should a person with mental illness get married? So I just mentioned about the social perspective is that the social dictum is that everyone must marry. Everyone must marry. Sexual needs are to be met only via marriage. And however, in a setting of mental illness, often there is a double standard. When a person has a daughter with mental illness, parents want to marry her off. But the person who has a son without a mental illness is not willing to take a person with a mental illness. So the bahus are not accepted with mental illness, whereas damas are more accepted in our society.
Madam, 30 seconds left.
Yeah, I'm just finishing. Now, the legal perspective is that Article 16 of the United Nations Human Rights, it clearly says that men and women of full age without any limitation due to race, nationality or religion have the right to marry and to found a family. However, in our country, all marriage laws have put some restrictions on the marriage of persons with mental illness. These are not absolute, but they are there, and on the ground of this, nullity and divorce can be granted. Now, I just want to mention here that the marriage laws of our country are outdated and the cause of continuous stigma for mental illness and problems in persons with mental illness who are married by not disclosing the history of mental illness to the other party at the time of marriage. So this is always a controversial issue, to tell or not to tell the great secret of mental illness. And we have a lot of litigations for matrimonial release because of concealment of the history of mental illness at the time of marriage. And these marriages do take place because in our country, most marriages are still arranged.
Ma'am,
Now,
I'm sorry to
just
interrupt.
2-3 slides.
Madam, हम बहुत late
The
चल रहे हैं
courts
already.
employ the doctrine of caveat emptor to decide whether fraud has been committed. That means court says it is marriage is like marketing. So if you didn't want a spouse with mental illness, you should have asked before. If you have not asked after the marriage, you cannot claim that fraud has been committed. So this and in the case of Dastane, for this reason, court did not pass a decree of nullity. Now, the happy news is that the courts are now quite enlightened with the recent advances in the treatment of psychiatric illness, and they are landmark judgments. One by Lakshmi versus Ajay Kumar, the court observed that mental illness is curable, and once treated, it may not recur. And then in another judgment, this was Kolam Chandrasekhar and Kolam Padmalatha, the Supreme Court, the judgment was, man can't dump wife on ground of schizophrenia. It is a treatable, manageable disease on par with hypertension and diabetes. I will go a stage further that mental illness is better than diabetes. It is easier to treat mental illness than to treat diabetes. I won't go into the details. Then there's a paradoxical provision in the law that the burden of mental illness, insanity is in the respondent. I think this provision was to protect the marriage, but it is self-defeating, because if the illness is denied, it will not be treated, and if it is accepted, it will be treated, and there will be better outcome. Then the role of the psychiatrist. The role of the psychiatrist is multifold: to engage the spouse and family to be co-partners in the care of the patient. Number 2, to ensure patient receives uninterrupted psychiatric treatment, including rehab of optimal quality. 3, to help patient, spouse and family to cope with the various marital problems that emerge during the course of treatment.
Excuse me,
Due
madam.
attention has to be paid to social
madam.
norms and legal provisions.
Madam,
just
please,
2 minutes.
I
last
mean,
2. Rehabilitation needs of the
the
patient are
inauguration.
assessed in consultation with the patient and family and executed. Now, I want you to refer to the clinical practice guidelines, which tells you how to manage these issues relating to marriage. And then there are 4 models of rehabilitation: the first marriage, the second marriage. First marriage is maintained, and the person may be living with the husband at the sasural, or you find sometimes occasionally you find that they may be living at the Mecca. So the first marriage is maintained. Sometimes both of them may have an illness, so they adjust, one with a physical, one with a mental. Then the second marriage and first marriage breaks, and second marriage takes place, and usually this is also quite common in our country. Just a minute. And then the divorce status, sometimes second marriage cannot take place, but these persons live with their family, with their children. The children help them and satisfy the reproduction needs. And last, it's not always possible to get them married. In such cases, the unmarried status continues and the person is taken care of by the family. In conclusion, all persons with severe mental illness have a right to marry, and most do get married. Rehabilitation via marriage is recommended. Marriage provides for all the needs, including sexual needs, and it will also decrease the burden on the state for providing formal rehabilitation services. Thank you so much.
Now we have presentation for various papers for various awards, and we have six speakers. We already have given time limits to them, so please stick to the time. There will be a timer running, and if you go beyond the time, we have discussed that we'll be penalizing them. And so thank you so much for this, and we begin with the first speaker.
Yeah. The first presenter is Dr. Abhinav Singh. This is a competitive session, so every awardee gains if the person is able to finish within the time limit. Thank you.
Good afternoon, everyone. So the time limit is 12 minutes. Sit in there. 15 minutes. Okay. Including question answers. Good afternoon, everyone. I am Dr. Abhinav, Additional Professor in Department of Dentistry, AIMS Bhopal, and the Nodal Officer for the Regional Training Center for Oral Health Promotion and Dental Public Health in Madhya Pradesh. The article titled Loneliness and Disability as Predictors of Oral Diseases among two groups of older adults in Central India has been published in Journal of American Dental Association. Loneliness has been conceptualized as an individual's subjective experience about lack of satisfying relationships. Loneliness is widespread, present in the society, and it can affect all age groups, but specifically the aged. The research has linked loneliness to higher mortality and has also termed it as the hidden killer of the older adults. Poor social connection has been attributed to 50% higher chances of early death. The effect of loneliness and isolation on mortality exceeds the well-known impacts of other risk factors such as obesity and cigarette smoking. The aging phenomena has transpired as a significant health issue of the 21st century. With the rise in life expectancy due to the substantial reduction in mortality, 2/3 of the world's elderly live in developing countries. India has attained the tag of aging nation, with the elderly population being approximately 138 millions, that is over 8%. Presently it is 12%, over 12%. WHO recognizes disability as a global public health issue and as a human rights issue. The rates of disability is increasing due to aging populations. Over 1 billion people are estimated to live with disability, which is approximately about 20% of the world's population. Researchers have evaluated the effect of loneliness on general health. However, the effect on oral health has been not studied. Besides loneliness, older adults are also vulnerable to chronic diseases and the associated disabilities. Keeping this in mind, this study was conducted to explore and compare the association between loneliness and disability with oral health among two groups in central India. These two elderly groups were all the participants from the 3 old age homes in Bhopal and the elderly patients attending the departmental OPD services at AIIMS Bhopal. A total of 421 subjects participated in the study, of which 105 were from the 3 old age homes and 360 participants were those who were attending the departmental OPD. The sample size was on the basis of a pilot study using power of the study at 90% and precision at 5%. The enrollment ratio was fixed at 3:1. All the elderly subjects from the 3 old age homes participated in the study. The demographic characteristics of the participants were collected by means of personal interviews. The dental team comprised of 2 examiners and a recording clerk. Patients reported outcome measurement information systems. Social isolation scale was used to assess loneliness. A memorandum of understanding was signed between Department of Dentistry, AIIMS Bhopal, and Promise Health Organization, USA. Total of 8 questions were used to assess the social isolation and loneliness. Scores of 1 to 5 were assigned for each question on a Likert scale. 1 was never, 2 was rarely, 3 was sometimes, 4 usually, and 5 always. The WHO Disability Assessment Scale, Hindi version, was used to assess the disability. This is applicable across various cultures. The questionnaire covers the 6 domains of functioning, which includes at cognition levels, at mobility, assessment of interaction with people, assessment of self-care, ability to perform daily life activities, and ability to participate in community activities. The social isolation scale and WHO disability scale were recorded prior to clinical examination. Community periodontal index scale was used to assess the periodontal disease, that is the gum problems. WHO's criteria were used for dentition status assessment. A 2-day training session was organized for standardization and calibration of the examiners within the Department of Dentistry. The kappa statistics value which was obtained were for inter-examiner agreement 0.86 and for intra-examiner agreement between 0.90 and 0.92. The ethical clearance was taken from the institutional ethical clearance. Chi-square test and Mann-Whitney test were used to assess categorical variables. Regression analysis was conducted to identify association of loneliness and disability with caries, periodontal disease, and edentulous, adjusting for the confounding variables. The odds ratio was calculated with 95% confidence interval. The significance was assumed at p-value less than 0.05. All statistical analysis was conducted in SPSS version 21 for Windows. Moving on to the results of the study. Table 1 presents the distribution of participants according to demographic characteristics. There were no significant differences between the participants from old age homes and those elderly living with their families for literacy and income levels. However, significant differences were noted between the age groups for the participants residing at old age homes and those residing with the families. The older participants were at the old age homes. Table 2 depicts the age-wide distribution of periodontal disease with dental caries. Significant differences again were noted for the clinical oral health variables between old age homes and the elderly participants residing with the families. However, we could see that the poor oral health status was present in both the age groups. Table 3. It represents the disability scores among the two elderly groups based on WHO disability scale. The 6 domains of functioning which were included were ability of moving around and getting around, the ability to perform self-care hygiene, that is dressing, eating and staying alone, getting along and interacting with people, ability to perform life activities like domestic responsibilities and work, and participation in community activities. Again, significant differences were noted between these domains of functioning between the elderly participants residing at old age homes and those residing with the families. Poorer scores were noted among those participants who were residing at old age homes. Table 4 represents the social isolation scores among the two elderly groups in the study. Significant differences were noted for questions number 3, 4, 6, 7, and 8. The question number 3 was, I feel isolated from others. The question number 4, I feel people are around me, but they are not with me. Question number 6, I feel that people avoid talking to me. Question number 7, I feel detached from other people. And question number 8, I feel like stranger to those who are around me. So these questions were significantly different. They have been answered. The higher social isolation scores were reported among participants from old age homes. Table 5 reflects the regression analysis for loneliness, disability, type of residence, and its association with oral health. Loneliness was associated with dental caries, periodontal disease, edentuliousness with odds ratio of 1.86, 1.29, and 2.37. Disability was associated with dental caries, periodontal disease, and edentuliousness with odds ratio of 4.63, 3.85, and 3.63 respectively. Similarly, type of residence was associated with dental caries, periodontal disease, and edentuliousness with an odds ratio of 2.27, 2.19, and 3.63 respectively. On to the discussion. Significant association has been noted between loneliness and disability with oral health in our study. Higher loneliness and disability scores were reported from old age homes. High levels of tobacco consumption, low dental care utilization, and an extremely high prosthetic need of 90% were the other major findings from the study. A high prevalence of periodontal disease, that is of 97%, and of dental caries of 50% was also noted in our study. Shankar et al. Reported isolation and loneliness to be adversely associated with functional status among elderly in UK. Roxell et al. Established an association between health-related quality of life with loneliness. Social relationships, they are integral to human well-being and have protective effects on disease outcomes. Loneliness and social isolation, however, have been overlooked. These are major issues which the oral health care delivery system and the delivery services need to plan for. Loneliness is a serious public health concern. The healthcare practitioners, they are not trained to consider loneliness as a coexisting issue. Diminishing economic resources, increased disabilities, death within families worsens social isolation. 1 in 3 adults in the United States report loneliness. The seriousness of the concern could be understood by the government in UK having appointed a National Ministry for Loneliness. Moving on to the conclusion of the study, that loneliness and disability was significantly associated with oral health in our study. The two elderly groups reflected poor oral health, low use of oral health care services, and extremely high dental care needs. Practicing dentists need to understand the significance of loneliness on oral health. Interventions to reduce isolation and disability may be beneficial in improving the oral health among the elderly. Thank you.
Okay, thank you. So we can have limited questions. Any question to the speaker from the audience?
Anyone wanting any questions from the audience? No. So can I ask you a question related to the statistical? You said there was 90% power and 5% type 1 alpha error, but you didn't actually tell us for what this was computed. Yeah.
So they were computed for the various variables which you are assessing, outcome variables like dental caries, periodontal disease, and then accordingly we calculated the sample size.
No, I don't think you can do it for several variables like that. You have to, which was your primary outcome variable?
So our primary outcome was dental caries, periodontal disease, because we were assessing, associating with.
Okay. So how did you adjust for clustering of the site in the statistical analysis? Part of it, one was from 3 different old age homes and the other was from OPD, which may not have been a randomized sample.
Sir, I'll tell. So within the old age homes, there are 3 old age homes in Bhopal. So we had considered all of them.
My question is, how did you adjust for that or factor for that?
Means we did a 3:1 ratio for a sample size recruitment from the OPD services. So that we had 105 participants from.
Okay, I don't think you got the question. And the odds ratio that you showed us, were these adjusted odds ratios or simple odd ratios? Because you can have several variables, age, sex, place, income.
So they were adjusted odds ratios.
For what? What was the multivariate model?
For the confounding variables, like
what confounding put into
like
the
if we were assessing for dental caries, then other variables like periodontal disease and other variables were adjusted for.
Okay, thank you.
Okay, thank you. Thank you so much. You can clap for. Wait a minute, I think we'll give you a certificate.
Dr. Arpit Gupta.
Yes.
Okay.
So, should we start? So, a very good afternoon to one and all respected chairpersons, senior members, and dear colleagues. I'm here to present this study titled Modeling the Impact of Increase in Sugar Prices on Dental Caries in India. The study has been published with the prestigious journal Community Dentistry and Oral Epidemiology in 2022. As we all know, dental caries is a kind of a major public health problem these days as far as oral care is concerned. And dietary sugars, they play a major role in the caries causation. And if you talk about sugar, it is not just caries, it is about the long list of NCDs to which sugar is one of the main culprits. And as far as caries is concerned, the newer evidence says that amount of sugar intake have shown a greater association with dental caries as compared to the frequency. And the World Health Organization has strongly recommended that the free sugar intake should be less than 5%. So the target is somewhere to meet these recommendations of WHO. We know this is a major concern. Many public health preventive strategies, population-based strategies are in place. Oral health education is going around, but the downstream strategies somehow are not competent enough. They have not been found to be so reliable because of so many reasons. Therefore, there is a shift which we see in some of the European countries and some of the Western world, whereby the focus is on the upstream approach. And when we talk about the upstream approach, it is about the policies, the legislation, the fiscal measures, something what we are doing in tobacco control as well. So imposing taxes is increasingly considered a potential strategy to incentivize consumers for improving their dietary patterns. What we say, healthy practices be easy practices and unhealthy practices be difficult practices. So that is only possible when unhealthy practices are available at a cost which is higher than the healthy ones. So with this concept, we kind of come out with this study whereby globally various studies have reported that economic and health outcome impact of SSBs, the sugar sweetened beverages taxation, is high on dental caries, diabetes, and obesity. However, we can't find any study in the literature which is actually talking about the effect of change in prices of SSBs and sugars on the oral health as far as the Indian population is concerned. And that is why we planned this study with an objective to assess the caries incidence prevented and the caries associated tooth loss averted or avoided during an individual's lifetime on increasing the price of sugars or SSBs in India. And also to assess the treatment cost saving. If the disease is less, the treatment costs will be saved. So to assess the treatment cost saving to this burden. A mathematical model was developed, and this mathematical model consisted of a cohort. This is a hypothetical cohort of 1,000 individuals, whereby individuals enter this model at the age of 12 years, and only permanent dentition were considered. And this is an age, 12 years is an age when all the permanent teeth are largely erupted, and that is why we have chosen this date. The cohort was followed for a lifetime. We have taken an average lifetime of 75 years, very close to the average lifespan in India. And a combination of decision tree and Markov model was parameterized on MS Excel. And we kind of worked on 4 models. One was sugar consumption at the current price. Whatever the current price is, if things goes on at the same pace, obviously inflation factored in. One was that model. Another model was a hypothetical model. Supposedly, we increase the price of sugar by X percentage, let's say 20%. So what is going to happen as far as oral health is concerned? Third one was SSPs, the sugar sweetened beverages. So the current price of SSBs and what happens if we increase the price of SSBs in India. So this is a Markov model which we have kind of developed. This Markov model includes some probabilities of transition from one stage to another. And the transition cycle was kept at 6 months because we generally recommend a 6-monthly dental checkup. So the transition cycle was 6 months and the probabilities were used in this Markov model. So the input parameters were probability of the decayed, missing and filled teeth, whereby we had used a national survey, one and only national survey which is available in the country, although it dates back to 2002 and 2003. So the data from that survey was used. Then we have used some estimates on sugar and SSB consumption in our country. So we have very well referred to some literature which talks about how much sugar and SSBs are consumed per capita in our country. We have talked about elasticity calculations. So elasticity simply means if we change the price of sugar by X amount or X percentage, what is going to be the change in the consumption? Price goes up, consumption goes down. So that is called as elasticity. So we have used elasticity parameters from some of the studies by food characteristic demand system, whereby for sugar it was minus 0.34, and for SSBs, it was minus 0.94. We have used the sugar dental caries dose response relationship. That is, how much sugar will leads to what amount of dental caries. So that dose response relationship we have used, whereby it says that there is caries experience tend to increase by 0.1 unit for every 10 gram of sugar consumed. So these parameters we have used, and also we have used the treatment cost. So for treatment cost, we have used the CGHS parameters, which is kind of generic parameters which are being applied to the whole of country. So the current CGHS parameters were used for the treatment costs. With this, there was transition across the Markov model whereby the population cohort was followed. I have already talked about increase in sugar prices and raising the price of SSBs. And there were two baseline scenarios where we have talked about sugar consumption at the present rate and sugar consumption in the event of 20% increase in prices. So both these scenarios were modeled for a time horizon of 63 years, that is from 2021 to 2083. And this was done to model an individual's lifetime on half-yearly cycles. Further, we have gone ahead with sensitivity analysis, whereby a univariate analysis was done to assess the effect of uncertainty in parameter values on overall health outcomes. And the effect of joint parameter sensitivity was analyzed by applying a probabilistic sensitivity analysis. Some standard distributions like gamma distributions for cost parameters and beta distributions for the caries incidence and progression parameters were done. Uniform distribution was used for simple random values. We have done Monte Carlo simulation whereby the model was run 999 times, and we have kind of computed the medians and the 2.5th and the 97.5th percentile for the confidence interval. Coming on to the results, as this table shows, increase in the price of sugars. So if we increase the price of sugar by, let's say, 20%, the overall taxation would be 41%. Right now, sugar is in somewhere 18% tax slab. So that makes the overall taxation to 41%, and it leads to 1.32 tooth saving of an individual in a lifetime, just by increasing the price of sugar. And if I talk about number of dental caries prevented by rise in SSBs, then it is 0.19. The number is low because in India, SSB consumption is relatively low as compared to the Western world. Looking at this graph, which says that a 20% increase in sugar may prevent the loss of at least one tooth due to caries during lifetime within a group of 33 individuals. So this trajectory shows how the increase in sugar prices will prevent the tooth loss per person. These are the monetary benefits, and it clearly states that 20% increase in the sugar price will lead to almost 3,000 billion cost saving in the lifetime. So these are some staggering facts which we have seen. Coming on to the discussion part, it is reported that a sugar increase of 25 grams per day will lead to at least one tooth per child becoming carious. In India, sugar consumption is on a rise. We all know that. There is a data which says that it has increased from 22 grams per day to 55.3 grams per day from 2000 to 2010. And SSB sales are again increasing almost 13% annually. So we need some factors to bring down these sales. And if the current consumption pattern continues, it is likely to impact consumers' health significantly. Concerning oral health, the ready availability of cariogenic food and drinks overpowers the benefit of other preventive strategies like fluoride. Thus, it is imperative to adopt measures that directly target the affordability of unhealthy products in the market and thereby reducing their consumption. Such kind of efforts have been made in some Western countries whereby they have kind of taxed SSBs and sugar to a higher level. We have so many examples from California, from Middle East, where these modalities have been effective. although our estimates are like little lower as compared to the estimates of the Western world. And the primary reason is that there is a difference, there is a variation in consumption, there is a variation in price elasticity, there is a variation in probabilities of caries incidence and progression. So India specific, we are not able to find as good a result as Western world, but still they are quite promising. Currently, sugar and SSBs falls in the 18% tax slab, and we have already discussed that raising it to almost like 40% or 41% will lead to a consumption of sugar which is within the recommended levels of WHO. That is 5% or less than 5% of daily energy intake, and also save at least one tooth from getting caries in lifetime of an individual. So there are certain limitations. We were unable to account for what we call as cross price elasticities. You know, if one product becomes costlier, it always affects another product. So the cross price elasticities could not be assessed. The opportunity costs could not be assessed. It could be possible that these SSPs will not eliminate, as some people might continue to buy them. Still, even if the price is high, some individuals might continue to buy them, and they might forego other things. And further, you know, the cost of some dental treatments may rise because it might reduce their workload somewhere. And these are some of the challenges, but we have not counted them in, so that these are some of our limitations. So just to recommend, future research in this area is required and should focus on measuring the additional cost as well as health benefit of these changes in the market behavior that may happen. Additional focus should be there on evaluating the various stratas. You know, the effect might be different on the upper, middle, or the lower socioeconomic strata people. And besides the increase in the price of sugar or SSBs, other oral health promotive, preventive, and curative strategies could also be factored in. So just to conclude, raising the prices of sugars and or SSBs may substantially reduce the caries incidence and caries associated tooth loss in India. Thank you. Thank you so much.
So the session is open for the questions from the House. Yeah, please. Could you please give a mic?
Very innovative, research. In terms of the translational value, do you think this can lead to the policy changes by the government? Do you feel that, is it significant enough to say that? And what is the flip side of not eating that sugar? It would be some people, by escalating the price of the sugar, there would be a strata of population who would not be able to afford, minimum amount of calories. So for that, did you calculate that what malnutrition or thing parameters?
So I think this is a very valid point. I believe that this research alone won't be able to translate the, or let's say compel the policymakers to make a translation in the policy. But yes, these are building blocks, I would say, and this is first of its kind in our country. One of the limitations which I have highlighted is the effect on people with different socioeconomic strata, lower, middle, upper. So we need to strategize things in a different way. And one thing to understand is for the lower socioeconomic strata, the government is already running the public distribution system whereby even sugars are being provided at a very nominal prices to them. So if they increase the overall cost for others and let this be provided to the lower socioeconomic strata, I think things might be better, I believe.
Did your simulation model adjust for inflation in prices?
Yes, sir, we have adjusted for inflation.
And what you took, what values to adjust?
Sir, as a rule of thumb, 3% inflation is generally used in most of the economic evaluations, and we have used that.
Thank you. Thank you so much.
Thank you, sir.
So I have a question, like
Please, sir.
when prices go up, soon after, within a couple of years, they settle down to the same taste, same behavior. Tobacco has not gone, in fact. Look at the cost. Okay, so it's a very costly affair to manipulate the cost and then see the effect, because it's more education. So I still not very concerned with something like sugar can be manipulated, because if you do it after some time, the behavior such as, so I
but
still have.
tobacco is somehow, somewhere a success story. May not be a complete success, let's say, but still it is a success story in making. And there are certain countries, and let us not talk about sugar directly, even SSB is a component. We know, let's say our kids are in schools and SSBs are available so cheaply. So unhealthy practices are cheaper and easily available. And fruits, healthy practices, they are actually not available. They are like too costly. So we need to address these concerns of making healthy practices the easier practices. Yeah. Thank you.
Okay, thank you. So the next speaker is Dr. Shailendra Singh Rana, who will speak on influence of the tongue volume, oral cavity volume, and their ratio of upper airways, a cone beam computed tomography study. Dr. Rana, please go ahead.
Thanks. Good afternoon, everyone. I'm Dr. Shailendra Rana, working as an assistant professor in Department of Dentistry in Bathinda. The title of my paper which is selected for award, is Influence of Tongue Volume, Oral Cavity Volume, and their ratio on upper airway, a cone beam computed tomography study. So basically, I am orthodontics, and we correct the malocclusion using orthodontic treatment alone, in which we place the braces by using the orthodontic surgery. By this surgery, we correct the jaw discrepancy, but after the completion of growth, with the collaboration of oral surgeon and plastic surgeon, and by the dentofacial orthopedic access, in which we correct the jaw discrepancy in growing phase. So by dentofacial orthopedic appliances, we correct the maxillar mandible position if it is placed forwardly, backwardly, or expanded and constricted. So like in this case, maxilla is positioned backwardly, so we correct by using the Hyrax and face mask appliance and bring the maxilla forward. Basically, what we are doing, we increase the oral cavity size by increasing or by bringing the maxilla forward. Not only we improve the maxillary size, but also here you can see we improve the airway. If we increase the oral cavity size, we improve the airway from 0 mm, 1 mm to 5 to 6 mm. So by these appliances, we improve the oral cavity size. So oral cavity, if we talk about oral cavity, it is comprised of the vestibule and oral cavity proper. And oral cavity proper is connected with the oropharynx through the oropharyngeal isthmus. And maxilla and mandible are the bony landmark of this oral cavity. And for the upper airway, comprised of nasal cavity, is nasopharynx, and behind the tongue and the soft palate is oropharynx, and below this is hypopharynx. And tongue, anterior 2/3 part of the tongue is housed in the oral cavity, and posterior 1/3 part is housed in the oropharynx. So we can say that oral cavity volume and tongue volume could have relationship with the upper airway. Hence, in this study, aim to investigate the relationship between the tongue volume, oral cavity volume, and their ratio with the upper airway using CBCT. So this preliminary study was performed on 15 CBCT images, in which 8 images from the male subject and 7 images from the female subject. And mean age of muscle was 21.86 years with a range of 15 to 33 years. For CBCT scan, we ask the patient to sit in upright position, because if in supine position, if patient sit in supine position, tongue will fall backward and it restrict the airway. So we ask the patient to sit in upright position, FX place should be parallel to floor, and ask the patient to keep teeth in maximum intercursion. And we also ask the patient to not to swallow, breathe, or place the tip of the tongue to the lingual surface of upper incisor to standardize the tongue position. For imaging protocol, we took the CBCT of patient head with the iCAT scanner with the power of 120 kilovolt, 5 milliampere, and field of view of 17 into 22 centimeter, and 0.4 mm voxel size, and 8 second is scanning time. Then after a CBC scan, image is exported to DICOM file, and then DICOM file is imported to a DICOM viewers imaging software. Many software are available like Anatomage, Dolphin, and Mimics, but in this study we use Dolphin imaging software. And then we construct the sagittal, coronal, and axial slices, and then again the file is imported into the Mimics software for volumetric measurement. So DICOM, for the DICOM file is imported into the DICOM imaging software because it is necessary to orient the image before measuring the airway, because orientation also affects the airway. So we orient the image according to FH plane and transorbital plane. Like in this image, we place the mid-sagittal plane on the midline, axial plane by the line passing from the right and left orbit, and coronal plane a line passing through the bifurcation of the first molar. And these are my oriented image. After orientation of each image is imported into the Mimics software, and we measure the tongue volume, oral cavity volume, and upper airway, and for the segmentation of the these airways. So these are my boundary limit of upper airway and oral cavity, like nasopharynx, oropharynx, hypopharynx, part of the pharyngeal airway, and oral cavity. This is anterior and posterior, superior, inferior, and lateral limit of my these oral cavities and airway. Then we define boundaries are placed on for the nasopharynx, oropharynx, and the hypopharynx, and we measure these airway. This is my image of the calculated volume of hypopharynx, tongue, oropharynx, oral cavity airway, nasopharynx, and maxillary sinus, and nasoethmoid. We took as a nasoethmoid because it is very difficult to differentiate between nasal and ethmoid air sinus. So we took it as a single unit, as a nasal ethmoid. So intraoral reliability we measured by the intra-class correlation coefficient, and based on the 95 confidence interval, intra-class coefficient was excellent for left maxillary sinus, right maxillary sinus, nasoethmoidal, nasopharynx, oropharynx, and oral cavity airway volume. And my ICC was good for hypopharynx, oral cavity volume, and the tongue volume. These are my mean value and standard deviation of different parameter, in which tongue volume and oral cavity volume ratio is 85.29 with the standard deviation of 18.88. Means it is almost similar to the other studies which are already available. So we also measured Spearman's correlation coefficient to know the correlation between different variables. And for tongue volume and oral cavity volume, our results show significant negative correlation. So come to discussion, the volume were measured using segmentation of CBCT using Mimics software, that is DICOM viewer software, and patient specific threshold range based on density was taken. Based on density means for soft tissue we took the different threshold. For airway we took different threshold, and for the hard tissue we took the different threshold. For airway we took -1024 to -500 threshold. For the soft tissue -500 to 500 threshold, and for the hard tissue we took the +500 to 1024 threshold. So we took the different threshold for the different tissue. And tongue and oral cavity volume ratio is taken in this study, and it represents the oral configuration irrespective of physical and skeletal framework of the subject. Means if somebody has greater physique, his tongue volume and oral cavity size should be larger. But we took tongue volume and oral cavity volume as a ratio because it will not affect by the skeletal framework or the physique of the subject. So tongue volume ratio has in our study, tongue volume and oral cavity volume ratio has a significant relationship with the oropharynx, oral cavity air, and significant positive relationship with the tongue. So it means for a constant oral cavity size, increased tongue size decrease the oropharyngeal airway, or for a constant tongue size, decrease oral cavity volume, decrease the oropharyngeal airway. Means for a constant oral cavity size, if tongue size is increased, oral cavity is not capable to accommodate the whole tongue, and tongue will fall backward into the airway, and it will reduce the airway. As a result of enlarged tongue move posteriorly and decrease the oropharyngeal airway. This is supported by various pathological conditions like tongue enlargement disorder, like hemangioma of tongue, amyloidosis of tongue, and Melkerson-Rosenthal syndrome that is associated with the obstructive sleep apnea. And other condition is for a constant tongue size. If oral cavity size are decreased, again tongue will move backward. This condition, why we are discussing actually in orthodontics, we sometimes we extract the premolar and retract the anterior teeth. If we retract the anterior teeth, tongue will again fall backward. Oral cavity is not capable to accommodate the whole tongue, and tongue will fall backward and it reduce the airway. So that's why we again, that's why we're discussing that if we reduce the oral cavity size, tongue will fall backward and it reduce the airway. And other condition is mandibular and maxillary setback surgery, in which we cut the maxilla or mandible and setback. It also reduce the oral cavity size, and in this condition also we reduce the airway. So these are some studies that had limitation of boundaries are not defined, segmentation method is not mentioned, some study only measure tongue volume, oral cavity volume. So these are some limitations. But in our study, unlike previous, is not limited to oropharynx. We measured the whole upper airway, like we measured the nasoethmoidal area, nasopharynx, oropharynx, and hypopharynx, nasoethmoidal, maxillary sinus, whole upper airway and maxillary sinuses we measured by this study. And in this study, we used keen methodology on tongue and oral cavity segmentation. In this study, we used manual slice by slice editing. Other method of segmentation is semi-automatic or automatic segmentation. But manual slice by slice editing is more accurate compared to the other method of segmentation by semi-automatic or automatic. And we use slice editing tool for editing over segmentation and under segmentation marking of slices also we did by using this. This software, Mimic software, has this type of ability. We also use Boolean tool for removing overlapping volume between two anatomical regions. If we measured oropharynx and sometimes it goes, some part goes to the oropharynx, we can remove by using this Boolean tool by using the Mimic software. So my study has limitation of a small sample size, age range of my subject is also wide, and we also did not measure tongue volume, oral cavity volume according to a skeletal relationship, and growth pattern of patient. That is also factor, like vertical grower has less airway compared to the horizontal grower and an average grower. So we also not measured according to the growth pattern. But my sample size is very limited, so I did not divide into the skeletal age of the subjects. So finally, I would like to conclude that this finding indicate an influence of tongue volume, oral cavity volume, and their ratio on upper airway. And tongue volume, oral cavity volume could be used for the obstructive sleep apnea diagnosis. Actually, for orthodontist, we correct the mild to moderate cases of obstructive sleep apnea. So we generally the CBCT of these patients, so we can diagnose obstructive sleep apnea using this tool, or we using the tongue volume or oral cavity volume. There is no need to do a polysomnography in mild to moderate cases of obstructive sleep apnea. So this study we can use tongue volume or oral cavity volume as a diagnostic tool. And our sample was adult non-obstructive sleep apnea subjects, and further study can be done in obstructive sleep apnea subject to know the ratio of tongue volume and oral cavity volume and its effect on the upper airway. Thanks.
So this is open for the questions from the house. Okay.
The next presentation is by Dr. Kameshwar Prasad sir, cohort profile, the Lokarpon, a population-based prospective cohort study in middle-aged and older adults in India. For Dr. Abhay Indrayan Academic Award, he is the recipient of that. Professor Kameshwar Prasad sir, please.
First of all, I must thank the committee who thought of awarding me this prestigious award. As many of you know, Dr. Indrayan is a very well-known biostatistician, and his models are used by the government of India even now. What I'm going to present in his memory is perhaps appropriate prospective cohort study, which is mainly to focused on causes of stroke and cognitive decline, but you can't take out myocardial infarction from this. This is a collaborative project between AIMS New Delhi, Erasmus Medical Center Rotterdam, and National Brain Research Center Manesar, funded by Department of Biotechnology and Department of Health Research. So the word Lokarpan stands for longitudinal cognitive and aging research in population of NCR. NCR word we use because we have a rural population, Ballabgarh, and urban, which we do from AIMS, and, which is Vasant Kunj and Munirka. So that's why the nickname is Lokarpan, and it's appropriate name because this study is dedicated to the public. How we conceived this idea was that from my MBBS days, I have been hearing about presentations which starts with Framingham Heart Study. And I always wondered why people don't quote some Indian study. They start with Framingham and then they go on to their other parts of the talk. So in 2011, when I was vice chairman of Neuroscience Task Force, we invited proposals for cohort study. But initially there were no takers. Then we invited people to a meeting and asked, why don't you want to do cohort study? And I still remember, director of a very established institution says, who has the time, so much time to invest? And you know, you need coordination between so many departments, not possible for us. So I'm thinking it has to be done by AIMS. No institution, no other institution is taking it up. So a delegation came from Rotterdam, and to cut the long story short, we had a meeting and we decided that we'll do a study like this. And AIMS, when nobody takes the lead, has got to take the lead. And the reason for focus on stroke is that stroke incidence is increasing in developing country, whereas it is decreasing in developed countries. Same thing is happening about ischemic heart disease. So needless to say that we need to think about what are the reasons. And these can't be genetic reasons. I'll come to that later. So some environmental, biological reasons have got to be found out. And it is a pity that when people report 97 cohort studies in a paper in Lancet, there is not a single one which is quoted from India. So this is a paper which is available, but this was focused on atherosclerotic cardiovascular disease. Not a single one which was published in India when this paper was published. So we started with this overall goal of establishing a large cohort. So this is not a single study. It is a mother of multiple studies. And we focused on elderly population for the simple reason that you have to be efficient. You can't go on doing 20-year study, particularly in India. But our scientific objective was to study the known determinants as well as some novel determinants, which novel, when I say novel, I mean some Indian determinants like yoga, vegetarianism, multilingualism, and so on, and how they correlate or are associated with stroke or dementia. We were asked by DBT to have urban as well as a rural component, each with 7,500. I'm not going into sample size calculation. We did think it was appropriate, and it started in January 2016. Specifically from epidemiological terms, if you want to find out, we don't yet have adequate idea of what is the etiological fraction or attributable risk of even conventional risk factors or protective factors. What are the thresholds which should be applicable to our population for risk prediction? Are there any protective or risk factors which are specific for India? And we still don't have a riskometer for local population, and this has become essential because when you develop guidelines when to use statin, now in developed countries they say that if your 10-year risk is 7.5% or above, then you start using moderate intensity statin therapy. And needless to mention that there is not a single study like Framingham or Rotterdam which integrates genomic and neuroimaging data and have genotype-phenotype correlation, and with the idea of developing a polygenic risk score which will predict and help us in preventing stroke and dementia. So that is why we started, and I'm not going to spend much time on how we planned it. It was a very difficult exercise, and I wish I should not have taken this, but having taken this, I had to spend all my time on this. We, of course, start with community mobilization, then personal contacts with the individual houses, then we have to take consent, then some data collection at the household, and then bring them to medical center in AIMS for further data collection, and then a second visit for MRI brain. So we had identified from this election rolls about 16,732 households, of which 9,817 were actually eligible because many were permanently locked. So if you go to Basant Kunj, you will find often houses belonging to NRIs which are permanently locked, and that number is not small, 1,742. So finally, 7,383 people, households were contacted, including 12,250 individuals, of which 8,858 were willing to participate, and 7,505, they came to AIMS finally, completing all the data collection, except MRI, which is available for 2,604. So we had field assessment, fasting blood collection at home, then medical site visit with further blood collection and anthropometry, physical examination, history, diet, physical activity measurement, then blood pressure, etc., Doppler, echocardiography, neuropsychological tests, then the assessment, and of course, DNA extraction from the blood we took, and the second visit for MRI brain. So to minimize non-response in a study like this, you have to be very careful in selecting an area, and distance is very important. Organization of travel of the participants was made by the project, otherwise they won't come. And then we had to enlist cooperation and instill some degree of altruism in the people to participate. And as you know that we have still lack of research supportive mindset, so it took some time to mobilize support as much as we wanted. And started always with, these resident welfare associations, and then ultimately, finally, participants' consent. You can see going there and mobilizing people, not spending much time on this, but basically it takes time to get them to consent and maintain the motivation. And that is why we had to have dedicated vehicles bringing them and dropping them off. We had to give pre-consultation and manage appointments in AIMS in various departments. And then, of course, we had to plan data collection in detail, which I will come to a little further. You know that when we talk of data collection, we have to keep in mind that in India, it is not easy to get income data. So we looked at what, just as NFHS does, look at the items purchased by the household, and then from that we calculated their wealth index. Minimizing respondent burden is very important in epidemiological studies, so we had to have some criteria so that all data need not be collected, but certain specific risk factors which we wanted to study based on either previous literature or because there is some relevance in our country. For each measurement, we had a procedure laid out. So there was, for example, if hip circumference has to be measured, then how to do it, every detail was given to the workers. And then medical side, we had all these measurements. We were quite a bit on the target, and we met the target as we wanted. But I tell you, this requires 24-hour work, otherwise it doesn't happen. But in MRI, we were falling short because MRI's time was not available, but still we have now collected 2,604 MRI. This is the first population-based MRI from this country. There is no other study which has population-based MRI findings. So what to present is a difficult exercise. We have already 5 published publications, 5 are in preparation. But I'll give you some idea about this. One question will be, those who participated and those who did not, how different they were. So the first column is about those who did not participate, and the second column is about, second means third and fourth column. First and second is about those who did not participate, third and fourth about those who participated. So as you can see, those who were currently married, they were more likely to participate. Those who were busy in homework, they were not willing to come and participate. And I'm not going into each one of these, but there were some differences. Fortunately, all kinds of people were represented, but not in representative in the sense that there were basic differences between those who did and who did not participate. What are the major findings? Major findings are that 50% people have 3 or more risk factors. 70% people have hypertension. Of 30% are not even aware that they have hypertension. In urban population, 38% are diabetic, 30% are not aware, but those who are aware, 48% are on treatment, but only 12.5% are controlled according to HbA1c criteria. 40% people in urban have thyroid disorder, of which 60% are unaware, and 9%, to be accurate, 8.9% have mild cognitive impairment in urban area, and they are not aware about it. And the amnestic MCI is 5.7%. We did MRI, so a little bit of MRI I would like to tell you that correlation between risk factors, a lot of macro structure and microstructural measurement of in MRI was our goal, which we are doing. We have published, we have one paper got accepted, and it is first time that we have lobe-specific volume of Indian population of those who are 50 years and above. I won't spend too much time on what we found, but we have a biobank where we are now doing genotyping, whole genome genotyping of the data, and some new genes have also been discovered, like some hypertensive genes specific for Indians. We spent a lot of time on quality assurance, internal as well as external, and because there was international monitoring, there was international advisory committee, and PhD students, 4 of them have been awarded PhD. We had appreciation from a person who started the Rotterdam study, and now he is in Harvard School of Public Health. These are the people. I thank them for participating, and I acknowledge the Government of India, AIMS Delhi, Erasmus, and all the participants. Thank you very much.
Yeah, so this is open for any question from the House. Yeah, please.
Dr. Prasad, congratulations for this study. Really lacking in India. I just wanted to know that whenever we get into these kind of cohort studies, what is the overarching question? Because you will have anything or everything that one can do,
But what would be the one of the foremost things that you would like to do from this? Like you have MRI, you have all anthropometry, biochemistry, everything. Where do you think that the first thing that you would like to do?
Well, first thing I would like to have, as I told you, Desi riskometer, which means we can't use Framingham risk and apply to Indian population. That is developed in Caucasian population, right? So first thing is to have our own risk calculator so that we can have our guidelines accordingly. That is one thing. Second thing is, now we know that there is gene environment interaction. It is not only environment. So now every population is having a polygenic risk score and combining this with other conventional risk factors and then developing prediction models. We have to do it our own, otherwise we will either not have it, or if we have it, we have to develop it here and then apply it in prevention.
Right. I mean, that part seems fine, but when you talk about this genetic score calculation, largely, lots of studies have already been conducted all over. Do you expect to find a new gene on this? And I mean, your proportion of patients, like 30%, or that would come out to 2,000, 2,500. Are you hopeful of finding a new gene or anything which will aid in the Desi riskometer?
Yeah, if I understand your question correctly, will we find, we hope to find Indian
gene? Make an impact.
Indian
will make an impact in the risk calculation.
One paper we have, this is not related to this paper, but we have published a paper already of case control comparison of stroke patients and controls. I think 4,000 population, 1,500 cases, 2,500 controls. And we have published, which is already published in Neurology USA, one gene of simulation pathway, which is dominantly in, it is not that it is absent everywhere else, but it is dominantly in India. So could be India specific. And I was telling you, only last week we analyzed data on hypertension. And one gene which is associated with berry aneurysm is coming out highly significant at the level of what we call genomic significance, which may be a hypertension gene. Now the question is, how sure are we? No, we can't be sure. We have to have validation study, which, what we have found in the case control, we are trying to, we will hopefully validate in the cohort study. As soon as it happens, someday there will be something which will probably be India specific. Yes, sure. Thank you.
Any other question from the house? Yeah, Dr. Shweta. Dr. Shilpa.
Not a question, just compliments, sir. As a feedback, my sister lives in Vasant Kunj and her mother-in-law was one of the subject of your study. And the whole community knew about it and a lot of public education was also spreading through it. And as a result, everybody became conscious. The elderly were teaching their co-peers. So it was a really a big path-breaking thing, I can say, where people are talking about their health and medical issues. Thank you, sir.
Thank you. I must tell you, one old lady, very old lady who came on wheelchair. And I remember what she said. Every day I remember. You know, first thing she told the residents, she was president of Resident Welfare Association. We in India are not research minded. We have to be research minded. I think this is such an important statement. I see repeatedly when get reminded that she is absolutely right. At this time, we still are not as much research minded. Our Rotterdam people, they said, oh God, your people are so demanding. They are asking for each report. They are asking for a report. In Rotterdam, we don't give any report. We simply ask them to contribute and say if there is anything of concern, we will report to your, what is called family doctor. We don't give any report, but they are very demanding here. And they can't imagine a vehicle going and picking up in Rotterdam and in Framingham. It is just an announcement, people come on their own. So we have to go a long way, but this is a beginning.
Thank you, Professor Prasad. I'm not sure I got it correctly. In the table you showed that in India there are no cohorts?
No?
Or did I mistake it? you showed a table in which you showed India was in red and there are no cohorts or something like that. You
No,
said?
no, that is that is in the paper. The paper which is published actually in Lancet, which is from China and so on. So many, but there is not a single study quoted from India in that. But I am aware of at least 8 studies which are there from India. So we had a workshop where we called all people who have done cohort studies in India, including from people from Chennai, people who are in Mumbai, people like cardiology people, they have some studies. But I'm talking of 50 years and above cohort. I know of some children's cohort study, which are marvelous, but 50 years and above cohort, still there are at least 3-4, which I'm aware of. And Lassi is a big cohort study which is going on.
That's fine, that's fine.
It was not reported by them
That's
in the
fine.
lens.
Yeah.
That's
Thank
fine.
you.
Thank you.
Thank you.
Okay, thank you, sir.
The next presentation is by Dr. Kalpana Luthra. She is the recipient of Dr. Tulsi Das Chugh Award, and she will be presenting broadly neutralizing plasma antibodies effective against autologous circulating viruses in infants with multivariant HIV-1 infection. Professor Kalpana Luthra, please.
Good evening, everybody. At the outset, I wish to thank NAMS and the selection committee and the chairs for nominating me for this award and giving me an opportunity to present. And it is my proud privilege to present my work. And this work would not have been possible without my PhD students, Nitesh, Shefali, and the MD student Ayushman Dhubal, who have worked round the clock for 3 years to get the data that is presented in this work. And without the collaboration from Department of Pediatrics, Dr. Rakesh Lodha and Dr. S.K. Kabra and Professor Bimal Das from Microbiology Department. So this is in addition to the other research team of my lab. So till date, there is no effective vaccine against HIV, and antiretroviral therapy is effective in reducing the viremia, however, not successful in preventing latency. And moreover, antiretroviral therapy also, it needs to be used prolonged over a period of time, and this leads to drug resistance in the individuals, and also the affordability issues remain. So since 2008, when the Nobel Prize was awarded for the discovery of HIV and the fact that it infects our immune cells, till date, we don't have an effective vaccine. Only a vaccine could help in reducing the viremia substantially at very early stages of infection, so that in case the person continues to be infected, a high dose of antiretroviral therapy can lead to much decrease the viremia and prevent development of latency, which becomes more complicated. So this virus is comprising, it's an RNA virus comprising of an envelope which is a heterodimer of 3 monomers of glycoprotein. And every HIV infected individual develops antibodies against the virus. However, only a subset, 15 to 25% of these individuals develop neutralizing antibodies, meaning those antibodies which can bind to the virus and block it from infecting other cells. Now, of these individuals who develop neutralizing antibodies, there is only a subset of 1% who are broad or elite neutralizers. Elite neutralizers meaning they are able to neutralize diverse viruses, like in the West, you see that in most of the West, which is shaded in gray, individuals are infected by clade D viruses, whereas in India and South Africa, it's predominantly clade C viruses. So more than 50% of the global infections belong to clades, are due to clade C viruses. So in order to identify epitopes which can go into an immunogen design, it is very important to characterize the viruses circulating in such individuals so that those individuals who are able to elicit good antibody responses, the viruses in them maybe, if developed into immunogens, can elicit similar responses in the vaccination. So that formed the basis of our study. And a brief, introduction to the immunology that happens in HIV-infected individuals. Like in healthy individuals, you see that the immature B cells, once they are in the bone marrow, they develop into naive mature B cells, which an encounter with an antigen or a pathogen lead to development of plasma cells which secrete antibodies and combat the infection and clear the infection, after which you have resting memory B cells which can reside for long number of years. However, in an HIV-infected individual, you have immature B cells and which develop into naive mature B cells, but once they encounter the HIV, so which is very persistent and continuously in their circulation, so these naive mature B cells continue to rapidly proliferate to compensate for the loss and develop an exhausted tissue memory B-like cells, which are not effective in producing neutralizing antibodies. So this is a challenge in HIV-1 infection due to the high the mutation that happens in the virus. So there are certain differences in the HIV infection in infants versus that in adults. It is seen that if one is not given antiretroviral therapy, more than 50% of the children mortality within 2 years of birth in the absence of antiretroviral therapy. Now, according to recent NACO guidelines, every individual who is tested positive for HIV is initiated on ART. However, as I told you, there are complications of ART and adherence is also a problem. So, because of this difference in children and adults, like in children, it is seen that very less children, less than 5% become long-term non-progressors. So long-term non-progressors mean that they don't develop symptoms despite being infected and there is a controlled infection in them. Whereas adults, you can see the development of long-term non-progressors in 5 to 15 of the infected individuals and less than 1% become elite neutralizers. So because of these differences and the fact that infants who are usually infected during birth by mother-to-child transmission with the well-defined genetic bottleneck leading to infection with a minor variant, meaning that the difference between adults and children are that when at birth, children acquire maternal antibodies, which are already developed against a major circulating viruses in the mother. So it's only the minor variant which is able to infect the infant. And once you have this infection, so this provides a unique setting to understand what are the viral factors associated with the induction of broadly neutralizing antibodies, which is abbreviated as BNAbs here. So we recruited 50 HIV-infected infants in the age range of 9 months to 2 years, and we excluded children below the age of 9 months due to the presence of maternal antibodies in them. And then we went on to characterize the presence of neutralizing antibodies in these children, because those children who have good neutralizing antibodies are the potential candidates in whom we can characterize the viruses in natural circulation and then identify epitopes which are able to generate these kind of good antibodies in these children. So this was done by a luciferase-based reporter assay. I'm not going into details. As you can see here in the first vertical column is the ID of the infant HIV-infected children who are recruited from the pediatrics and their CD4 and viral load were done in the Department of Microbiology. And we did the neutralization assay and we found that you can see here on the top of the table, there were top 4 HIV-infected infants
who you can see color-coded in red or dark orange, majority of them were able to neutralize the viruses which are indicated on top. We tested them against a panel of 12 viruses which represented the global diversity. So the circulating viruses in the entire global population of HIV-infected individuals. So representative global viruses were tested for the presence of neutralizing antibodies in these individuals. And the top 4 were elite neutralizers. And in addition to that, you can see a line here. So these 6 children, infants, were developing broadly neutralizing antibodies. So these were the percentage breadth, that is how many viruses across different clades they were able to neutralize, and the potency in terms of geometric mean titers. So we would obviously realize that in infants, you would not expect a high potency, that is the titers of antibodies, they are recently infected. So therefore, the geometric mean titer cannot be calculated in them in terms of ID50 titers, and therefore we for the first time developed a modified score depending on the breadth potency matrix with our data on elite and broad infant neutralizers to provide neutralization scores on a continuous matrix of ranging from 0 to 1, and those who cross the 0.7 threshold are elite neutralizers, and those which cross the neutralization score of more than 0.3 were broad neutralizers, and less than 0.3 were non-neutralizers. So we further validated this score by again testing for the neutralizing activity, which was previously done in our laboratory, the good neutralizers from the adolescent age group and the adults, and we found that they fall very much into this score, and this is valid. So next we will turn to see in these elite neutralizers, what are the epitopes on the virus which is eliciting such good antibodies in these individuals. And if you see here, I'm not going into the detail, it is predominantly the orange dots which are mostly present in all these elite and broad neutralizers. And you see the fold dependence is much more than the twofold increase in the dependence, and this was tested using pseudoviruses which were mutated for that particular epitope. So when you see a fold change in the neutralization, you know that the neutralization depends on that particular region. So predominantly we found that in these elite and broad neutralizers, the V2 apex targeting plasma neutralizing antibodies were predominant. Next, we went on to characterize the viruses circulating in these elite neutralizers. So for this, what we did is we performed single genome amplification of at least 40 virus envelopes. We sequenced the entire viral clone, and then we looked for the envelope gene diversity. And as you can see here, in these top elite neutralizers, there is a high envelope gene diversity, meaning single nucleotide substitutions, which ranged from 2.5% to 15.1%. So this indicates that these elite neutralizers were infected by more than one virus. Now, due to the single time point nature of the study, since they were once tested, immediately put on antiretrovirals, we were not able to follow them in their antiretroviral naive status. So therefore, although they were infected with more than one virus, we could not call them or categorize them as a co-infection or a super-infection. Therefore, we went on to call them as multivariate infection. So within patient diversity, neutralizers ranged from 2.6 to 15.1. Such high extent of within patient diversity is reported in literature typical of multivariant infections. So this is again a representative of the population frequency of single genome amplificons. Within this donut plot shows the infant ID, and within the parenthesis is a number of clones. Like say in some we characterized 45 clones, and in some we characterized 40 clones, which represented more than 90% of the circulating viruses in those populations. So based on this and also the highlighter plots, we found there was a high diversity in the viral infections in these elite neutralizers, and this high diversity in the viruses which is contributed due to more than one virus infection in these elite neutralizers, led to the neutralizing activity to be very potent in these individuals. So from these highlighted plots, with maximum likelihood trees, which you can see there is this lot of branching and variation in the viruses circulating in these individuals, we found that there is productive infection with more than 2 distinct viruses. Thereby, we concluded that multivariant infection is observed in these infants with elite neutralizing activity, and this suggests that a vaccine which would be based on a multivalency can have better ability to elicit neutralizing activity. So, very briefly, we went on to further characterize each and every pseudovirus. We constructed pseudoviruses in these elite neutralizers and tested them for their reactivity with the plasma neutralizing antibodies. And we found that, to our surprise, that all these pseudoviruses, they were not resistant to the plasma antibodies, suggesting thereby that envelope-specific antibodies, which are generated in the context of 2 distinct viral variants, which are infecting the same infant, can target epitopes on both envelopes, suggesting the favoring of a polyvalent vaccine. Then we went on to clone and express this envelope glycoprotein, characterize their antigenicity, because if you want an immunogen, it would be more the native-like trimeric envelope. And yes, it did conform to the native-like state by binding only to the neutralizing antibodies and not to the non-neutralizing antibodies, or very minimally. And these clones are being taken forward for the development of clade C-based immunogens. So these are potential immunogens which are further being characterized in the lab. And to conclude this article, the plasma neutralizing antibodies in infants with multivariant infection target both variants, suggesting that the envelope-specific antibodies generated in the context of 2 distinct viral variants target conserved epitopes on both the envelopes despite the viral diversity. Thank you.
So this is open for the question from the house.
I had an acknowledgement slide, but probably it got missed out.
It's okay. Okay.
Thank you.
Okay.
Next slide, please. Yeah. So this is again another trimer that we have patented, and we are taking forward for preclinical studies. This is from a pair of genetically identical twins. Those days, their NACO guidelines were to put HIV-infected individuals on antiretroviral therapy only when their CD4 counts dropped below 500 cells per microliter. So we were able to do a longitudinal analysis of the coevolution, and this particular the trimer is being taken forward for preclinical studies. And without all these collaborators and their valuable reagents that they provided in the NIH reagent program and this battery of PhD and MD students, this work would not have been possible. Thank you very much.
There is a short break now for testing of the connectivity. I hand over to Dr. Sood, please.
Really short break. We come back. Dr. Rajwa, please. Dr. Sachdev. बस ये 10 मिनट I know. अभी टेस्टिंग तो हो गया इनका। हम तो चेयर में, हम चेयर में 10 मिनट खुल जाए। वो 5 मिनट 10 मिनट मत बंद कर अभी कर। Okay. Yeah. So thank you so much for joining us. So now we have a next speaker, and the speaker is Dr. Ashok Kumar, who has been awarded Nanda Guli Suryanarayan Rao Academic Award. I request Dr. Ashok Kumar to deliver, and because of constraint of time, maybe request you, sir, for whatever time, like we will request 7 minutes plus discussion 10 minutes.
Okay.
So this is a
We are
seemingly constrained.
because the chief guest has to join in 10 minutes total, sir. We will be highly obliged. Thank you.
Okay, thank you, Chairperson. And I would like to express my gratitude to National Academy of Medical Sciences and the selection committee who, selected me for this award. Actually, and that's related to this focused work on advanced materials-based approaches for healing diabetic foot ulcers. So what approach, it's an engineering approach actually, but taken from the clinic actually. So what we have done here actually, we have generated oxygen releasing antioxidant scaffold material for diabetic foot ulcers actually, where we are incorporating the elastomeric properties, we have antibacterial properties, angiogenesis, oxygen releasing, and loss attenuation actually. Then we tested it on the animal model of diabetic foot ulcer actually to see whether it can attenuate the oxidative stress actually, and also can repair the diabetic foot ulcer actually. So what in this approach, oxygen, as you understand actually, is life and is required everywhere actually. Tissue engineering implants, even if they have shown a lot of potential actually, but still they impose a lot of hypoxia condition actually. So that's one of the important areas actually where we would like to have oxygen there. Myocardial infarction actually, where lack of oxygen supply is there, increasing oxidative stress. Particularly what the topic is actually related to the diabetic and chronic wound regeneration, hypoxia, neuropathy, oxidative stress are the key hallmarks actually, and that is where actually we just are looking into this type of possibility actually, how we develop actually these type of materials and try to see actually how the hypoxia condition actually can be elevated in that particular thing actually. If you're looking at the diabetic foot ulcers actually, it has a healing impairment actually that is predisposing abnormalities, which is neuropathy, oxidative stress, trauma, compromised angiogenesis, and particularly the poor oxygen supply and neutral supply, and specifically the infection is creating other problems actually. The current treatment strategies is the debridement of the wound, management of the infection, and increasing the angiogenesis actually, or diabetic management actually. So, or using actually hyperbolic oxygen treatment or tropical oxygen treatment actually. So this is what are practiced actually in the clinics, but in various ways. But how we can combine these together actually and develop a type of scaffold actually, which can be utilized in an approach which can be utilized actually
to have a sort of better effect overall in that actually. So if you look at the global challenges of diabetes, I don't need to tell actually to this audience actually. So it's a staggering numbers there actually, but the increase is also actually percentage wise is also very alarming actually, that in 44 where we will be active. So this number is quite alarming on that actually. But on the other hand, diabetic foot ulcer or diabetic foot ulcer related complications actually are much more problematic than the prostate cancer, breast cancer or Hodgkin's lymphoma combined together. It takes more lives than all these cancer things together actually. The Indian scenario in the diabetic epidemiological condition is, though this is a little bit older data, actually we have 61.3 million people in India who live with the diabetes, 900,000 each year lost their life actually on this. It's also putting a lot of cost on the treatment strategies actually, and Indians usually have average 10 years earlier onset of diabetes actually than our Western counterparts actually. All these are creating a sort of major complication when we talk about the diabetic conditions actually. Diabetic wounds which are in the advanced strategies, as I said, is hyperbolic oxygen therapy, topical oxygen supply, or use of activated wound care products actually. And they use also some growth factors or bioengineered skin. So if these are the advances in the clinic actually, so what we did is actually we brought these advanced clinical strategies actually into the engineering aspects actually and try to put them together and see how we can do it actually as a sort of combined approach. Like for example, when I said actually the hyperbolic oxygen therapy or tropical oxygen therapy is given, so we developed for that matter actually oxygen controlled targeted manner, delivery cargo of exosomes actually, and then we have a cellular dressing actually. So this is just a sort of how we design. I will not go into the design of this material actually, but this is what we mentioned, that combining all these aspects actually we are putting together this type of dressing. Then we put it to the wound effects actually. So this is just a sort of validation in the beginning actually to see actually whether this hypoxic condition can be improved in this actually, which is just a sort of outcome of that. And we see that in 9 days time actually we can completely recover the wound. We just having a sort of hypoxic condition. Then we combined with the exosomes actually. Exosomes are the vesicular bodies actually from the cells. They carry the message of the cell actually. So we took the adipose tissue derived exosomes and combined them actually on these scaffolds and then evaluated them. This is just a sort of details actually how these exosomes were isolated actually and then how they were characterized actually. These are nanovesicles actually in the range of something like 200 nanometers, and they carry all actually the properties actually, the growth factors which are typically used actually for diabetic conditions actually. We clubbed this in the material actually which we used, and this is just to show actually how the wound is closed here. So you have a closure of the wound by using this type of material, this type of approach. I will go directly, and this is just to show actually how these exosomes are internalized within the cells. So to just get an idea actually that they have effect actually and they are functional in that. So I will go into the animal model actually which we do for the diabetes actually. We just put the animals on high-fat diet for 14 days and then treated them with the streptozotocin actually for inducing diabetes, and then created a wound. And this wound was applied actually with different type of dressings. Actually, these dressings are using the exosomes, it is releasing the oxygen, and it is antioxidant actually. And then if you look into this data, which again I'm not going into the detail actually, is just the outcome of this data is that in 14 days time, it's completely curing actually the diabetic foot ulcer actually in this condition actually. We show you all the factors actually which is calculated here actually that within 14 days with these type of conditions actually we can cure the diabetic foot ulcer. And this is the histological analysis also telling us whether this skin which is coming back is matured epidermally actually and what is the property of that. So that's also what is it having actually, and then just some marker expressions to show that it is the right type of skin which is being regenerated actually. So that's with this condition actually. I will go into that when we just made a sort of challenge to give a sort of infection into these. How in the case of infection actually this type of dressing can work actually. So with that also actually we have seen if we incorporated the Pseudomonas aeruginosa or Staphylococcus aureus, we still can manage basically to treat these wounds. Again, we see actually a proper epithelialization actually and collagen deposition actually in all these cases. And this is what we have in hand. We have a biocompatible dressing, which is biodegradable in nature. Within 3 weeks time, actually, we can have a diabetic foot ulcer cured by this. It's a base material polymer synthesized indigenously, contains ascorbic acid as antioxidant, calcium peroxide as oxygen releasing compound, and cell-derived nanovesicles, which are alternate to the stem cells, actually, which are providing basically the properties, actually. Thank you for the attention.
Thank you so much for acceding to our request. नहीं, कोई प्रश्न नहीं।
This brings us to the end of this session where awardees had presented their work. And we conclude this session and hand over to the Secretary NAMS, Professor Umesh Kapil sir. Thank you so much.
I request Lieutenant General Diljit Singh ji to come and felicitate our judges. Please, sir. ये लीजिए, मैंने कर दिया।